All right. So, before beginning with the symposium, let me tell you that this symposium actually is a part of our IMA Fest 2023. IMA Fest is the annual conference of Indian Medical Association Dombivli. This is the 24th year of our annual conference. And every year before the conference, we generally have a pre-conference workshop. And this time, when we were doing some thinking as to what to take up for the pre-conference workshop, this idea came up of taking up a diabetes symposium. And so here we are with a pre-conference diabetes workshop symposium. We have separated it from the conference for the particular objective that diabetes is a very important topic. And since we are keeping it online, we wanted people from outside the Thane district also to join, because in conference, as being a physical conference, generally people who are able to attend the physical conference would have been able to join for the pre-conference workshop otherwise. And that's why we kept this online, and we have separated it from our conference, that this has no bearing with the registration for the conference. And here we are with the conference today. So we move on to the scientific sessions. And before we move on to the scientific sessions, I invite Indian Medical Association Dombivli President Dr. Vijaya Lakshmi Shinde to give her presidential welcome to the attendees for the symposium.
Good afternoon, everyone. A very warm welcome to all the delegates, expert speakers, and my team members of IMA Dombivli branch. First of all, my best wishes to Team D4 Diabetes Symposium. And I appreciate Dr. Pate Madam, Dr. Meena Pruthi Madam, Dr. Medha Oak Madam, Dr. Gayatri Ghanekar Madam, Dr. Rashmi Sonar Madam, Dr. Makaran Ganpule Sir, and whole team of IMA Fest and IMA Dombivli who are behind the crafting and planning of the sessions for today's symposium. As the day progresses, you will realize how well crafted each session is and how all the experts bring together the great grand disease in front of us. Being a diabetes myself at an early age, there are many queries about this deadly disease in my mind. And I am sure you will all have two related to diabetes as a disease, pathogenesis, diagnosis, treatment, newer modalities, monitoring and maintenance, follow-up care, complications and prevention of the complications, and many more. Without wasting much time, I request the symposium team to start the sessions, and best wishes and congratulate to the organizing team of symposium. Thank you so much.
Thank you, madam. And so we move on to our today's sessions. Before we begin with the sessions, there are some important announcements. One is that this particular symposium has been accredited with 2 MMC credit points, but to avail the credit points, one, you will have to attend the symposium. Second, you will have to put your attendance in the chat box. There will be no issuance of hard copies of the certificate. Please do not send me repeated queries regarding this, that when will the certificate of the symposium be issued. As per the MMC guidelines, we are not supposed to be issuing hard copies of the certificates, though they will be issued to the medical students who have joined today's symposium, but not to the other delegates. The MMC credit points will be directly verified and uploaded on the MMC website, and you can go back and check it on the MMC website portal under your own MMC webpage. And this whole process takes about 1 month or so. So after a month, you can check. The credit points won't be uploaded probably as D4 Symposium. They will be uploaded as from IMA Dombivli, Indian Medical Association Dombivli. So after a month, please check on the MMC website whether your credit points are uploaded or no. Second is, as a part of today's symposium, we have at IMA Dombivli, we have formulated under the guidance of Dr. Meena Pruthi, Dr. Shruti Patti, Dr. Naina Chaudhary, and Dr. Anjali Vaidya. They've come out with a beautiful write-up, a diabetologica, which we will be sending complimentary to all the attendees. A soft copy will be sending across by mail. Third, the program, today's program, the D4 Symposium, will be uploaded later on YouTube. It is not live on YouTube today. We'll be uploading it later on YouTube, and the link will also be shared with all the attendees at a later date. And to ask question and answer, at the end of each session, you can ask your question and answer. You can ask it in two forms. You can either write it in the chat box for the moderator to take it up, or you can raise your hand, and if time permits, we will definitely be allowing all the delegates to ask their questions. So without wasting much time, let's move on to our scientific sessions, which you all are so eagerly waiting for. So as we all know, diabetes mellitus is a metabolic systemic disease with a high rate of morbidity and mortality. An editorial article in the Lancet in 2008 described the global challenge of diabetes as the biggest epidemic of the 21st century due to the increased percentage of type 2 diabetes and gestational diabetes mellitus cases, and the number of young patients with type 2 diabetes, that is MODI, and of course the type 1 diabetes. The disease burden of diabetes is expected to increase in the next few years and decades. The Atlas of the International Diabetes Federation estimated that 537 million adults were living with diabetes in 2022, and this number could increase to 643 million by 2030 and 781 million by 2045. 5 million adults with impaired glucose tolerance are at increased risk for type 2 diabetes. More than 1 million children are living with type 1 diabetes. As per ICMR, India Diabetes Study published in 2023, the prevalence of diabetes is 10.1 crores in India. At least 136 million people, or 15.3% of the population, has pre-diabetes, and the ratio in Maharashtra of diabetes to pre-diabetes is 1:1.2. As we know, type 2 diabetes mellitus is a non-communicable, lifestyle-related chronic metabolic disease of global involvement and is associated with acute and chronic complications which lead to reduced quality of life, premature morbidity and mortality. And it is named a silent killer because of the primary disease being silent at an early stage, and it usually gets diagnosed when presenting with a vascular event like stroke or heart attack. Uncontrolled diabetes leads to increased risk of CV complications, cerebrovascular and peripheral artery disease, and microvascular complications. Long-term complications of diabetes are a leading cause of end-stage renal failure, adult onset blindness, non-traumatic amputations. Treatment of diabetic complications is often more extensive, expensive, and disheartening than diabetes itself. The burden of diabetes is often unaffordable to the common man in a developing country like ours. And so it is very, very imperative that we as medical professionals, because we come across diabetes from all walks of life in whichever specialty we may belong to, we need to be aware of all the facets of this disease. And with this background, let's begin our today's journey of D4 Symposium, Detect, Decode, and Defeat Diabetes, and move on to our first session of going back to the basics of diabetes, where Dr. Gayatri Ghanekar will take us briefly through pathogenesis, types of diabetes, and the overall complications associated with diabetes. And I invite upon Dr. Hemant Patil, who's a consultant plastic and cosmetic surgeon, director, Arnav Super Speciality Hospital, and treasurer of IMA Dombivli, to moderate this session. And over to you, Dr. Patil. Please allow me to present. Yeah. Is my screen visible?
Yes, ma'am. Thank you, madam, for a nice introduction. I welcome all of you to the wonderful symposium today. It's a great pleasure and honor for me to introduce our own member, Dr. Gayatri Ganekar, madam. She is a consultant endocrinologist currently practicing in Dombivli and Kalyan. She has done her MBBS from prestigious St. GS Medical College. She has pursued her MD degree from Gandhi Medical College and from Bhopal, and she has completed her DNB endocrinology from PD Hinduja National Hospital, Mumbai. So it's who is the best person other than an endocrinologist to teach us the basics of diabetes mellitus. So we welcome you, Dr. Gayatri Ganekar, madam, and I hand over the session to you to take it forward.
Yes. Am I audible now?
Yes, all the I'm making all the speakers and the moderators as co-hosts, so you'll be able to share screen and mute and unmute yourself at your own perusal. So please, you can do that.
Okay. Is my screen visible? Is the presentation
No,
visible?
madam. No, madam.
Okay. Is it visible now?
No,
Madam.
no.
Not visible yet.
Okay. Uh, share.
Madam, if you want, you can just share it with me on WhatsApp. I'll open it from my end and project it if you want. You're finding it difficult?
Yes, I will share it.
I'll actually, okay.
I have to share and entire screen.
Madam, you just have to open your presentation and just press the share screen, icon which is there on your screen. Just open your
Yes, I have
presentation.
shared.
It's not visible.
Yes, I have shared it.
You have shared it on WhatsApp?
Uh, yes, ma'am.
You have shared it on the group?
I have shared it on the email, madam.
On the mail? Oh. Then I'll have to open it, download it, and then I'll be able to just.
But I am actually trying to
Okay,
share.
just give me a minute. Just give me a minute. You
Is
have
it?
shared it on my mail ID?
Yes. Now is it visible? Yes, ma'am. Is
I
it
think it is
visible now?
visible now.
Yeah.
Visible,
Yeah.
visible.
Yes.
Yes, it is
Thank you.
visible now. Yes.
Thank you. Okay.
Right.
Sorry for the little glitch. Thank you very much to IMA Dombivli for this wonderful opportunity. It's a great honor. Thank you, Dr. Hema Patil, for the kind introduction. And now I would like to take you all through this journey of back to basics. This presentation will help in setting the stage for the next presentations, the next topics, which are clinically relevant and very thoughtfully crafted. So, this is the oldest depiction of diabetes, which was found in an ancient Egyptian papyrus. So, diabetes basically means a siphon or going through, and mellitus is sweet. We know the definition of diabetes by ADA. It's a standard definition characterized by hyperglycemia, which can result from defects in insulin secretion, action, or both. But only hyperglycemia is not enough. We all know that we have moved away from the glucocentric approach, and we are now also encompassing the various complications that are associated. So, such chronic hyperglycemia is associated with long term damage, dysfunction, and failure of different organs, especially the eyes, kidneys, nerves, and heart and blood vessels. So the classic micro and macrovascular complications are also very much a part and parcel of diabetes. So whenever we are diagnosing a patient with diabetes or whenever we are treating, we have to be mindful about the complications. So criteria are also standard and well known. ADA and RSSDI agree upon the same. So just for the sake of completion, I'm enlisting them here. Fasting plasma glucose more than 126, 2 hour postprandial more than 200, and HbA1c more than 6.5. Of course, when we are looking at HbA1c, we need to be careful about the assays that we are using in the lab. In a patient with classic osmotic symptoms, a plasma glucose more than 200 is also good enough for diagnosing. So few more terminologies which are often associated with diabetes are pre-diabetes and borderline. Sometimes they can be confusing. So HbA1c, which is not normal and not yet in the diabetic category. So HbA1c from 5.7 to 6.4 is characterized as pre-diabetes or borderline. Impaired fasting glucose means the fasting blood glucose from 100 to 125. Impaired glucose tolerance is postprandial blood glucose from 140 to 199. Stress hyperglycemia is a transient form where stress tends to dysregulate the balance, and often such patients are able to go back to normoglycemic state once the stress is resolved. There are now atypical forms of diabetes which are commonly seen. For example, you can see type 2 diabetes in a patient who is lean, and you can see type 1 diabetes in a patient who is obese. So these atypical forms are now emerging, and so diabetes in youth and such atypical diabetes is a challenging aspect. So we know something called as flatbush diabetes or KPD or ketosis prone diabetes. It is a condition which is seen in a middle-aged patient who has insulin resistance, who has obesity. Phenotypically, that patient is like a type 2 diabetes patient, but suddenly during a stressful period, this patient will go in frank ketosis, just like a type 1 patient. So ketosis is seen in such patients when they undergo a severe stress. This kind of diabetes is called fatal diabetes. Basically means wide swings and wide fluctuations in diabetes, which were seen or originally described for type 1 diabetes. Young patients who have some psychosocial issues, or geriatric patients who have a lot of end stage complications and dementia, or those patients who have poor access to food, poor access to insulin, often end up in such brittle diabetes, which is a therapeutic challenge. Bronze diabetes is a triad actually of diabetes, liver cirrhosis, and bronze discoloration of skin, which is classically seen in hemosiderosis. And bronze term comes from the pigmentation which is formed in the skin with melanin and the hemosiderin. LADA is nothing but latent autoimmune diabetes, so in adults. So that is type 1 diabetes, which is seen in an adult age group. MODI is monogenic onset, maturity onset diabetes of the young, which is monogenic form. And gestational diabetes, neonatal diabetes, and diabetes in youth will be discussed shortly. So classification is basically type 1 diabetes, which is associated with absolute insulin deficiency. Type 2 diabetes, where predominant pathophysiology is insulin resistance, and other specific types where some specific effects are related to beta cell function, insulin action are identified, which are commonly known as MODI. The diseases of exocrine pancreas, the repeated episodes of pancreatitis or pancreatic surgeries or pancreatic tumors, endocrinopathies which are associated with diabetes like acromegaly and Cushing's disease, various drugs or chemicals which are also endocrine disrupting chemicals, which we'll be discussing shortly, and some infections. There are some uncommon forms of diabetes, and there are other genetic syndromes which are associated with diabetes like Klinefelters or Turners. They have high risk of developing diabetes. And the fourth category in the ADA classification is gestational diabetes, which is any diabetes which is diagnosed for the first time in pregnancy. Earlier it was limited to diabetes which develops during pregnancy as a result of various pathophysiological events that take place during pregnancy, but now we know that many times even type 2 diabetes is first time discovered in pregnancy. So etiologically, if we want to go slightly in details here, genetically type 1, type 2 both are polygenic, whereas MODI is monogenic. Age of onset is young in type 1, whereas type 2 and monogenic, we know that it is slightly older. However, we are increasingly seeing type 2 diabetes in children as young as 12 and 8 years of age. Clinical presentation is acute and dramatic in type 1, whereas more insidious in type 2 and monogenic. Autoimmunity is associated commonly, and ketosis is associated commonly with type 1, whereas these are not really associated in type 2 and MODI. Obesity is more common in type 2, but we are seeing now type 1 in obese patients because of the overall obesity pandemic. Acanthosis, basically a sign of insulin resistance, again is more common in type 2, but can be seen in other forms if insulin resistance was pre-existent. There are stages of type 2 and type 1 diabetes, where these stages basically reflect the pathologic events that are taking at the level of beta cells. So normal glucose tolerance, such patients basically who have genetic risk of diabetes and who are in the obesogenic environment, they will initially have normal glucose tolerance, but they will have signs of insulin resistance. Next stage is when this insulin resistance is so high that it is not allowing the beta cells to function properly, and such patients start showing slight increase in the blood glucose levels, and they reflect the pre-diabetes. Next stage is the development of overt diabetes, and finally the complications. So it is a fact which is very important to note that even in the pre-diabetes stage, 80% of beta cells are already damaged and 80% of insulin secretion is already less. When a patient develops diabetes, around 90 to 95% of beta cells are not really functioning. So it gives us an important therapeutic message that we should actively screen for diabetes, and moreover we should actively screen for signs of insulin resistance. That is the correct way of prevention. Even in type 1 diabetes, there are various stages that have been identified. So therapeutic intervention in type 1 is not so clinically relevant as it is in type 2. It is more of a research setting. So initially there are some patients who have genetic predisposition for developing autoimmunity. Such patients go on to develop the auto antibodies, but they are yet in the pre-symptomatic phase where their blood glucose levels are normal. Finally, gradually they go in the dysglycemia stage, they develop symptoms. Suddenly they go in the symptomatic phase with a rapid onset DKA and the osmotic symptoms. So these are the various stages in type 1 diabetes. So in the first and second stage, often the auto antibodies are clearly identifiable. In stage 2 and 3, not all the autoimmune antibodies can be identified. That's why many patients who come with frankly DKA and we try to check for the auto antibody levels, many times they may be absent. So the various theories about pathogenesis of diabetes. So first, oldest was triumvirate model, where the diabetes hyperglycemia was more associated with impaired insulin secretion from pancreas, increased hepatic glucose production, and decreased glucose uptake. Then the ominous octet came into play, where they've identified some other aspects, for example, the islet alpha cells and their role in increasing glucagon, which leads to increased hepatic glucose output. Then neurotransmitter dysfunction at the level of brain, which is associated with appetite dysregulation. At the level of kidneys, there was increased glucose reabsorption. At the level of fat, there was increased lipolysis and decreased incretin effect in the gut. So all this probably explains the whole diabetes perspective. But even more theories came up subsequently. So we have seen triumvirate and ominous octet. The next is the dirty dozen of diabetes. Four more theories have been put forward, where role of catecholamines has been discovered. So basically, dopamine, which is the predominant catecholamine in the brain. So hyperdopaminic states are more likely to have insulin resistance and likely to develop diabetes. So clinically, if we say, such patients are those who have more stress and those who are really uh, you know uh, eating for the sake of pleasure, or those who have hedonic eating, and they are kind of addicted to sugar. So these patients are more likely to develop diabetes. So there is also role of RAS in diabetes. Earlier it was thought that renin angiotensin system is more important for blood pressure, but we know that now RAS system is also important at the level of beta cells of pancreas. The system, there is a crosstalk between RAS and insulin, and upregulation of RAS is associated with good glycemic control. So the molecules which upregulate RAS, the ACE enzyme inhibitors and the angiotensin receptor blockers, are the agents of choice to be used in patients who have diabetes and hypertension both. Testosterone deficiency and hypogonadism in males is associated with increased insulin resistance and development of diabetes. Vitamin D has pleiotropic effects, and vitamin D deficiency is also very common and clearly associated with type 1 and type 2 both. In type 1, it is affected, basically it affects the immune system in type 1, and vitamin D deficiency makes an individual more prone to develop autoimmune disorders, whereas in type 2, vitamin D deficiency is associated with insulin resistance. So even these four components of pathogenesis were described. Later, the third, which is in unlucky 13, the iron overload, which we have discussed in bronze diabetes, basically accumulation of iron and the free radicals inside the islets of Langerhans and the beta cells of pancreas, that is associated with development of diabetes and insulin resistance. and even the 14th factor has now been developed, and it completes the so far and well known factors, that is the gut derived serotonin. It is the most recently found theory. So serotonin is secreted by gut during the states of fasting, and this serotonin leads to increased lipolysis. Basically it activates the hormone sensitive lipase, so it's a adaptive mechanism for fasting. But if it is upregulated too much, it becomes maladaptive, and it leads to increased hepatic glucose production and development of diabetes. So this completes the faithless 14 or the 14 theories of development of diabetes, which have been pictorially depicted here. So it also gives us different therapeutic options, and so the blue boxes basically tell us that which molecules can be used in which particular situations. Genetic factors are also important in diabetes, but it was found that type 1 and type 2 are largely polygenic. The individual genes do not have any great contribution towards development. Mainly, it is the less contribution in type 2. The single genes have more contribution in MODY rather than type 2. But we know that these genetic effects are also a continuum. So some genes which are more functional in patients with MODY are also moderately functional in patients who have type 2 compared to those who do not have diabetes. So it's all a continuum basically. So these genes are basically related to beta cell function and insulin secretion and NAFLD. If parents have diabetes, there is 39% more chance that one of the offspring will get diabetes. Twin studies show that 90% of unaffected twins will go on to get diabetes, and there is 5 to 10% more risk of developing diabetes if first degree relative has diabetes. So genome wide association studies have been done for identifying specific pathogenic targets or pathogenic genes for diabetes, and they are underway. Epigenetic factors are equally important. These are basically the environmental factors which can be in utero factor where maternal environment predominates, or there can be ex utero factors like the obesogenic environment, and even famines have a great role in development of diabetes in subsequent generations. We will be discussing it shortly. So in pregnancy, what happens is excessive glucose and lipids, which are circulating in the maternal circulation, go across to the fetus through the placenta, and they do some epigenetic alterations in genes involved in energy regulation and metabolism. And if such a fetus is already has some predisposing genes, and if such a child is placed in an obesogenic environment, he or she will definitely develop childhood obesity and insulin resistance. So hyperglycemia, hyperinsulinemia, increased inflammation, and oxidative stress in pregnancy will lead to bad intrauterine environment. 3 to 5% only will develop anatomical malformations, but 30 to 40% of such children will go on to develop some hypothalamic dysfunction, and it will be at risk of developing obesity. So whenever a patient with diabetes diagnosed first time in pregnancy comes to us, it is a that interaction is a great opportunity for us to make herself aware, and of course we need to reduce the anxiety that the child will immediately develop diabetes, but we need to make sure that we pass on the message about putting the child in good environment and healthy eating habits and activity, so that he does not land up in childhood obesity. So socio-cultural environmental factors are very important in type 2 diabetes basically. So our country so far was considered as a low socio-economic status or low income country, and once the income starts increasing, the social equivalents of this, like less physical movement or eating ultra processed or more processed food, having more stress, and the feel good or the party culture, celebration of everything with sweets, all these things get a kind of social status. So a patient with diabetes who knows that all these things can regulate the balance of his blood glucose, but often such patient finds it difficult to control this behavior because it is associated with good social status. So this is now a great challenge in dealing with such patients. And of course urban living is associated with more environmental pollutants and more pesticides, which have a role which we will be discussing. Even environmental factors are important in type 1 diabetes because there are prenatal triggers like congenital rubella infection or maternal enteroviral infections, cesarean section, high birth weight, old maternal age. All this puts a child at risk of developing type 1. Postnatal triggers like environmental infections, the frequent respiratory infections, early introduction of cereals, eggs and cow's milk can also trigger autoimmunity. Promoters of progression of type 1, like overweight or increased height velocity, high glycemic load, high fructose intake, dietary nitrates or nitrosamines which come from the environmental pollution, pubertal status because it is associated with natural insulin resistance, steroid treatment and stress. All this puts even a child at risk of developing type 1. So environmental factors are more important than genetic predisposition in development of type 2 and also in type 1 diabetes. So colonization, so it is a very interesting study and article which is or rather a video which is easily available on YouTube. So sweet misery, or how British colonizers contributed to diabetes among the South Asians. So basically during this 150 years of British Raj, there were 17 or 18 famines which were documented. Before British Raj came to India, it was only 5 famines in the past 2000 years. So this increased number and frequency of famines basically led to a large scale development of adaptive insulin resistance. So all of us who are surviving now, we have had ancestors who survived this famine. So how did they survive? They survived by eating less. They survived by developing the adaptive insulin resistance. So they passed on this important gene which was important for their survival to us. But now we live in an environment which is actually obesogenic, or which is more affluent, or there are excess calories which are available to us. So such genes which are affected by famines make us more prone to develop diabetes. So and why there were more famines was because of the brutal and cruel policies of British Raj, where they did lot of food export, they did agricultural destruction, and they demoralized the agricultural laborers. So that's how the famines made us, I mean, probably that's also one of the factors why Southeast Asians are more prone for getting diabetes. uh, Next, yeah, so this twin cycle hypothesis is also interesting hypothesis, where it talks about the intra the fat in the organs which are important in the diabetes development, the fat in the liver and fat in pancreas. So positive calorie balance or excessive calories will lead to increased liver fat. It will lead to resistance to insulin for suppression of glucose production. It will also lead to increased secretion of VLDL, which is rich in triglycerides. So this high triglyceride VLDL, when it comes to pancreas, it is associated with increased islet cell triglyceride, which again reduces insulin response to ingested glucose and causes insulin resistance. So all this cycle is a self-propagating cycle. These two cycles are self-propagating. So the only way of breaking is to reduce the calories and to cause more caloric more utilization of these calories. So these twin cycles are responsible for development of diabetes in a patient who has obesity. Gut microbiota is also extremely important in type 1 and type 2. So as we all know that the immune system, the robust immune system which is associated in the gut, is basically 70% of the immune system is regulated by the gut bacteria. In under healthy conditions, there is a good biofilm of bacteria, and the tight junctions of lamina propria are seen. So whenever we eat a meal which is rich in simple sugars or simply rich in sugar, it leads to inflammation, and it triggers inflammation which leads to damage in the bacterial film. The fibers, if the fibers in the diet are less, the healthy bacteria which live on those fibers, their population reduces, and it promotes the growth of pathogenic bacteria. These pathogenic bacteria cause inflammation. They lead to loosening of the tight junctions. They gain entry across the tight junctions in the submucosal areas, where they lead to inflammation. This inflammation, the inflammatory cytokines, increases the insulin resistance. It also exposes the body to various antigens and makes auto antibody production more. So it also triggers autoimmune response in a patient who has genetically prone for type 1 diabetes. It reduces very important immune cells, which are the T helper cells. T helper cells are very important in preventing obesity. If T helper cells are present at appropriate amount, they will prevent fat absorption, and they will promote ideal fat level in the body. But these reduction in the T helper cell will lead to more absorption of fat. So this leaky gut is also an important seat of insulin resistance in a patient with diabetes. So we need to work on this gut, setting the gut health right. So there is a lot of marketing for pre and probiotics, but very important here is to avoid ultra processed foods, to eat more fibers, to eat more vegetables. That is a simple way of promoting healthy bacteria. Muscle
Sorry
and
to
diabetes.
interrupt, but just a gentle reminder for time, madam. How many
Yes,
slides?
2 minutes more.
Okay, okay.
Yes, so muscles are also very important for diabetes. So we know that in type 1 and type 2 both there is sarcopenia, and the diabetic muscles have reduced metabolic capacity, atrophy. They switch to glycolytic fiber. So there is a lot of painful muscular movement. So often these patients are always complaining of fatigue and painful movement, and they are less motivated to move. So muscle is also very important. It is 50 to 60% of peripheral glucose uptake is at the level of muscle, so it is important for insulin resistance. So various drugs, we all know about glucocorticoids, but beta blockers, basically there are beta receptors at the level of pancreatic nerves, and they, by blocking these, they reduce insulin secretion. Thiazides, by causing hypokalemia, lead to hyperglycemia. Nicotinic acid and statin also, the HMG-CoA reductase pathways which they inhibit are also essential for insulin secretion. So high intensity statins like atorva or rosuvastatin in higher doses are associated with diabetes development. The protease inhibitors in retroviral diseases, the treatment of CA prostate, where the goal here is to make the, I mean, there is androgen deprivation basically. So this androgen deprivation is associated with increased insulin resistance and subsequent development of diabetes. Anti-transplant drugs which are used after renal transplant like tacrolimus, sirolimus is associated with diabetes, whereas atypical antipsychotics are also associated, and the tyrosine kinase inhibitors, which are the new oncotherapy, that is also associated with diabetes. So EDCs like arsenic in water, bisphenol A in plastic, which comes through food and water, and organophosphates and chlorines, which are there in the chemicals, are associated with insulin resistance and diabetes. So in conclusion, it's a contrasting and pervasive disease. Too many calories, malnutrition, both are associated with diabetes. Too much insulin, insulin deficiency, both can be seen in diabetes. Too much fat and lipodystrophy, that is too less fat, is associated with diabetes. Malnourished mother and obese mother, IUGR, as well as macrosomia, all these contrasting factors can be seen in diabetes. So it's a very challenging disease. Genes, intrauterine environment, and the extrauterine environment are equally important. It is pervasive because it affects all the organs. So the tagline for managing is balance everywhere. Try to keep the mind, meal, and muscles in balance. So try to move more, try to eat healthy, healthy meal, and try to control the stress at the level of mind. Thank you very much for this opportunity. And just one more message, that read your labels carefully. So this is the depiction of amount of sugar that goes in all these ultra processed drinks, which are easily, easily we can find at any kirana shop, and easily we can gulp down the whole thing. But just see the amount of sugar that they have. And also, by, I mean, this is just the label. So all the things which are marketed as healthy are not really healthy. So one has to be mindful about these and try to teach these aspects to your patients, because they are the ones who are going to make these lifestyle choices, and we have to educate them about this. Thank you very much for this opportunity. uh, I will stop sharing the
Yes.
screen, and questions are invited. Thank you.
Thank you, madam, for a wonderful lecture on the basics of diabetes. I think we can say that a good balance in life, as you said, and preventive measures to prevent the diabetes itself should be the key to fight against the diabetes. Due to consent of time, I request madam to please be in the audience, and I request the audience to put the questions in the chat box. We are from IMA Dombivli. We are really thankful, madam, for being the part of this symposium and enlightening us on basics of diabetes. And we present this certificate of appreciation from the IMA Dombivli for comprehensive and elaborate session for medical professionals on diabetes mellitus back to basics during online D4 symposium Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd of November 2023. Thank you, madam. Thank you once again. And now I
Thank you very
request,
much.
yes, ma'am. And now I request Dr. Archana Pate, madam, to take over the session ahead. Thank you.
Okay. Yeah, am I audible?
Yes, ma'am.
Yes, yes,
Okay.
ma'am. Yes,
So
ma'am.
thank you, Dr. Kanekar, for that wonderful session. I think this will make it easier for our attendees to go through the subsequent sessions with much ease. Thank you, Dr. Hemant Patil, for that wonderful moderation. We move on to our next session. Timely diagnosis of diabetes is very likely to have a beneficial impact on patients' future clinical course by decreasing the amount of time they are exposed to high level of adverse risk factors. To throw light on the diagnostic tools in diabetes, we have with us Dr. Milind Bhide. To introduce our eminent speaker and to moderate this session, I invite Dr. Makarand Ganpule. He is immediate past president of IMA Dombivli and a consultant pathologist practicing in Dombivli since last 22 years. Over to you, Dr. Ganpule.
Thank you, Dr. Archana, ma'am. Can I get the slide, please? The next topic is the diagnostic tools in diabetes. To speak on this topic, we have eminent pathologist who will be speaking on this topic is Dr. Milind Bhide. Dr. Milind Bhide is an MBBS and MD from prestigious Grant Medical College. He's a gold medalist at MD in 1991. He runs a private pathology lab in Thakurgwar in Mumbai. He has a special interest in endocrine and immunoassay, special interest in laboratory information systems, and has designed and uses a self-made laboratory information system. So I request Dr. Milind Bhide to please go ahead with the session. He will be speaking on diagnostic tools in diabetes. If any delegates, if they have questions, they can raise the hand in the end of the session if the time permits, or otherwise they can put the questions in chat box. Over to Dr. Milind Bhide, sir.
Thank you, Dr. Makarand Ganpule, for having invited me for this session. And I would also like to thank IMA Dombivli for arranging this wonderful session on a very important topic, which is diabetes. So I'm here from the lab side to discuss about diagnostic tools in diabetes. First, let's look at the pathophysiology of diabetes. This slide applies only to non-insulin dependent diabetes. So diabetes is a disease which happens in genetically predisposed individuals. It's multifactorial inheritance. So there's no one single gene except for monogenic diabetes, which is a very small percentage of cases. So we can't really do a genetic test and find out who is going to develop diabetes. Insulin resistance is the key, and it precedes many years before overt diabetes happens. Generally, diabetic patients will have higher insulin levels compared to normal individuals for the same level of blood sugar. Bad food habits containing high carbohydrate foods, sedentary lifestyle aggravate the situation, and other pathologies like high blood pressure also can aggravate the overall clinical scenario. There is disturbance in lipid metabolism. High blood pressure and thyroid disease will create complications. And most of the complications, clinical complications of diabetes are because of vascular complications, which develop 50 to 20 years after the disease sets in. Because of this, we have increased risk of myocardial infarction, diabetic retinopathy, and nephropathy, which are extremely common in most diabetic patients. So having said this, let us look at the different tests that are available. The tests that are available for diagnosis are obviously blood glucose measurement and HbA1c. I'm not going to go through the exact values because I'm sure there are a lot of clinicians who are going to speak on this topic and they will discuss the values in their own talk. Once you have diagnosed diabetes for diabetes management, we can again look at blood glucose done at various times of the day, including post-breakfast, fasting, post-meals, evening, and night, or even continuous glucose monitoring, which is now possible. We have HbA1c, which is an invaluable tool for the control of diabetes as well as managing or reducing the incidence of complications. As we all know, diabetes is a disease that affects microvasculature. To detect the incidence or to detect the probability of this microvascular damage, we can do what is called as a microalbumin to creatinine ratio. In patients who have ketosis, there is a test available which is called serum ketones. We can do what is called as a beta hydroxybutyric acid, which is superior than measuring ketones in urine, which will tell us how we can manage these patients. All patients which have serum ketones will need aggressive management, preferably by admission. For insulin resistance, which is the key to this disease, we can do fasting insulin and fasting glucose, and there is an index called as HOMA index, which will help. Since this disease also complicates other diseases and the lipids are dearranged, we must do lipid profile, TSH for any concomitant thyroid diseases, and creatinine to know whether the kidney is affected in any way. There are other special tests which can be done, like C-peptide in patients who are on insulin, to understand whether they are producing in-individual insulin. Insulin gets secreted from the pancreas as pro-insulin, which gets split into C-peptide and insulin. And C-peptide is also only possible. The source of C-peptide is only the in vivo, that is from the pancreas of the patient. When we give insulin externally, that can affect insulin levels when detected on immunoassays. So when the patient is taking insulin, we have to do C-peptide. Other antibodies like IL-6 antibodies and GAD65 antibodies are done for insulin-dependent diabetes, which is thought to be a autoimmune process with a possible trigger. Tests for monogenic diabetes, as I mentioned, available. I will not be discussing further about this. So before we go on to other things, first let us look at the life cycle of a sample. The sample is collected in a fluoride tube. Today, most of the labs are remote and testing is done remotely, and the collection samples are collected in a collection center. Many of you may be having your own collection centers where you collect samples and send it to the lab. It is important that when you test for glucose, it is collected in a fluoride tube. How does this help? After we collect the sample, the RBCs and the WBCs in the blood continue to consume glucose, and they will bring down the glucose levels. So this has to be inhibited, and this inhibition is done by fluoride. So unless we use a fluoride tube, the blood glucose levels in the tube will not remain stable. So if you collect the sample in the morning and the fluoride is not there, by evening, you will have at least 25 to 30% reduction in the glucose when it is done after 12 hours. These samples are barcoded for identification, centrifuged, and the plasma is then used on the analyzer for testing. Testing usually is automated in at least most modern labs in major cities. So most modern labs in metro cities have a high degree of automation. So the chances are very less for analytic error are extremely less. Every clinician wants to know, how does a lab ensure that the results are correct? So what we do basically is that we do quality control. How do we do this? If I was to extrapolate that, if a clinician wants to understand if his weighing scale is proper or not, what would you do? You would take a known weight, a substance of a known weight, and put it on the weighing scale and see that if the designed weight is 50 kilos, is the weighing scale showing 50 kilos or not? And that is how you would know that your weighing scale is working properly. So similarly, as far as analyzers are concerned, we order pre-analyzed known sera in large quantities. So this vials which is seen here contains samples which are stabilized, and once all these vials will contain the same value of glucose. So if you see here in this chart, every day in the morning we run the glucose value from this vial, and as you can see, the value is constant. So from this I come to know, by plotting this chart, that my analyzer is working properly and I should be able to give accurate results for the patient. It is also possible to rerun a previously tested sample the previous day to see if the value compares with the new value compares with the old value. So in this way, the lab is able to achieve quality control and can ensure that we are able to give correct results. So let us look at the common questions that patients have for us. So I have doubts about accuracy of the result, either the patient or the clinician. What can we do? So most labs will preserve the sample for 2 or 3 days, and since it is taken in fluoride tube, the result constant. The lab to retest them, and we can also look at the QC data of the lab. So how long is glucose stable in a sample? It is stable for around 72 hours, and if you're talking about HbA1c, it is stable for almost 5 to 7 days if it is stored properly. Glucose was not requested when the sample was first collected. Can I put a request after say 4 or 5 hours? As I mentioned before, if the fluoride tube is not collected and only a serum tube or EDTA tube is collected, the glucose levels will start coming down. So if a request is put after 4 or 5 hours, we may not get accurate reading because of degradation of glucose. Now, patient has been on the same medication for several months and values have been in control. Suddenly, one fine day when he gets the values tested, he suddenly realizes that values have either gone very high or have gone very low. So what could be the reason? The commonest reason is infection. UTI is very common in diabetic patients, and any kind of infection, either fever, dengue, malaria, can increase the degree of insulin that is required. And a patient who is previously under control can have high glucose values, and this will be temporary in nature. So what are the other fluctuations? What the reasons for fluctuations in blood glucose levels? One is the time of the meal. as we know, the glucose and the insulin, the type of insulin that is taken is titrated depending upon the timing of the meal. And if the meal time is not constant, then actually the blood glucose values are going to change. Change in exercise routine, change in the type of food, or the glycemic index, or stress can all change the values of glucose in a patient who is previously under good control. In today's age, analytical errors in barcoded samples are very rare and not a common cause of variation in blood glucose. But sometimes we get same values for fasting and PP, and the patient is always worried that I made a typing mistake. It is not so. It is possible that fasting values and post values are absolutely same. We can also have a condition where PP is less than the fasting and fasting is more. Sometimes in some patients, post glucose value tend to be very low because of excessive secretion of insulin. And this is also normal in many patients. Another question that patient has is they have tested in the lab and they have also tested at home using a glucometer. So what would be the difference? In the lab, we test the sample on plasma, and plasma levels are generally 10 to 15% higher when tested in whole blood, where what is done on the glucometer. However, the recent glucometers have what is called as plasma calibration, and they will have values which will match the values given in the lab. What are the chances of a typographical error? In an IT-enabled lab, the instrument will transmit data directly to the PC. So there is very little scope of manual typing. So in an IT-enabled lab, the chances of a typographical error are very rare. It is possible that the lab has made a mistake when the patient registers in the morning in the patient's name or gender or the age, or many times in the name of the referring doctor is incorrect. And patients are always worried that if there is any such mistake, his entire report is wrong. This is not so. Tubes are barcoded, and the barcode only encodes the sample ID, and the result is linked to the sample ID. So any other such errors like typographical errors will not affect the reading of the sample. So as I've shown here, these are two barcodes, and this is a barcode which is used for a fasting sample. These tubes, this barcode attached to a tube, and this tube is kept in this rack, and the rack is then loaded on the analyzer, and the analyzer has an inbuilt barcode reader which will scan this barcode and positively identify the sample. And when the results are analyzed, for example, here's a chart for B12, we can see from which bottle it is done, from which instrument it is done, and what is the value. So in this way, we are able to positively identify the sample when it is loaded on the analyzer. Let us look at another important investigation, which is glycosylated hemoglobin. What is glyco-HB? So RBCs basically live for 120 days, and they contain hemoglobin when they are formed. The glucose in the sample irreversibly binds to hemoglobin, and this is called as glycosylated hemoglobin. So measurement of glycosylated hemoglobin is a measurement of hemoglobin and not of glucose. The rate of attachment of this glucose is directly proportional to the level of blood glucose. So the higher the amount of glucose, more the attachment and more the concentration of glycosylated hemoglobin. So the HbA1c test measures the glycosylated hemoglobin. Since the RBC live for 120 days, glyco-HB is the average glucose of the average blood glucose of the last 3 months. So when we do HbA1c, it gives us the idea as to what could have been the blood glucose level for the past 3 months. There are several methods available, and generally methods which have a very low CV or very low variation, as we can call it, as we say in layman's term, is useful, and generally a CV of 3% or less is ideal. A glycogen of less than 7% should be the treatment goal. And from this, there is a mathematical calculation to calculate the mean plasma glucose using a calculator. These are the reference values. So less than 5.7 will be normal, and more than 6.5 will be a diabetic. And depending on the glycosylated hemoglobin, we can get some idea what has been the control in the past 3 months. Sometimes we get values which are very low. For example, we can have a value which is just 3.5%. So this could be because patient has iron deficiency anemia which has got corrected. Patient could have G6PD deficiency or other hemolytic anemias or hemoglobin variants. So any condition which will decrease the red cell survival will decrease the hemoglobin A1c value. And in such a case, that value may not be useful for the interpretation as far as diabetes is concerned. So control of glycosylated hemoglobin leads to improved clinical outcome. It's a very stable test, easy to perform, does not require fasting. And today, most patients do their glucose at home and come to the lab only to do glycosylated hemoglobin. There's no intraday variation, and excellent instruments for multiple vendors are available. Those who are interested can go to this website NGSP, which has a lot of material about the different methods, references about different things, and it is dedicated to HbA1c. We also have good QC and EQA, that is external quality assurance, available for HbA1c. So how do we estimate HbA1c in the lab? There are several methods available. HPLC is a method of choice. It has a very low variation. It is fast, it's automated, and most important, it is able to pick up hemoglobin variants. So the important points of HbA1c are, it gives the average of the past 3 months. There will be a lag time after starting or changing treatment options. So if the HbA1c was initially high and the patient starts taking treatment, it will take at least a month or two for the HbA1c to decrease after the blood glucose comes under control. Mind you, it is a subtype of hemoglobin A. So hemoglobin A1c is glycosylated hemoglobin A. So whenever we have a homozygous mutation where we have, say, sickle or HBD Punjab or HBE, or when fetal hemoglobin is more than 22%, there may not be presence of hemoglobin A, and hence HbA1c cannot be estimated. There are several known hemoglobin variants that can affect the measurement of HbA1c, which is done on HPLC. RB survival and production has to be constant for us to accurately interpret HbA1c values. The previous method which I mentioned, that is the chemical methods and enzymatic methods, do not detect variants, and those are not suitable or will not be suitable to pick up any kind of hemoglobin variants in patients with such diseases. So what are the disadvantages of glycosylated hemoglobin? It is affected by red cell turnover, like iron deficiency, blood loss, malaria, hemolytic anemias. It is not useful in gestational diabetes because it's a short-term disease. Hemoglobinopathies I've already mentioned. And HbA1c cannot be used, it cannot be done in homozygous conditions. So for your reference, I have a graph here. On the left-hand side is a graph which is coming from an instrument which does HbA1c measurement. So there we have hemoglobin S. As you can see here, there is a S window which is detected, and this sample has 31.9% of HbS. The HbA1c reported is 7.1%. Since this instrument is able to take care of heterozygous conditions, I am able to report this HbA1c to the clinician. As against this particular patient has an unknown variant, which is 79.4%. So this patient probably has some other hemoglobin, probably hemoglobin D or E, or probably S, for which the patient is homozygous. And in this case, it is not possible to give HbA1c, and that is why this reading is not reported. However, if this sample was to get analyzed by other methods like immunoassay or non-HPLC methods, this could not have got picked up, and we would have got some value for HbA1c, which would not be right. So as we know, diabetes is a long-term disease, and long-term management is the goal. All organs are affected, and damage to microvasculature takes years. Damage to microvasculature happens in multiple organs, and it can easily be detected in the eyes and kidneys. In the eyes, we can do a fundus examination, and for the kidneys, we can do what is called as urine examination, which is urine albumin to create protein ratio. We can estimate GFR, and we can also do creatinine, which can give us eGFR using a formula. So what is microalbumin? Microalbumin is a very important test, but neglected test, which should be done in patients who have diabetes for some years. It is nothing but albumin secreted in the urine in small quantities. Albumin, the molecular weight of albumin is 60,000 Daltons, and it is at the threshold where the protein is just retained by the kidneys. So microalbumin is nothing but albumin secreted in small quantities, and it is a very strong predictor of diabetic nephropathy and also a strong predictor of cardiovascular disease. So patients with microalbumin will have undetectable albumin when done by urine strip method. So if you have done urine routine and it has protein 1+, then doing microalbumin may not help because the concentration is already on the higher side. We can do what is called as a spot sample. Very easy to do. It should be done when the patient has got up before doing any physical activity, because after physical activity, normal patients can have some amount of albumin coming in the urine. Concentrated sample done after decreased water intake is preferable. We can also do a 4-hour sample or a 24-hour sample, and it will still help in interpretation of microvasculature. As we all know, diabetes is all about insulin resistance. There is something called the HOMA index, in which we do fasting glucose and insulin levels, and we have two scores, HOMA 1 and HOMA 2. Calculators available online. What they basically do is they check the level of insulin against the glucose level, and we can get some idea as to what is the degree of insulin resistance. So these are the reference intervals. More than 2 is considered insulin resistance, more than 5 probably diabetes. What is the confusion? The confusion is that many people use HOMA 2 calculator and use the normal range for HOMA 1. HOMA 2, there is no normal range. So please check which calculator you are using. There are two calculators available, HOMA 1 and HOMA 2, and the reference range is only available for HOMA 1. I will stop here and I would answer any questions if available. Thank you, sir.
Thank you, Dr. Bide, sir. If there are any questions, actually there is one question which has appeared in the chat box. If the patient is having thalassemia, what will be the HbA1c reading? What will be the reading will be affected, or we can use HPLC for thalassemia patient?
So if the patient is thalassemia minor, which has a benign clinical course, there is no significant decrease in red cell survival, and we should be able to use HbA1c for management of diabetes. If the patient has thalassemia major, the red cell survival is severely decreased, and then such patients we cannot use HbA1c for the management of diabetes.
Thank you, Dr. Milind Bide, sir, for the excellent session, and especially concentrating on pre-analytical errors also, and how to collect the samples, and because that is the thing which is many a times neglected when we receive samples from the hospital, especially from the hospitals. Thank you, doctor.
Yeah, I would like to also add in the last that please have some confidence in the lab. Lab is your partner for managing your patients. If the clinicians have a query, please talk to your pathologist and find a solution so that we can work together for the benefit of the patient. Thank you so much.
Thank you, sir. This last take-home message is very important. Can I get the certificate? This is a certificate of appreciation from IMA Dombivli presented to Dr. Milind Bide for comprehensive and elaborate session for medical professionals on diagnostic tools in diabetes during online D4 Symposium organized by IMA Dombivli on Friday, 3rd November 2023. Thank you, Dr. Milind Bide, sir, and over to Dr. Archana Patil for further proceedings.
Thank you, sir. Thank you so much.
Yes, Bide sir, that was indeed a wonderful session, and I think you have given some very practical pointers of diagnosis. I mean, it is useful in our day-to-day practice. Everybody sees those results, but interpreting them is something which we need to know. And the finer points which you have given, they really will make a lot of difference in the practice. Thank you so much for those wonderful pointers. Thank you, Dr. Ganpule, for that wonderful moderation. And now we move on to our next session. Our third session is on diabetic nephropathy. As we know, in India, the prevalence of chronic kidney disease is 800 per 10 lakhs of people, and the incidence of end-stage kidney disease is 200 per 10 lakhs, and diabetic nephropathy is the most common cause. Diabetic kidney disease is a complex and heterogeneous disease with numerous overlapping etiologic pathways, including changes in glomerular hemodynamics, oxidative stress, inflammation, interstitial fibrosis, and tubular atrophy. Considering the irreversible and progressive nature of the disease with such high prevalence, efforts should be directed towards its primary prevention. To talk about this very important topic of diabetic nephropathy, we have with us eminent nephrologist Dr. Dinesh Mahajan, and to moderate this session, I invite Dr. Shruti Patki, who is anesthesiologist at Dombivli, and just allow me, because Shruti, I have received this at the last moment. I'm sorry I've not been able to add it. But what I can say is that she is a crusader for teaching the CPR, and she has got her very own Anubandha, this for teaching the CPR. And so we have with us Dr. Shruti Patki, who's going to be moderating this session and the next. So over to you, Dr. Shruti Patki, for moderating the session. Dr. Shruti, you are made a co-host. You should be able to mute and unmute yourself. Just a minute. Yeah, Dr. Shruti?
Yeah, can you hear me now?
Yes, yes.
Yeah. Good afternoon, everyone. It's an honor and a privilege to introduce Dr. Dinesh Mahajan today. He is an MBBS, MD Medicine, DM nephrologist, practicing at his own Disha Kidney Care at Dombivli. He's been an assistant professor in Department of Nephrology, KEM Hospital, Mumbai. Area of expertise, kidney transplant and adult and pediatric is his area of expertise. Also, he has an expertise in critical care, nephrology, and dialysis. He has many papers to publications to his name as well. Sir, we would like you to enlighten us with your talk on diabetic nephropathy today. Over to you, sir.
Am I audible?
Yes, you are.
Yes. Good afternoon, and I'd like to thank IMA Dombivli to give me this opportunity to speak on this important topic of diabetic nephropathy. As we are all aware that with increasing burden of diabetes, India is already the diabetes capital of the world, and the entire medical fraternity is busy managing all possible complications of diabetes. One of them being diabetic nephropathy. In the next 15 to 20 minutes of my presentation, we'll be having a brief introduction of the topic. We'll be talking about the pathology of diabetic kidney disease, the significance of albuminuria, and a small note on non-diabetic kidney disease and various hypoglycemic agents in diabetic kidney disease.
Dr. Mahajan, if you could
Uh,
make your screen full screen, that will help.
Now, madam?
Yes.
Yes, so 30 to 40% of the diabetics will develop diabetic kidney disease. Now, diabetic kidney disease accounts for the single most common causative factor for end-stage renal disease in India. Around 70 to 80% of the patients who land up with hemodialysis, the causative factor for them developing renal failure is diabetic nephropathy. The next one being hypertension. A patient being diagnosed with diabetic nephropathy, it has huge financial implications considering the financial aspect of dialysis management or the financial aspect of kidney transplantation. Uh, the most important thing about this disease is if patient is monitored properly right from the beginning, we ensure that proper glycemic control is achieved. Definitely, the progression of diabetic nephropathy can be retarded, and patient will be benefited in a big way. Coming to the pathology of diabetic nephropathy, as we are all aware, it's a complex complex pathway where there are few metabolic factors and hemodynamic factors. The metabolic factors being like increase uncontrolled sugar leading to development of basement membrane hyperglycation, basement membrane thickening, that leading to oxidative stress, and hemodynamic factors like activation of renin-angiotensin system. Both these factors will lead to activation of intracellular signaling molecules, which ultimately leads to increased transforming growth factor beta, and ultimately it leads to fibrosis and sclerosis. So that leads to advanced diabetic disease or diabetic glomerulosclerosis. Now, here we can see a single glomerulus with typical Kemmelstein-Wilson lesions in the glomerulus, signifying advanced nature of the disease. Now, the Renal Pathology Society classification is used for classifying the diabetic nephropathy. That is classified into four classes. Class 1 being glomerular basement membrane thickening with the glomerular basement membrane more than 430 nanometer in males and greater than 395 nanometer in females. Class 2 being mesangial expansion. Class 3 being presence of one Wilson lesion in the glomerulus, and class 4 is advanced diabetic sclerosis. Now, as Dr. Bhide also pointed out in the earlier presentation, that monitoring albumin-urea is the simplest way to monitor diabetic kidney disease. Now, it's a marker of intraglomerular microvascular change. Now, the terminology microalbuminuria is given up now, and it has been replaced with moderately increased proteinuria. That is proteinuria between 30 to 300. And if the proteinuria is more than 300 milligrams, then it is classified as severely increased proteinuria. Earlier, it was known as macroalbuminuria. Now, control of albuminuria prevents the decline in GFR. So every diabetic patient should be monitored for presence of albumin in urine. Now, 20% of the patients with declining GFR will have no albuminuria. Now, this point is very important. Many times we keep on monitoring the albuminuria, but in spite of patient having diabetic nephropathy, still his urine protein will be negative. So we need to keep this point in mind that even if there is no albuminuria, patient can still have diabetic nephropathy. Now, the stages of diabetic kidney disease are stage of hyperfiltration, stage of moderately increased proteinuria, stage of severely increased proteinuria, overt proteinuria, and end stage renal disease. Now, in the initial phase, because of intraglomerular hypertension, there is hyperfiltration, and ultimately, if there are proper glycemic control, lifestyle measures are not followed, then that leads to development of microalbuminuria, and which progresses to severely increased proteinuria and overt proteinuria. Now, one can clearly see from the graph that till the stage of microalbuminuria, the decline in GFR or the slope of fall in GFR is very less, or the decline in GFR is very slow in the initial phase. But once the proteinuria crosses over proteinuria, that means it crosses 1000 milligrams, then the decline in GFR just increases in a logarithmic way. So that signifies that the earlier we pick up microalbuminuria and we make all possible efforts to retard the progression, definitely we can delay the onset of end-stage renal disease in our patients. The evaluation of albuminuria in the previous presentations, sir has discussed about this thing. The basic test spot urine albumin creatinine ratio or protein creatinine ratio can be done. But the gold standard for proteinuria estimation remains 24-hour urine protein estimation. Though it is cumbersome, but it remains the gold standard for proteinuria estimation. Now the estimated GFR, the preferred equation is the CKD EPI equation, which takes into consideration the gender and race, apart from creatinine and body weight. And there are various calculators which are available from which estimated GFR can be calculated. Now, this is the KDIGO classification of diabetic kidney disease, which takes into account the GFR, and it has given due consideration to the level of albuminuria for classifying diabetic kidney disease. Now, coming to the epidemiology of diabetic kidney disease, very less data, Indian data is available regarding the epidemiology of diabetic kidney disease. Type 1 diabetic patients, 20 to 30% will have moderately increased proteinuria at 15 years, and less than half will progress to overt proteinuria. When it comes to type 2 diabetes mellitus, as per the UKPDS, this is the UK data. At 10 years, the prevalence of moderately increased proteinuria, severely increased proteinuria, and elevated creatinine concentration was 25, 5, and 0.8%. But practically, what we see is in India, the prevalence is much, much higher. What we are seeing, though there are no confirmed long-term studies present in India, but definitely the picture is much alarming in practice. Now, what are the various risk factors for development of diabetic kidney disease? Genetic factors, certain genetic phenotypes like DD polymorphism, ACE genotype, 82 gene haplotype. Now, presence of these haplotypes will increase the chance of progression of diabetic nephropathy. Improper blood pressure control. Majority of the diabetics will develop hypertension at some point of time. So, improper blood pressure control will accelerate the intratumoral changes. Poor glycemic control, that remains the most important factor which decides the outcome. Race, presence of obesity, and smoking habit. All these factors, along with the glycemic control, will have a bearing on the progression of diabetic kidney disease. Now, non-diabetic kidney disease. Now, every rise in creatinine in a diabetic patient is not diabetic nephropathy. There are few rarer causes also. Say around 20 to 30% of the patients with high creatinine in diabetes could be because of glomerular disease per se. And the most important causes of them being membranous nephropathy, IgA nephropathy, post-infectious glomerulonephritis, minimal change disease, and FSGS. Most important thing is when to suspect such cases. Uh, a patient with proteinuria developing within 5 years of diagnosis of diabetic nephropathy. Usually, proteinuria takes some time for development. So, if a patient develops proteinuria within 5 years, we should suspect non-diabetic kidney disease. Active urinary sediments. Usually, during routine examination in diabetic nephropathy, the sediments are bland. So active urinary sediments will give us a pointer that there is some underlying, like say, connective tissue disease like lupus or IgA nephropathy. Acute onset of disease. Diabetic nephropathy, the onset is always chronic. It is always a slow progression. If there is acute progression, then we should think of non-diabetic kidney disease. Lack of retinopathy in type 1 diabetic patients. Now, fundus, doing simple just fundus examination will give us good enough information about the microvasculature of the body. So, if a patient of diabetes, he lacks any changes in the retina and he's having high creatinine, then we need to rule out non-diabetic kidney disease. Now, the uniqueness of diabetic kidney disease is the early development of anemia. Many times we see that a patient's creatinine is normal, he's having 3 plus 4 plus proteinuria, and they start developing early edema feet and anemia. So the reason remains less erythropoietin production from the kidneys. Patient is already a diabetic. Patient is already having diabetic kidney disease. He is having decline in GFR, and they start developing anemia. Second unique feature is uremic symptoms at low level of creatinine. Now, patients of diabetic kidney disease, they will develop fluid overload type states. They will develop uremic symptoms, anorexia, nausea, vomiting at very low level, say 3 or 4. The level is not fixed to any every particular patient. It keeps on varying, but development of uremic symptoms are very common at very low level of creatinine. If you take the case of, say, hypertensive nephropathy or polycystic kidney disease, patients with even a very high creatinine level of 10 or 8, they will be stable. But if you take the case of diabetic nephropathy, then definitely at low levels of creatinine, they will develop uremic symptoms. Early onset of fluid retention, that is the characteristic that any diabetic coming with edema feet definitely is a pointer that patient is having proteinuria and is having underlying diabetic kidney disease. So early development of anemia, uremic symptoms at low level of creatinine, and early onset of fluid retention are the unique features of diabetic nephropathy. Now, treatment of diabetic nephropathy. Now, actually, treatment would be a very wrong word to say, because like there is no complete treatment for diabetic nephropathy. But what we can do is we can just say these are measures to retard the progression of diabetic nephropathy, because diabetes is a long-standing disease, and the pathology starts from day one, and it is very important that patient is sensitized towards these changes so that we can take preventive measures. So to retard the progression of diabetic nephropathy, it is important that Patient needs to be sensitized about aggressive glycemic control. The HbA1c values should be below 7 or closer to 7. There should be a good blood pressure control. As per the KDIGO, the target they have set is below 130 by 80 millimeters of mercury. Weight reduction, definitely obesity control helps in retarding the progression of diabetic nephropathy. Now, role of renin-angiotensin system blockers. These have been the chief agents in control of proteinuria and hence progression of diabetic nephropathy. Now, proteinuria is given more importance because more is the proteinuria, more will be the inflammation in the glomerulus, more will be the activation of the fibrotic pathway, and hence leading to glomerulosclerosis. So that's why controlling the proteinuria becomes very important. And renin-angiotensin system blockers have a big role to play. But then we need to understand that there is no role in primary prevention. Okay, for primary prevention, the most important thing is controlling the blood sugar. So their role is in secondary prevention and not in primary prevention. The key factor is to start in the initial stages of moderately increased proteinuria. So that's why every diabetic patient should be monitored for proteinuria once in 6 months. And if there are, if moderately increased proteinuria is identified, then definitely renin-angiotensin system blockers should be initiated. Now, combination therapy with an AT2 receptor blocker can give rise to hyperkalemia and acute kidney injury. So, while using renin-angiotensin system blockers, it is important that we keep a close tab over the potassium levels and also monitor the creatine level frequently. Now, additional kidney protective therapy. Now, these are new agents which have shown to have a protective benefit. Now, having said that, but the major role still lies with good glycemic control. The new agents being SGLT2 inhibitors, non-steroidal selective mineralocorticoid receptor antagonist, and GLP-1 analogs. Now, for SGLT2 inhibitors in diabetic kidney disease, they help by reducing the glucose absorption in the proximal convoluted tubule by inhibiting the sodium glucose co-transporter. They cause glycosuria and natriuresis. They normalize the glomerular tubular feedback by increasing delivery to the macula densa and reduce the intraglomerular hypertension and reduce the hyperfiltration. SGLT2 inhibitors also reduce cardiovascular events in established atherosclerotic cardiovascular disease. They prevent hospitalization and death in patients with reduced ejection fraction. Their use should be avoided in GFR below 20. Basically, with low levels of GFR, they are not going to act because the basic action lies in inhibiting the sodium glucose co-transporter. So the major role of SGLT2 inhibitors lies in helping in glycemic control, okay, achieving good blood pressure control, and of course reducing the proteinuria. So that way, by through these all three different mechanisms, SGLT2 inhibitors are postulated to retard the progression of diabetic nephropathy. Of non-steroidal mineralocorticoid receptor antagonists, they block the mineralocorticoid receptor, which has a major role to play in inflammatory and fibrotic cascade. The agent being finerenone, it is usually started 20 milligram, but its use should be avoided in GFR below 25. And it is very important that we monitor hyperkalemia in such cases. GLP analogs, patients with established diabetic nephropathy with advanced kidney disease, over there GLP-1 analogs usually have a lesser role because at low levels of GFR, the glycemic lowering effect of GLP-1 analogs is very less. So they have weak glucose lowering effect, particularly in patients with reduced eGFR. They can be used safely in patients with eGFR more than 50. and monitor for gastrointestinal side effects, nausea, vomiting, which could precipitate AKI if we are using GLP-1 analogs in patients with advanced diabetic nephropathy. Now, coming to the various oral hypoglycemic agents which are used commonly in every diabetic in a setting of diabetic nephropathy. The most controversial has been metformin. Now, FDA has cleared the doubt. The US FDA has cleared it out. Now, the recommendation is very clear that below GFR of 30, metformin should not be used, but it can be used safely in GFR between 30 to 60. Now, if the GFR is below 30, the maximum recommended dose is only 1 gram. Beyond 30, we can keep the dose to around 2 grams. So pioglitazone, the use should generally be limited because they have a tendency for fluid retention, fluid overload, and as diabetic nephropathy patients also have a tendency for fluid retention. So use of pioglitazone should generally be avoided in such cases. So coming to sulfonylureas, which by default remain the predominant group which are used in India. Now, their use should ideally be avoided, but like considering the financial aspect, their use is still there in India in a big way. Glibenclamide use, which is the longest acting amongst the sulfonylurea, should be completely avoided. The ones which can be used are glimepiride, gliclazide, and glipizide. Though the chances of hypoglycemia remain high with use of sulfonylurea in patients with diabetic nephropathy. Now, coming to DPP-4 inhibitors, the safest of them being linagliptin, because it is the predominant metabolism is through the liver. Sitagliptin can be used in half the doses, but other gliptins should be avoided.
Dr. Majan, may I please interrupt? We are running short of time.
Yes. Now I'm just ending my presentation. The problems unique to diabetic kidney disease are poor AP fistula prospects. Hypoglycemia is relatively more common in diabetic kidney disease patients. Survival is less compared to non-diabetics on hemodialysis. Cardiovascular disease is the most common cause of death in such patients. Now, the take-home messages: estimate albumin, and eGFR annually. Maximize the use of renin-angiotensin system blockers. Keep suspicion of non-diabetic kidney disease in mind. Diabetic kidney disease will have uremic symptoms early, and it is best to have an integrative approach for a strict glycemic control and to retard the progression of diabetic nephropathy. Thank you.
Thank you, sir. Thank you so much for an enriching session. Can we take, if there is time, we can take questions if there are any.
We are running short of time, actually. I think the participants can ask questions in the chat box. I'll request Dr. Majan to please be in the audience. And if there are any questions, please take it up in the chat box.
Yes.
Thank you so much.
On behalf of IMA Dombivli, we'd like to present the Certificate of Appreciation to Dr. Dinesh Mahajan for a comprehensive and elaborate session for medical professionals on diabetic nephropathy during the online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd November 2023. Thank you so much, sir, for an enriching and enlightening session. I hand over the session to Rajna Patel for further proceedings.
Yes, thank you so much. Thank you, Dr. Majan. I think it's very, very important to understand diabetic nephropathy. As we have seen and as you have rightly said, it is fairly common, and the patients can be saved a lot of trouble if everybody is, rather conscious about looking for early onset of diabetic nephropathy. So thank you for that wonderful presentation, and thank you, Dr. Shruti, for moderating the session. We now move on to our next session. Studies show an increased likelihood of sudden cardiac death and unrecognized myocardial infarctions in patients with diabetes. Moreover, acute ischemic syndromes, peripheral arterial disease, cardiomyopathy, advanced CVD complications occur more commonly in patients with diabetes than in those without. Because the typical cardiac symptoms often are masked in patients with diabetes, the diagnosis of myocardial infarction commonly is missed out or delayed. Effective strategies for earlier detection of clinical CVD could reduce morbidity and mortality in patients with diabetes. To throw light upon this particular facet of diabetes, cardiovascular complications in diabetic patients, I invite upon our next speaker, Dr. Atul Limaye, to enlighten us on this particular aspect, and I request Dr. Shruti Patki to kindly continue with moderation of this particular topic.
Thank you, ma'am. Thank you for the session. I would like to now introduce our next speaker, Dr. Atul Limaye. He's a director of cardiology and TAVI services at Fortis Hospital, Mulund. He's a highly experienced interventional cardiologist with decades of niche expertise in diagnosing and treating cardiac diseases. He's been on the American Board in Internal Medicine Cardiology. He's an interventional cardiologist at Nuclear Cardiology and Echocardiography. He's finished his fellowship in interventional cardiology at Mount Sinai Hospital, New York. He's also finished his fellowship in cardiology from Montefiore Medical Center, New York. He's got many fellowships from other schools like the Harvard Medical School, Birmingham, and Women's Hospital, Boston. He's also been a fellow at the Royal College of Physicians, London. Areas of expertise are coronary angioplasty, TAVI, and clinical cardiology. I would like to now hand over the session to Dr. Atul Limaye, and I would ask him to please enlighten us with the session on cardiovascular complications in diabetes. Thank you, sir.
Thank you very much for that introduction. Can you hear me?
Yes, sir. You're audible.
Let me see if I can get my... Are my slides visible?
Yes, it is visible.
Great. So thank you for the opportunity to speak to Dombivli IMA today on the cardiovascular complications of diabetes. And as you all know, diabetes is a risk factor for ischemic heart disease. It is an independent and major risk factor for heart disease. So the way diabetes affects the heart is through various ways. One is indirectly by causing accelerated atherosclerosis, which is the graph that you see in the front of your screen. So you develop blockages in the coronary arteries, which in turn lead to ischemia, which in turn causes heart failure. And the end result is heart failure, either preserved ejection fraction or reduced ejection fraction. Diabetes can directly be toxic to the heart and cause what is called diabetic cardiomyopathy, which is a unique kind of cardiomyopathy, which is unique to diabetic patients because of, again, direct toxic effects of having high sugar in your bloodstream for many, many years. And diabetes and the interplay of diabetes and atherosclerosis and heart failure can in turn also lead to chronic kidney disease. So all in all, diabetes is a major risk factor for ischemic heart disease. What are some of the cardiac complications of diabetes? The top complication of diabetes obviously is myocardial infarction. This can be either ST elevation MI, or it can also be unstable angina or non-ST elevation MI. Other complications, heart failure. We talked about the unique form of diabetic cardiomyopathy. Or patients are also prone to develop heart failure with preserved ejection fraction, so-called HFpEF, because diabetes leads to stiff ventricles. Stiff ventricles do not allow relaxation of the ventricle appropriately, and therefore you develop heart failure with preserved ejection fraction. These are the various ways in which uncontrolled diabetes affects the heart. So coronary artery calcification, accelerated atherosclerosis, increased arterial stiffness. It can also cause diastolic dysfunction because of the impaired relaxation, increased ventricular stiffness, and it can also cause heart failure with reduced EF because of systolic dysfunction. It leads to reduced heart rate variability, increased in the resting heart rate, and impaired coronary vasomotor activity and can lead to all sorts of arrhythmias. Because it blunts the sympathetic and the parasympathetic nerves, diabetic patients traditionally and typically do not get the classic angina. So they may not complain of the classic constricting chest pain, arm pain, jaw claudication, all of which we are very familiar with. Instead, they may be very vague about their symptoms. They may talk about a little bit of a chest pressure. They may talk about dyspnea on exertion. They may talk about undue fatigue. And these symptoms may be their manifestation of angina because, as I said, the parasympathetic and the sympathetic innervation of the heart has been blunted. Myocardial infarction is the primary cause of death in patients with diabetes mellitus. This second sentence is very important, and I want to stress that adequately. Diabetic patients without a history of coronary artery disease have the same risk of major coronary events as those with existing coronary artery disease. What do I mean by that? What I mean is, if you have a patient who is non-diabetic, who has existing coronary artery disease today, in other words, he has had angioplasty, bypass surgery, etc., he is a diabetic patient without any history of known coronary artery disease, has that same risk as a non-diabetic patient. That is a very, very powerful statement that should indicate to you that diabetes is nothing but a coronary artery disease equivalent. Diabetic patients with a history of myocardial infarction have more than 40% risk of a recurrence of MI. So you can see in these three sentences how intricately involved diabetes and coronary artery disease is. In fact, it would be no exaggeration to say that if somebody has 5, 10, or 15 years of diabetes, you should consider them as having coronary artery disease. Now, what is the extent of that coronary artery disease? Obviously, may be different in different diabetic patients. Some patients may have overt high-grade lesions. Other patients may have minor lesions or microvascular dysfunction, and we'll get to that in a minute. There is more than 20% risk of a first MI within 10 years of developing a diagnosis of diabetes, which is equal to the risk of a second MI within 10 years in a non-diabetic patient with a history of MI. What does that tell you? It basically tells you that the presence of diabetes speeds up heart disease. The plaque formation, the fatty streaks which are built up in the artery wall, which are ultimately going to narrow the artery, are accelerated the moment you have impaired glycemic control. And because arteriosclerosis is accelerated, you get more blockages, and it is no surprise that you get more myocardial infarction once you have long-standing uncontrolled diabetes. We talked about the fact that diabetic patients don't have the typical symptoms. Ischemia can occur without symptoms in diabetic patients. In fact, many a times when we do coronary angiography, we are surprised that a diabetic patient with minute or minor symptoms has extensive multivessel ischemic heart disease on presentation even before his ischemic symptoms has occurred and even before treatment has been instituted for his coronary artery disease. I think previous speakers have also documented that a delay in diagnosis leads to worse prognosis, particularly when it comes to coronary artery disease. We spoke about diabetic cardiomyopathy, which is a unique kind of direct toxic effect of diabetes. So you don't have to have blockages in the arteries for you to develop cardiomyopathy if you have diabetes. The reasons for that: direct toxic effect of chronic high sugar, the presence of microvascular disease, which is different from the macrovascular disease which we detect on coronary angiography, the presence of autonomic neuropathy, the presence of widespread ischemia because of coronary artery disease. A combination of all of these factors leads to cardiomyopathy, which can be heart failure with reduced EF, or it can be heart failure with preserved EF. These are the various sort of pathological underpinnings of how diabetic heart disease occurs. I think it's important that we understand what is happening at the micro level. So inflammation, diabetic patients are in a chronic inflammatory state. The presence of advanced glycosylation end products, faulty insulin signaling, faulty neurohumoral and accelerated neurohumoral mechanisms, autonomic dysfunction, accelerated myocardial cell death pathways, mitochondrial dysfunction, and overall stress in the myocardium because of the interplay of all of these factors. Let's shift gears and talk about the vascular complications. The mandate is to speak not just about the cardiac, but about the vascular issues as well. So where are the two important vascular complications of diabetes? Brain and the neck vessels, which cause stroke, and peripheral vascular disease. So if someone has blockages in the aorta or the iliacs or the leg arteries, it will cause claudication, critical limb ischemia, and sometimes even lead to gangrene of the extremity. Mortality from stroke is increased almost threefold when patients with diabetes are matched to those without diabetes. What is the most common site of a stroke in diabetic patients? It is the small penetrating arteries, which you can see in this cartoon here. So atherosclerosis can happen anywhere in the neck vessel or in the brain. What I'm just indicating is that a common site in diabetic patients are these small penetrating arteries for which there is really no immediate mechanical solution. So you can't sort of go in there and remove a clot because it is lodged in any of these small arteries. Almost 13% of patients above the age of 65 have had a stroke if they've had diabetes. This is just a cartoon that is telling you that the atherosclerosis can happen in the common carotid, internal or the external carotid arteries. If it happens in the internal carotid, this is the highway to the brain or one of the highways to the brain. The other is the vertebral artery. If you have blockage in the internal carotid artery, you can have downstream effects from that blockage leading to stroke. And the interventions typically are either carotid endarterectomy, where the surgeon takes out the plaque with an open surgery, or carotid artery stenting, where we put a stent and minimize and maximize flow in the carotid artery. Diabetes increases the likelihood of severe carotid artery disease, and diabetic patients are likely to suffer irreversible brain damage with carotid emboli that otherwise in non-diabetics would only produce a transient ischemic attack. So the message that I'm giving you is that everything that happens in diabetes is X times what happens in non-diabetic patients. What about peripheral arterial disease? Well, the same process of accelerated atherosclerosis that happens in the heart and happens in the brain can also happen in the peripheral arteries supplying the blood. So here's a cartoon that shows you that patients with diabetes and peripheral artery disease have up to 15 times higher chance of leg amputation. Over 30% of diabetic patients above the age of 50 have peripheral arterial disease, and greater than 50% of patients with critical limb ischemia also have diabetes. And once you have diabetes, what you see here, the photograph of the leg of a person is just an advanced arteriosclerosis leading to impending gangrene. And what you see in the picture right below that is someone who's had an amputation, a below knee amputation, as a result of extensive diabetic peripheral arterial disease. So the interplay of other risk factors such as smoking, hypertension, and high cholesterol, along with a sedentary lifestyle and diabetes. So a pentafecta of risk factors, if you will lead to insulin resistance, which in turn will lead to metabolic syndrome. And then one risk factor plays on top of the other, and very soon you have accelerated atherogenesis, endothelial dysfunction, micro and macrovascular disease in all the vasculature in the body, the heart, the brain, and the legs. This is the interplay of what happens at a micro level. So endothelial dysfunction, microthrombosis, inflammation, platelet activation, RAS activation, and all of this leads to rapid and extensive atherosclerosis, dysinsulinemia, and a tendency to thrombosis. What are some practical considerations that we can take from whatever that I have said so far? Well, number one, take symptoms seriously. Number two, investigate symptoms seriously and counsel lifestyle changes aggressively. This could include smoking cessation, weight loss with portion and calorie control, and we should make a special mention to encourage physical activity in all our diabetic patients because of the downstream beneficial effects of insulin resistance amelioration with physical activity and risk factor control. What about treatment? Obviously, lifestyle changes first. Medications with an aim to improve glycemic control, lower lipids, and better control of high blood pressure. What are our treatment targets? The ADA recommends that we target an HbA1c of less than 7, which translates to a fasting of less than 130 and a PP of less than 180. I think all of you know that. This graph is important. It basically talks about a shared decision-making model with your patients. What do I mean by that? So if you have a patient who's 75 years old and he has poorly controlled diabetes, you are not going to be as stringent with that person as you are going to be with a 40-year-old patient. So here is the sort of cartoon that shows you, where you need to be more stringent, more aggressive, and where you need to be a little lax. So where should you be lax? Elderly, multi-vessel or multi-organ damage in a 70-plus-year-old person. And where should you be more aggressive? In a 40-year-old who has been recently diagnosed. There is a special type of dyslipidemia in diabetic patients where they have high triglycerides and small LDL particles and high apolipoB. Our lipid targets are LDL less than 70 if they only have diabetes, and LDL less than 55 if they have established coronary artery disease. We should use high-intensity statins, atorva, 40 and 80, or Rosuva with or without ezetimibe. What about hypertension? One line. Treat hypertension to target a blood pressure of 130 or 80 or better, and we prefer RAS inhibitors over all the other agents. So ACE, ARB, which also have the benefit of kidney protection. Second line may be calcium channel blockers, and our third and fourth line are thiazides and beta blockers, because all of us are familiar with the small risk of increasing sugar and altered lipid profile with thiazides, and a small risk of masking hypoglycemia with beta blockers. Which is not to say that you shouldn't reach out for these drugs, only to emphasize that your first line and second line should be ASARB, and CCBs. My last slide, take-home points. I know I'm right tight on time. Take-home points. Diabetes is a coronary artery disease equivalent. Take symptoms seriously and investigate thoroughly for ischemic heart disease. Ischemic heart disease and MI is common among diabetics. Stroke and peripheral artery disease are other vascular complications. There are multiple pathways to heart failure in a diabetic patient. We should treat sugar, lipids, and blood pressure aggressively. And don't forget lifestyle interventions, diet, and exercise as the cornerstone of all diabetic therapy. Thank you for your attention. I think I was fairly tight on time. I'm happy to take any questions.
Thank you so much, sir. Ma'am, I think we do have 3 minutes if there are questions.
Yes, yes. Let us please take questions. So just as you advised, a tight glycemic control, you took a very tight time control. So wonderful presentation there. Any questions? We'll be happy to take questions.
I think there are no questions. I just want to point out just one pet peeve of mine, which is important because I think the audience is important. I think the audience of Dombivli physicians and other doctors, my pet peeve is the following, that when you see a lab report and it says that the LDL is less than 130, and all of us think that LDL 130 se niche ho gaya, kaam khatam ho gaya. I think that mentality needs to change. I think we all need to appreciate that we should drive down LDL as much as we can to a target of less than 70 in diabetics and less than 55 if they have heart disease.
Sir, there are many people who are here, many are family physicians and we have got audience from the entire Maharashtra. So what I'd like to ask is that, there are times when we start them on statins when the LDL is still on a higher side, but the total cholesterol has come down. And, the patients are really of quite this on you that, you need to do something about the drug levels. So can you just give any guideline regarding that?
So
Because
there
these
have
days
been
patients are quite aggressive on telling us about what to do and what not to do.
I think my prediction is that in the coming years, you will find that most of the societies, the ADA, the ACCHA, are going to continue to lower the target for LDL. You remember not many years ago, the target LDL used to be 130, then it moved to 100, now it is 70, and in established coronary artery disease, the target is 55. Why is the target going lower and lower? Because there are enough studies out there that show lower the better. So now there are PCSK9 inhibitors, the injectable medicines that are driving LDL to the 20s and 30s. And there is no signal of harm when your LDL is 25. So I think our focus, the entire focus, should be on LDL and LDL only first and triglycerides second. And let's drive down the LDL to as low as possible.
Dr. Shruti, if there are no other questions, we can wind up the session.
Okay. Thank you so much, sir, for a wonderful session. On behalf of IMA Dombivli, we would like to present the certificate of appreciation to Dr. Atul Limai for comprehensive and elaborate session on cardiovascular complications in diabetic patients during the online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on February 3rd, November 2023. Thank you so much, sir, for a wonderful session. I hand over the session back to Dr. Asna Patil. Thank you, ma'am.
Thank you, Limesh sir. It was indeed a wonderful session, and I think our attendees have taken many take-home messages today from you, and it's going to be really beneficial in their practice. Thank you so much for that lucid session. Thank you, Dr. Shruti, for that wonderful moderation. We move on to our next session for the day. Just give me a minute, please. Yes. So before we move on to the next session, my small announcement again regarding the MMC credit points. Please put your attendance in the chat box. The MMC credit points will be given to people. I'm sorry. Yeah, okay. So MMC credit points will be given to the attendees who attend the session, and of course, those who give their attendance in the chat box. There will be no physical issuance of the certificates. The MMC credit points will be uploaded directly on the MMC website into your own MMC webpage. This whole process takes about a month's time, so be patient and please check in your MMC web credit points in your own MMC web page at the end of 1 month, and the credit points will not be as D4 Symposium. It will come from IMA Dombivli. So please do check it after a month's time. Okay, so moving on to the next session. Erectile dysfunction secondary to angiopathic, neuropathic, or myopathic damage is a leading complication of diabetes in males. Other reproductive complications include ejaculatory dysfunction, hypogonadism, modified semen parameters, and delayed puberty. Specifics of reproductive dysfunction in diabetic women are less definite than men due to lack of standardized evaluation of sexual function in women. To talk on this very important issue of sexual health in diabetics, I invite upon Dr. Ajay Kanbar, and to moderate this session and the next, may I please invite Dr. Sharad Gurav, consultant laparoscopic and laser anorectal surgeon having his own Dr. Gurav Surgical Clinic at Dombivli. He is also attached to Fortis Kalyan, SRV Mamta, and Curie Hospital, Thane. Over to you, Dr. Sharad.
Yes, hope I'm audible clearly.
Yes, you're audible.
Yeah, good afternoon, everybody. On this sweet afternoon, we are talking about the diabetes. So the next session we are going to be having on diabetes and sexual health, as told by Dr. Archana Madam. For this session, we have speaker Dr. Ajay Kanbur. He is a consultant urologist practicing in Thane. He is honorary urologist at Australia Hospital, Jupiter Hospital, Thane, FPAI, Mumbai, Indira Mondi Mulund, and Fortis Hospital, Mira Road. He is International Transplant Fellow from the University of Tennessee, Memphis, with special area of interest being kidney transplant and embryology. He is the urology faculty for SIMA, Mumbai, and former associate professor of urology at KM Hospital. He has several national and international publications and presentations to his credit, and actually participates in various symposia, conferences in urology. So, may I please welcome Dr. Ajay Kanbur to this wonderful session. Dr. Ajay Kanbur, over to you.
Yeah. Why am I not getting the screen? Can you see the screen? Am I audible?
Yes, sir, you're audible and the screen is visible. Yeah.
Thank you. Thank you, Dombivli IMA, for inviting me for this session. I might add quickly here that the sequence of Atul and Ajay was wrong, because the penile problems and the ED functions start much before the coronary one starts. So it should have been Ajay Atul instead of Atul Ajay. Nevertheless, diabetes affects certainly sexual function, erectile dysfunction being the most common. 30 to 50% of men will complain at some time or the other after the diabetes for having erectile dysfunction, a poor libido, premature ejaculation, as well as retrograde ejaculation. If you see this box, the red is no problems. At the age of 40, if there are no problems, minimal problems start a little later on. And as you go to the age 70, you will find that there are less normal people and more problem with complete problems of erectile dysfunction. Quick word about women, though I am a urologist, andrologist, it is women also play a part in male sexual dysfunction. Inadequate vaginal lubrication, reduced desire, particularly post-menopausal, increased time or a mismatch in orgasm is also caused partly for male sexual dysfunction. The psychological effects following this is severe depression, sometimes up to a point of suicidal tendencies. There is complex, there is a lot of guilt, there is fear of complications of diabetes and urinary infection for some reason that men always say that they want to avoid sex. There is tiredness and fatigue, low body self-esteem, there is pain, disfigurement, etc. Pregnancy, of course, in the elderly is not to be considered. What would be the risk factors for patients of diabetes having ED? Smoking, trauma, alcohol, and age by itself can lead to ED. But the vascular disease, treated, untreated hypertension that coexists with diabetes, multiple drug therapies, particularly beta blockers for blood pressure, dutasteride for BPH medications, are the ones that bring down the libido, and therefore it adds to the existing erectile dysfunction. Neuropathy of diabetes, all of you know, obesity itself and metabolic syndrome only add to the problems of erectile dysfunction in diabetes. What are the factors, therefore, for development of erectile dysfunction? Age, duration of diabetes, how long it has been. We are seeing younger patients who have diabetes. Therefore, one has to be very careful. Someone said, we know India is the diabetes capital of the world, and therefore, to have erectile dysfunction in a diabetic man also is a challenge. Smoking habits, hypertension, dyslipidemia, obesity, and so on. So all these problems have to be collectively taken care of before we actually decide on what kind of treatment to give for diabetes. So how would you assess a patient of ED in a diabetic? First and foremost, take a very good history and proper physical examination. I have a Prader orchidometer which actually tests the size of the testes, and we note it down. If we can come after 5 years or 10 years and find a reduction in the size of the testicular volume, it also suggests hypogonadism. Fasting glucose, evaluation of secondary sexual characteristics, blood pressure measurement. Other investigations included clinical pictures would mean picture of detumesced penis, as well as a picture of an erect penis in AP and lateral taken by the patient on his mobile and shared with the doctor. Examination of penis and testis, of course, is a part of the examination. So quickly coming to treatment of ED in diabetes, would be all currently licensed pharmaceutical treatments that are possible. I will give you a list of medications that we start with and we end with. All the neurovascular consequences of diabetes may mean patients are more resistant to treatment. So if you already have diabetic neuropathy, it means that next in line would be cystopathy, diabetic cystopathy. But much before that would be erectile dysfunction. So as I said, even before a coronary event, the penile event would already have set in. So patients in diabetes who say that they have poor erections or a poor libido must undergo complete cardiovascular check also. How would you treat treatment of erectile dysfunction in men? Pharmacological agents, patients and partner choice. You must always ask the partner what exactly they are aiming at. Are they aiming at childbearing? Are they aiming at sexual pleasure or whatever? Type 1 diabetes patients are more likely to accept self-rejection therapies for ED than patients with type 2 diabetes for very obvious reasons. So treatment options are standard PDE5 inhibitors, which once upon a time was possible on prescription either of a urologist, physician, psychiatrist, or an endocrinologist. These days, anyone and everyone can do it, which is good because access to these medications was otherwise almost impossible 20 years ago. Sildenafil, tadalafil, vardenafil are all available in India. The advantage of sildenafil is it rapidly acts and works for about 1.5 hours. Tadalafil acts very slowly, but has an action of almost 36 hours. Therefore, patients who decide on an emergency sexual activity should first go in for sildenafil, which means that nothing was planned. Suddenly they feel they should have coital activity. They must take 100 milligrams sildenafil, rapid action in 45 minutes to 1 hour, which lasts for 1.5 hours. Those patients who have planned sexual activity can take tadalafil on a Friday night or a Saturday night so that the action will persist till Monday morning. This does not mean that they will continue to have erection or remain on an erect state. It's only that a little stimulation will certainly cause tumescence or erections. Alprostadil is a prostaglandin. Vacuum device, psychosexual therapy, and surgery I will dwell upon in a short time. First and foremost, there are no studies documenting that improved glycemic control will improve erectile dysfunction. 90 out of 100 patients say that my sugars are absolutely normal and still they will have erectile dysfunction. So this is a wrong thinking, but on the whole, it has other benefits, and therefore a good sugar control will certainly mean better quality of erections. Psychosexual counseling is very rarely done. Our patients are in such a hurry to get good erections that they don't want to go for psychosexual counseling. The correct sequence is to actually undergo psychosexual conference, change in lifestyle, behavior therapy, followed by drugs, followed by surgery or other devices. But when you say psychosexual counseling, the first thing say is, "Mala kai ved lagle ka? Am I mad?" So the best thing is to sort of tell them, rather than using the word psychosexual, I say sexologist or sex therapy, which is more acceptable to the patient, and then quietly send them to a psychiatrist or a psychologist. Here also, it is important to discuss the quality and stability of man's sexual relationship and how much interest he has in his sexual activity. With reduction in libido, he will not open up. Most men who come primarily for erectile dysfunction in diabetes start their history with urinary symptoms or some vague symptoms. After examination, and when they are about to leave the clinic, they say, "Can I just talk to you for a minute?" And then they start all over again with their sexual symptoms. So it's a good idea to ask the patient to open up immediately and start working on it. The first line therapy for ED would be class of drugs that have cyclic GMP PDE5 inhibitors, which I said was sildenafil, vardenafil, or tadalafil. Sildenafil is available, as you know, in 50 and 100 milligram tablet. Tadalafil is 5, 10, and 20 milligram that prolong the vasodilatatory effect of nitric oxide to initiate and maintain an erection. The other drug which releases nitric oxide is L-arginine. So what we have been doing these days is give a continuous dose of L-arginine daily in the night for about 2 months. It is sold as arginitric. And as and when the patient needs, they can take sildenafil, vardenafil, or tadalafil. Therefore, at that point, they would have had good release of nitrous oxide because of L-arginine as well as sildenafil action. And that gives fairly good results. What are the adverse effects of PD inhibitors? We all know, and the patients tell us there's a lot of headache. But I think this is a small price to pay when 3 minutes of pleasure gives you about an hour of headache at the end of 24 hours. This is better than the headache of not having erection at all. Flu-like symptoms, dyspepsia, abnormal vision, particularly to blue-green light, because PD inhibitors affect the retinal evoked potentials, and therefore white light is appreciated as blue-green light. It is absolutely temporary, and the patient gets back to normal in 24 hours. Quick word about vacuum devices. This is a device wherein there is a cylinder with a rubber band at the end and a suction at the top. Patients need to shave their private part and insert the cylinder onto a flaccid penis and use the pump. Gradually, the penis starts to get engorged with venous blood. And at the end of 3 or 4 pumps, when the penis is of a fairly good size, the rubber band is slipped onto the base of the penis and the cylinder is removed. This gives a fairly good amount of tumescence rather than erection. Now, patients who have very severe arterial insufficiency should not use this device. Patients, on the other hand, who have good arterial flow but have got venous leak benefit the most from these devices. Now, patients who do not want sildenafil, vardenafil, patients who do not want papaverine injections on the penis, patients who don't want to go far as to have a penile prosthesis are the ones who will benefit with vacuum devices. Now, officially, these devices may not be sold in public, but you can as well order it on Amazon or other websites and get it ordered at home. This is fairly good. Patients do well, particularly those who are elderly. Intraurethral alprostadil is a prostaglandin which has to be just inserted into the penis, actually into the urethra. And because of release of prostaglandins, the urethral mucosa absorbs the prostaglandin and therefore causes an erection. Now, this may be, it's not very easily available in India. One has to import it. And therefore, it is not very well known or popular in India at all. Coming to intracavernosal injections is almost a sure shot sign of having good erections. This directly causes tumescence in the penis within about half or 1 minute of injecting papaverine into the corpus cavernosum in a proper clinical setting initially. The drugs that can be given are papaverine, phentolamine, and prostaglandins. Prostaglandins is expensive and therefore not available in India. We have started using largactil or chlorpromazine in place of prostaglandins. So we call it bimix, papaverine and largactil combination. They are now used less often because of availability of sildenafil, vardenafil. But patients who don't or who show tachyphylaxis to these medications can still be given this injection. The first injection has to be given in a clinical setting just to make sure there are no adverse effects. And the patients have to be told to watch for priapism for at least 1.5 hours after the injection is given. This is how it is done. The application of tourniquet at the base of the penis is not required. Just 1 cc of 30 milligram papaverine or the mix is injected into the corpus cavernosum. And once this is done, apart from a little burning sensation, there is no pain because the needle is a 29 gauge needle. Within half a minute, the patient starts to get good tumescence. The other problem of erectile dysfunction is premature ejaculation. Unless asked, patients on their own do not volunteer because they have good erections. They will not come and say that there is a problem of premature ejaculation. Some patients primarily come for this because they say that their intravaginal erection time was very poor. So a patient who has ejaculation within 1 minute of vaginal penetration is a person on whom you should say there is premature ejaculation. People misuse this. After 1.5 to 2 minutes also of intracoitus, they say that they have premature ejaculation. So what we normally do is we actually give them a timer and they should time themselves just at the point of vaginal penetration and till the point that they start ejaculating. And that is the time of ejaculation. 1 minute or more is absolutely normal. Anything less than that is premature ejaculation. Mind you, premature ejaculation runs in families, and it is very difficult for a patient to be told or that he should be asked his father or his grandfather whether they had premature ejaculation. No one is going to ask his father about this, but it runs in families for sure. In diabetics, premature ejaculation is associated as high as 30 to 60%. So it is a fairly large proportion of patients will have this kind of premature ejaculation. Delayed ejaculation and anejaculation are also a part of diabetes erectile dysfunction, but certainly to a lesser extent. Delayed ejaculation is probably because of improper training of the brain, and anejaculation is largely because of drugs. Now, factors that are used with development of premature ejaculation is the duration of diabetes. The more late you are diabetic, the more the chances you get premature ejaculation. Metabolic control, erectile dysfunction that coexists with premature ejaculation. People confuse and they tell us that they have erectile dysfunction. In reality, they ejaculate fast, therefore they detumesce fast, and so they say they don't have erectile dysfunction. So sometimes premature ejaculation patients benefit by giving only sildenafil or tadalafil, and that clears off their premature ejaculation. How would you diagnose premature ejaculation? Assessment of self-estimated intravaginal ejaculatory lesion time, which is what we call IELT, by giving a simple stopwatch. It is not a good idea to give wife the stopwatch because she will always say it is less. So always give the patient and ask him to start and stop the stopwatch. In other lab routine tests, there is a serum leptin, which is now almost becoming a sort of standard landmark for premature ejaculation. So in a few years' time, if we estimate serum leptin, we will come to know whether patients have premature ejaculation. treatment, the first and foremost is psychological behavior. We must remember that erectile dysfunction is a penile phenomena. Premature ejaculation is a brain phenomena. So patients in whom there is premature ejaculation, you are the physician to divert his attention to psychosexual behavior rather than other things. Now, the best treatment these days is a SSNRI or selective serotonin reuptake inhibitor drug called Depoxitin. It's available as a 30 milligram capsule. 2 capsules 1 hour before sexual activity will cause good delay in the ejaculation by 4 to 5 minutes. 4 to 5 minutes is a long time for intravaginal penetrative sex. It's an on-demand, and therefore there are not much side effects except for a little blurring of vision and giddiness. Therefore, patients who take Depoxitin, it of course clears in 1.5 hours, but they are advised not to drive in the night. Retrograde ejaculation is common with sympathomimetic drugs such as imipramine, and they can offer improvement on conversion to antigrade ejaculation. The commonest cause, of course, is a TURP. Patients who have undergone TURP and are not told will get retrograde ejaculation. Patients who are on tamsulosin and other alpha blockers have an ejaculation but not retro ejaculation. They will not ejaculate at all or have a very low volume ejaculate. Now, all these can be treated with a variety of drugs. If nothing works, in younger patients who have retrograde ejaculation in diabetes, we have to put them on electro-ejaculator, which is done under anesthesia. And the electro-ejaculation is done through per rectum, where the nerves are given Faradic stimulation, and a cup is placed in front of the penis under anesthesia to collect sperms for either IUI, which is intrauterine insemination, or for IVF. To summarize, male sexual dysfunction, it's a common underappreciated complication of diabetes in men. Very few men will really open up to say they have these problems. Sexual dysfunction can be the first symptoms or comorbidities even before the cardiovascular problems set in. ED may be an early marker of systemic disease, as I already told you. And in presence of ED or hyposexual desire, hypogonadism must be ruled out by offering them hormone replacement therapy. Thank you.
Thank you very much, sir, for this crisp, yet elaborate overview of male sexual dysfunction. So, first of all, if there are any questions from the audience. Sir, I'm a surgeon myself, so I have a question about this, that usually in our practice, we get patients of, am I audible? I'm audible, right?
Yes, you are. Yes.
Okay. So in practice, there are two kind of patients I get. One is over enthusiastic. They means if I give them any sildenafil or tadalafil, they tend to abuse it. So
Yes.
these are one kind of patient, and second kind of patients are extra cautious. That even if you write sildenafil or tadalafil, they already have read everything about it. So they ask about cardiac side effects, diaphysium, etc. So how do you counsel such patients, and how do you avoid them abusing that?
Right. I'll first come to abuse. Patients who have been asked to take one tablet, take 2 or 3 tablets in over enthusiasm. We must remember that PD inhibitors actually inhibits an enzyme, and the amount of enzyme all men have in their body is fixed. So if you have a fixed amount of enzyme, you need only a fixed amount of drug to inhibit those enzymes. Drug more than that will only circulate in the body and cause other problems, but will have no effect on the erectile dysfunction. So it is very clear that you will hardly get to see Viagra poisoning. You will not hear that. At the most, they may get a little they get a tumescent penis for a longer period, but nothing happens. And as the drug dies out, it comes off. The other thing is media. Media has a long role to play. People first Google and check their symptoms, and their friends scare them into saying that sildenafil and other Viagra and other things are going to pose problems. They will get headache and all that. So because of the fear, they don't do it. The other problem is they say that now that I have taken it, I will get used to it. And when they think they get used to it and the dose is only going to increase over the years, they try to avoid it as much as is possible. So one has to play between at the psychology of the patient. In any case, the good news is that this is a prescription drug. So after 10 tablets, no chemist will give him another prescription unless you have a doctor's stamp on it. Therefore, either case, you have to deal with the patients meticulously.
Thank you very much, sir. So now we move ahead to present the certificate of appreciation to Dr. Ajay Kandu for his comprehensive and elaborate session for medical professionals on diabetes and sexual health during online symposium, D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd November 2023. Thank you very much for your time, sir, and your beautiful talk.
Thank you. Thank you.
Thank you, sir. Sorry, I could not display the certificate, but thank you for throwing light on this very important topic. And I think people shy away from discussing this topic. And it is very, very important for us to know as clinicians, because we have seen in clinical practice that people do want to talk about it. The patients do want to talk about it, but they find it extremely difficult to talk about this very sensitive issue. And I think we as clinicians must be able to talk about this issue very, very clearly with our patients. So thank you so much, Dr. Kanbar, for that wonderful session. Thank you, Dr. Gurav, for that wonderful moderation. And with this, let us move on to our next topic. Give me a minute, please. All right, so we have our next speaker and the in audience right now. Okay, so diabetic foot disease is a major global burden for patients and healthcare systems and is one of the most serious complications of diabetes. It encompasses infection, ulceration, and osseous destruction of the foot of a person with diabetes, frequently accompanied with peripheral arterial disease and neuropathy, which play a central role in the disease. The chance that a person with diabetes will develop a foot condition at some point in time is about 15%. Now I invite upon an expert in the field of diabetic foot disease, Dr. Tushar Rege, to speak on this very important topic. And I request Dr. Sharad Gurav to kindly moderate this session.
Thank you, madam. As we all know, diabetic foot is a very common term known to doctors as well as the diabetes patient. But as a surgeon, I can tell you that diabetes foot, in the contrary of common conception, that it is not only presence of wound in the foot, it has multi-modal etiology, and there are multifactorial, multiple factors involved this thing. So throw light upon this, we have Dr. Tushar Rege, sir, who is going to talk about diabetic foot. Dr. Rege sir is MS in general surgery from JJ Hospital and GMC Mumbai, followed by teaching experience at 10 years at the same institute. He has got the first to be awarded Diabetes Foot Fellowship from MUHS. He is a diabetic foot surgeon to the Governor of Maharashtra. He is a president IPA Maharashtra chapter. He has a 35 years of private practice in surgery in central Mumbai. He has DFC, Diabetic Foot Clinic, free diagnostic camps and awareness programs for Rotary, for Mumbai Police, for Raj Bhavan and Konkan Belt at Taronda as a rural initiative. So may I please welcome Dr. Tushar Rege. Dr. Tushar Rege, you are requested to continue the session. Over to you. Thank you.
Yeah, good afternoon, everybody, and pleasure to be with you all. Can you hear me well?
Yes, sir.
Yes, sir.
And is the screen sharing started? Is the screen seen?
Yes, it has started.
Yeah, wonderful. First of all, I must compliment you all for keeping time to such precision. Normally, you know, these symposia usually are delayed at least by some time, but you all have really kept it to precision, which is something great. I'll try and stick to my time. The topic given to me is treat early. And that is something which is extremely important because in diabetic foot, it is said that time is tissue. And with the loss of time, there is tissue necrosis, there is tissue death, and that's how people land up with amputations. I'm sharing a few surgeries with you all. How does my... Okay, yeah. This is the first patient whom I want to show to you. This is a patient who was coming with a small sinus below the fifth toe. Kept on going to his family doctor, then to his diabetologist, and maybe dressings were done. If you see this foot, there is hardly anything which is seen over there. As a result of which, nothing was done. This patient landed up in our clinic. All we had to do was an X-ray. And it is no rocket science. All we did was an X-ray, being a specialty diabetic foot clinic. And if you could see, there is frank osteomyelitis. We had to amputate the toe of this patient. And the problem was not of amputation. Amputation of the fifth toe is not going to really make any biomechanical difference to this patient. His question always was, why was the previous doctor, or why did the previous doctor not do even a simple thing like an X-ray? And believe me, madam, it's not just a medical legal problem. It can be a social problem. These are problems which can lead to violence. These are problems which can lead to altercations. And therefore, as you said, catching something early becomes extremely important. Here, probably he would have lost his toe in any case. His problem was not losing the toe. His problem was, मुझे पहले किसी ने बताया क्यों नहीं that I should have gone and got the X-ray done. Okay. Something very similar. This patient had a callus ulcer. You as physicians, diabetologists, general practitioners must be seeing this very commonly in practice. Callus ulcer is a small, chota sa wound, small ulcer at the base of the toe. Again, sometimes extremely dangerous. And the same thing happened with this patient. Many times in a busy practice, you don't even take off the footwear of this patient to see what the problem is. And this patient also had a frank osteomyelitis of the great toe, and the patient had to lose the toe. Now, what am I trying to tell you in this is, a simple thing like an X-ray done early in any diabetic foot patient, or a patient with, I wouldn't even say diabetic foot patient, in any diabetic who comes with any trivial foot problem, could salvage a toe or a foot. And this is the take-home message in these two cases, which are constantly on my mind, because these patients kept almost abusing their doctors. This is something which we have to take care that this doesn't happen. The figures are very dizzy. I'm sure many other speakers must have also spoken about figures, and these are old figures. Every talk, the figure keeps changing. Now they say there are 120 million diabetics in the country, which means the burden of this problem of diabetic foot is 240 million. If it was 90 million, 180 million. Look at the amount of diabetic feet which we are going to treat, which is actually a very debilitating disease. And over 1 lakh feet are amputated in our country today. And by amputation, I'm not talking of a small amputation like a toe. We are talking of amputations of the forefoot. That means the front part of the foot, below knee amputation, and above knee amputation. So if in our country we are going to lose about 1 lakh feet today, in a country which is developing, in a country where amputation, there are statistics which show that amputees do not attain mobility as what we actually would want. So therefore, your topic for today is very, very apt, where we have to catch these people early so that we can try and prevent amputations. And yet, in spite of all this, even today, we keep seeing these patients where there are patients with bilateral above knee amputation. And it's a very sad thing. This man's life is literally, what can this man do further? It's just that he has been amputated above knee, just that there is no infective lesion, but this life is actually an immobile life. There are a lot of these flowcharts which actually tell why all these injuries and things happen. But I want you to look at the bottom of this slide, which is showing in yellow. There is neuropathy. Neuropathy means altered sensations. And at the top of the chart is angiopathy, where blood flow is compromised. And together, this combination of angiopathy and neuropathy together ultimately cause a small wound or an ulcer, which can actually lead to infections and gangrene. Now, this is something which we have to know and stop at all costs, that it does not flare up to gangrene. There are some things which have now led to a better understanding and better treatment of diabetic foot. Since time is short, we will not go into details of all, but this is just to sensitize the audience. The first thing is something called a biofilm. Whenever there is an ulcer, whenever there is a wound, whenever there is an infection, there is a layer which is called biofilm. And unless and until this biofilm is cleared off, either by some mechanical agents or by scooping off, these wounds will not heal. The other things which have changed the focus or the concept of wound healing is an angiosome concept. Just as a particular area has got a particular police station, a particular state has got a particular government, there are specific arteries, there are specific blood vessels which actually perfuse that part. And to understand that is actually going to make a lot of difference in the treatment of diabetic foot. The third thing which has changed a person's approach to diabetic foot or diabetic foot surgeons to an ulcer and wound healing is vacuum assisted closure or a VAC, where a foam is put on the blood vessels, on the ulcer, which keeps on sucking the exudate at a certain pressure, and this helps wound healing. But the important thing in all this is not just the understanding of the mechanisms of ulcers, but the most important thing is counseling. And this is just to highlight what we are trying to show is that every patient in our clinic gets counseled at least for about 10 minutes, because they say that understanding the disease is actually one important thing to prevent a diabetic foot. With this now, I am going in the reverse direction after showing you an amputation as to how a diabetic foot presents himself. And it all starts because of autonomic neuropathy. And because of this dysfunction in the autonomic neuropathy, the sweat glands, the oil glands of the skin literally start dying out or start drying up. And therefore, this is something which all of you all must be seeing. And it starts with a dry foot. You can see this is classically a dry foot, prone to injuries. As a result of non-enzymatic glycation of the tissues, everything which is supposed to be a supple foot starts becoming a rigid foot. And you get what is known as, a person gets what is known as these hammer toes. Needless to say, these are the toes which will be prone to injuries. These are the toes which will be prone to ulcerations. And this is a precursor of gangrene and amputations. And this is exactly what keeps happening. This is a midfoot collapse with a callus ulcer in the midfoot. And as you see, because of the mechanics of this foot being lost, this ulcer is unlikely to heal. This is an extension of a hammer toe where the great toe has literally got cocked up. Needless to say, this toe is not going to bear the brunt of walking. And ultimately, this toe is going to ulcerate today or tomorrow. And because of these pressure points, because of neuropathy, which I told you, this is a classical callus which occurs at a pressure point on the great toe. And the same callus can be a precursor to gangrene and amputations. This is what madam, I'm impressed with the topic which you said. It has to be early. Everything has to be early. One has to go in, intervene early, give him proper footwear, excise the callus, debride the callus. Otherwise, this same small innocuous callus is going to cause gangrene and amputation either today or tomorrow. This is that same callus over a period of time has macerated. It is going deep down. And this, as I told you, is precursor to infections and gangrene. The same thing occurs in the nails. Because of an overall diminution in immunity of these people, most of them or a large number of these patients have what we call onychomycosis, onychogryphosis. That means fungal infection on the nail, and the nail becomes a giant nail. And ultimately, this nail can just get avulsed. And why does it get avulsed? Because it's almost like a dead nail. Again, this can be a precursor to infections and gangrene. The end stage of all this is a Charcot's foot, where if you see this patient's foot, It is nothing but a bag of bones. They say foot is a marvelous mechanism. It's like if I stand on your foot will get crushed. If I wear my shoes and I stand on your toes, your foot will get crushed. But when my whole body, when I stand on my own feet, my feet don't get crushed. That is as a result of the biomechanics of gait, foot being a wonderful pressure-bearing mechanism. Now, as the arches of the foot collapse, as you can see in this particular slide, this is just a bag of bone. This lady is unable to walk. If at all, this lady will go into a bilateral below knee amputation, just because these feet cannot take the pressure of anything. It's absolutely a non-pressure bearing or a non-pressure accepting foot. And then what do we do? Madam, I have about 7 to 10 minutes more.
Yes, sir.
Yeah. So we have to do certain tests. And what are these tests related to? They are to find neuropathy. They are to find vasculopathy. If elaborate or specific machinery is not available, you can use a monofilament nylon or a monofilament only to find out if there is proper sensations or not. This instrument is called a biothesiometer. A lot of diabetologists would be having this, and this is to test the sensory neuropathy where vibrations are generated. This is a handheld, a small instrument. We take it for camps also, and this instrument tells us
one has to check the blood flow either by palpating the dorsalis pedis artery or by examining with this instrument called a handheld Doppler.
This was to just show you that after maybe doing the first 50 handheld Dopplers, one can mention or one can understand whether the flow is poor, moderate, or good, which translates into monophasic, biphasic, or triphasic blood flow on a color Doppler. And then we can also do these foot mapping tests whereby pressure points can be identified. So this is again to show these elaborate pressure mapping. And see how it shows on the screen. These tests are done to identify which are the pressure points which need to be offloaded, because if you don't offload these, this is a Podia scan. It does not require any science or any gross rocket science to say that these red points are high pressure areas. And I can almost be like an astrologer and tell this patient that if you do not take care in due course of time, the areas marked in red are going to ulcerate. So all we need to do is just give him prophylactic or protective footwear, and we can actually take care of this problem. This is another instrument called ankle brachial index, ABI. ABI tells us about the blood flow and the blood supply. And in a professional setup, where since we are doing diabetic foot only, this is a little elaborate instrument called oxygen saturation monitoring, which is TCPO2 or transcutaneous oxygen tension, where a probe is put on the skin, which can at least tell me that if I amputate at this particular level, whether the amputation is going to heal or not. And again, diabetic foot, if very practically seen, is not a very complex thing. At the same time, the number of amputations, as we said, in our country itself, more than 1 lakh of amputations, major amputations are performed every year. What you need to do is you need to understand diabetic footwear and give the patient proper footwear so that the pressure points are offloaded. Or sometimes we have such type of footwear where there is something like a honeycomb. I can just remove the honeycomb pattern inside. So if there is an ulcer, if there is a pressure area, that in that hole which is created, that pressure ulcer can lie so that it doesn't keep getting aggravated. Simple things. These simple things are going to go a long way in preventing a major problem. And it's afternoon session, people get tired, and therefore I keep showing all ulcers, pus, everything. I like to show some good feet, so at least people feel happy. So I want you all to show us some. This was one of the model with some beautiful feet. But in a diabetic foot practice, we seldom get to see such beautiful feet. What we actually get to see is something like this, where there is frank gangrene. And as if this was not enough, you also get to see absolutely a maggot-ridden foot. This is in my clinic. And it is not an uncommon thing even amongst a so-called good class of people. By good class, I mean those who are conscientious, those who take care of their health, and yet will end up with such problems where gross infections can be done. And we all have to take care. And a pedicure is something which is important. But here, when we touch the patient's feet, many times the patient himself, goes a little out and says, "Doctor, pair ko aap haath laga rahe." And we always show this and tell them that if the Lord also had worshipped somebody's feet, cleansed somebody's feet, then we all as diabetic foot surgeon, not only diabetic foot surgeons, but everybody, whether it's diabetologists, physicians, family physicians, and not just that, even the relatives are counseled, as I showed you in one slide earlier, that these are the people who have to actually touch the feet of the people to see if there is any problem, so that a major problem can be averted. Ladies and gentlemen, I tried to be very brief to just touch various points of diabetic foot. But remember that diabetic foot is not at all a complex thing. All it requires to do is to have a certain passion and commitment. But those treating diabetic feet, or diabetologists or physicians who come in contact with diabetic feet, have to be very, very careful, because sometimes in a very short time, the change can be between something which can be controlled by antibiotics to a major amputation and a debilitating disease or septicemia and death. And as I showed you in the first 2 or 3 slides, it can be catastrophic. The patient starts questioning the doctor because they feel that wrong treatment has been offered to them. And therefore, one has to be very careful. In good humor, this last slide shows that diabetic feet is something which you must treat with due care and respect, because if you don't, this is something which could happen. I end my talk by again showing you beautiful legs. I am fascinated by beautiful legs because in all my clinic, there are callus, infection, pus, maggots. So I'm showing the 2 best legs in the world. These are Jennifer Lopez's legs. And I was told there was a study or some voting where Jennifer Lopez's legs were voted as the best legs in the world. Thank you. Thank you, ladies and gentlemen.
Thank you very much, sir. Thank you for such an elaborate talk. We have learned many new aspects of diagnosing and treating the diabetic foot. So we have 2 minutes if there are any questions from the audience.
Sharad, can I ask a question?
Yes, sure, ma'am.
Good afternoon, Dr. Rege sir. I want to ask a question. What is the role of angiography if there is any doubt in case of any wound which is not healing?
Yes. A very important question. Again, angiography and this vascular assessment again becomes a full topic. We could not cover it over here. The first thing which we do is the handheld Doppler. If one doesn't have a handheld Doppler, we can palpate the 2 major arteries, the dorsalis pedis on the dorsum of the foot, and at the side of the ankle, the posterior tibial artery. Then we do what is called a color Doppler, AV Doppler, arterial and venous Doppler. In this, if there is monophasic flow, then there is a role of angiography, first to find out whether there is stenosis or any gross narrowing of the artery. And then it is followed either by a balloon angioplasty or a stent angioplasty. Now, earlier, it was always thought that diabetic foot is a microvascular problem. But today, we have found that it is not just a microvascular problem. It is also a large vessel disease. And even opening up a higher vessel, if there is a stenosis, because of the increased pressure head, or because the top vessel or the larger vessel has opened up, there can be a good perfusion into the lower vessels. That is where angioplasty or an angiography is performed. Only thing you must remember is that peripheral angiography and peripheral angioplasty has got a limited role. It is there for a short while, but it is done only when there are no chances of the ulcer healing, where ulcer healing can be expedited or facilitated by an angiography or an angioplasty. So it is done only in select cases, but you must also remember that the contrast can be nephrotoxic, and therefore a good renal clearance or a good renal assessment is done before actually doing an angiography or an angioplasty.
Thank you, sir.
Thank you. I think we are at the time now. To summarize this, I can only say one sentence that stitching times is the dictum we are hearing from the childhood fits perfectly for the treatment of diabetic foot. So, may I now, on behalf of IMA Dombivli, I present a certificate of appreciation to
Dr. Sharad, there's one question from Dr. Sheetal Sagade, madam, if you can just take it in the chat box. Is
yes,
X-ray
we can have
compulsory for all foot ulcers in diabetic?
Okay. We can have other question.
Sir, yeah, if you can unmute yourself, sir, you're muted.
Yeah, can you hear me?
Yes, sir.
Okay, I couldn't get the question. Can you tell the question?
Dr. Sharad?
Madam, I also did not get the
Sir, Dr. Sagade madam has asked a question. In a diabetic patient, if there is any foot ulcer, X-ray is compulsory. X-ray needs to be done in all patients.
Ideally, no. But for that, you should be able to assess which patient requires an X-ray, because as I told you, like I showed you in that patient, for me, it was evident that an X-ray is required. For the previous people, probably they did not feel the need for the X-ray. So when in doubt, it is good to do, because if you don't do and then you find some problem, then the whole thing gets spoiled. Ideally, not in every patient at all, but an ulcer which is not healing, a callus which is bone probing, a callus which has a foul odor. These are the patients where X-ray is required.
Yes, Dr. Sharad, can you please sum up?
Yes. Yeah. So can we have the certificate? So on behalf of Indian Medical Association Dombivli, it's my privilege to present you the certificate of appreciation to Dr. Tushar Rege sir for his comprehensive and elaborate session for medical professionals on diabetic foot, diagnose and treat early during online D4 Symposium, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd November 2023. Thank you very much, sir, for your time. Thank you.
Thank you so much. It was a pleasure being with you. Thank you so much.
Thank you so much, sir. And I think you have covered that session really beautifully well. And I think the slides which were shown, or rather the images which were shown, I think people are very likely to remember what they see more than rather what they hear. So it's going to leave a long-lasting impression on them. Thank you so much for covering this topic so well, sir. And with this, we move on to our next topic. Kindly allow me a minute. Yeah. Okay. So diabetes in young has been classically defined as onset of diabetes less than 35 years of age. Sahu et al. Through a protocol-based evaluation and close follow-up of patients with diabetes in young over a period of 2 years determined that the most common etiologies for diabetes mellitus in young were type 2 diabetes mellitus, type 1 diabetes, fibrocalculous pancreatic diabetes, MODY, and mitochondrial diabetes. To talk on this very important issue of approach to a youth who comes with diabetes, I invite upon Dr. Sweta Budyal, and to moderate this session, I invite upon Dr. Ashwini Acharya, who's a consultant pediatrician at Jeevan Jyot Hospital, Dombivli. Over to you, Dr. Ashwini.
Thank you, Dr. Archana. It's a privilege to invite Dr. Sweta Budyal on behalf of IMA. So Dr. Budyal, she is a postgraduate and DM endocrinology from JS Medical College at Kane Hospital, Mumbai. She has got clinical fellowship in bariatric medicine from University of Ottawa, Canada, in 2016. She is a university topper in DM endocrinology from MUHS Nashik 2013. She has got published more than 20 publications in national and international journals. She has got paper presentation in national and international conferences. Her main areas of interest are pituitary and endocrine disorders and metabolic bone disorders. Dr. Budial, please start.
Thank you very much, IMA Dombivli, the organizers, Chairperson Madam Acharya and Dr. Pate for the kind words. Are my slides visible, Madam?
Yes, Madam. Yeah, visible.
Okay. So I must congratulate IMA Dombivli first before I begin for putting together such an excellent symposium, which is very relevant in the current era of diabetes pandemic. And it's very, very pertinent for everyone and anyone who is practicing medicine. So my topic is about diabetes in youth. So again, that's one of the areas where we see that the demographics is changing. A lot of young individuals, adolescents and children are presenting with diabetes. And no, it's not just routine type 1 diabetes that we used to see earlier. So I'm going to throw some light on approach to youth who present with diabetes. So who are youth? So I mean, we all know people who are young at heart, but here we are talking about people between age group of 15 to 32 years. So as Madam said, individuals who present before the age of 35, 32 are considered as young diabetics, and they have to be looked at in a little different way compared to our older individuals who present with diabetes, where the diagnosis is straightforward in most of the cases, and it's type 2. So if we look at the demographics or epidemiology of diabetes in India, there has been a paramount change. Earlier, like when I was a graduate student, what we were taught is that 90% of the patients who present with diabetes during childhood, adolescence, or early age have type 1 diabetes. But now this ICMR study, which was multi-centric study with a follow-up period of almost 20 years, with representation of data from Maharashtra as well. We have KEM and Hinduja as one of the centers who contributed to the study population. What was eye-opening was only 65% of the patients who presented with diabetes before the age of 25 had type 1 diabetes. And type 2 actually accounted for almost 24% of the patients. So that indicates that type 2 diabetes is on rise in young people, and we have to be on lookout rather than labeling everyone who presents in pediatric age group as type 1 diabetes. We really need to make the diagnosis. The diagnosis of diabetes is a very generic diagnosis, I would say. So we have to come to a specific diagnosis because the treatment and the prognosis may change. So again, it's type 2 diabetes is on rise. We know type 1 is becoming less common, but still it's the commonest type of diabetes that we see in pediatric population. But the diagnosis is not so straightforward in children. Like in adults, we see that like these obese, overweight patients, or even patients who are lean but have abdominal obesity who present after the age of say 35, 40, have strong family history. By default, we label them as type 2 diabetics, and we start them on lifestyle modification and oral anti-diabetic medications if required. But in young, it becomes more difficult, especially given the pandemic of obesity in pediatric age group. So there is a lot of overlap between type 1, type 2, and also monogenic diabetes, because the body mass indices of our kids is changing. The normative data itself is changing. So it's not uncommon to see a child who has normal BMI or who is slightly overweight but who actually has type 1 diabetes versus a person who has who is overweight or obese or has monogenic diabetes. So just presence of overweight or obesity which is underlying doesn't point towards the diagnosis of type 2 anymore. Also, all these syndromes of type 1, type 2, and monogenic diabetes can have a lot of uh, common phenotypic features in terms of age of onset, presence or absence of family history, presence or absence of ketosis or ketoacidosis at the time of diagnosis, the anti diabetes antibodies or the classic antibodies that we see in patients with type 1 diabetes, presence or absence of obesity. So all these can vary significantly. So it's, I think, the circumstantial evidence. You put together everything that you see in your patient in terms of your history, physical examination, and their response to the treatment that might have been offered to them before they actually came to you. All these would help you to arrive at the diagnosis at that particular point in time. And the diagnosis may have to be revised also in some children as you see the response to the treatment and change in the lab parameters. So I'll just take you through a few prototype cases. The first one is a 16-year-old male. I'm sure most of you must have encountered such children or adolescents in your clinic. He's referred basically to me for excess body weight. Both his parents are type 2 diabetic. His body weight is around 98 with BMI percentile being well above 99 centile. So he falls into the category of severely obese children. That's a common sense looking at his weight for his age. He also has elevated blood pressure, actually hypertension, so to speak, for his age. His HbA1c is at 7.3%, constituting, again, making a diagnosis of diabetes. His triglycerides are elevated, HDL is low, and C-peptide is normal at 4.2. So he's someone who is obese, had strong family history. He's diabetic. We see the classic diabetic dyslipidemia, which is like kind of a marker of insulin resistance, low HDL, high triglycerides, elevated blood pressure, and also on examination, presence of acanthosis nigricans and few skin tags. So this individual basically has type 2 diabetes, predominantly insulin resistance with some insulin secretory defect also. So the diagnosis here is straightforward. He started on metformin and he was also put on amlodipine 2.5 milligram per day. On second, he was motivated a lot for lifestyle changes. He did lose some weight, was very particular about being more active, staying away from the high calorie dense food. His HbA1c on second follow-up is 6.1%. Third follow-up, it's at 5.7%. And then he disappears for 2 years and comes back with HbA1c of 8.6%. So this is a common scenario that we all face. Oftentimes there is denial or shock. It's for the parents that to realize that the young child has type 2 diabetes, and as a result they may not opt for the treatment. They may just ignore it or go to some alternate ways of treating it, and the patients spend significant amount of time in hyperglycemia. So what is the outcome of long-term cardiovascular outcome of children or adolescents who present with type 2 diabetes quite young during their life? It's something that's very interesting, because whether we should treat them very intensively or give them more and more and more time to accept the presence of this underlying metabolic disorder and work on that and then get their sugars under control. So how should be our approach? Aggressive or let it be? So we have got like very good insights from this today's study group, which was published in NEJM. So in this particular study, children and adolescents between the age of 13 to 17 years of age who had a diagnosis of type 2 diabetes, which was proven not only based on their phenotype, but also absence of anti-insulin and other pancreatic antibodies. And in selected cases, whenever there was a doubt of monogenic diabetes, the genetics were also done. So these were purely type 2 diabetic individuals. And they were randomized to receive either metformin plus lifestyle modification, or metformin plus pioglitazone. And they followed up. And subsequently, even after the study ended, the children were still followed up. The individuals were still followed up for the period of around 15 years. So what we see here is that within 3 years of diagnosis, there is gradual increase in the HbA1c. And the HbA1c, the mean HbA1c at 15 years of follow-up is almost between 9 to 10%. So type 2 diabetes is traditionally considered as a progressive disease. As the age advances, there is more and more beta cell dysfunction, not failure. We don't consider this beta cell loss as a permanent entity now. It's more of beta cell dysfunction, and the insulin resistance remains persistent. And if it's not properly taken care of with the help of lifestyle management as well as pharmacotherapy wherever it is needed, the patients will have poor control. And if we look at the outcome, the median age to develop the first complication in these children was 6 years from the time of diagnosis. And the median time to develop 2 complications was around 9 years. Median time to develop 3 complications was around 10 to 11 years. So within a decade, many of the patients had either 2 to 3 complications. So onset of diabetes in young age or adolescence is not an innocuous entity. That is what the parents should understand. And it has to be dealt with in a more aggressive manner. Also, if we look at these complications with a more closer view, what we see is that the cumulative incidence of hypertension was 67%. That of kidney disease was 54% at 15 years of follow-up. So almost 54% of the patients have diabetic kidney disease, either in the form of proteinuria or decrease in eGFR. They have dyslipidemia, almost 50% of them have dyslipidemia, and almost 30% of them have diabetic peripheral neuropathy. And at 15 years of follow-up, the incidence of the cumulative incidence of presence of any microvascular disease put together was close to 80%. So these patients who present with type 2 diabetes at a young age, there is going to be a huge burden of diabetes-related complications if this condition is not given enough attention and intensive treatment. So it requires a lot of counseling, follow-up, motivation, education to the patient and the family. Coming to the next case, this is a 20-year-old girl. Her weight is around 48 kgs, body mass index is 17, so she's actually a lean girl. She presented with osmotic symptoms which were going on for last 2 months. There is no family history of diabetes. Her random blood sugar, which was obtained because of her osmotic symptoms and weight loss, was around 456. A1C was elevated at 12.5%. The urine ketones were 2+. Blood gas was normal. She did not have diabetic ketoacidosis. TSH was elevated. So she's someone who is lean, no family history, severe hyperglycemia at the time of presentation, presence of ketones, though she is not present in diabetic ketoacidosis. And again, there is one more autoimmune problem that we see here in the form of hypothyroidism. So this all raises a suspicion of type 1 diabetes, which was confirmed by presence of low C-peptide and high titers of anti-GAD65 antibodies. So this is like a classic presentation, though here the age of onset is little late. We classically see the onset of type 1 diabetes before the puberty, but no age is barred. As actually the age advances, the prevalence of type 1 diabetes may go on increasing. We do have patients presenting with type 1 diabetes for the first time in their 50s, 60s, all the time. So no age is immune, but again, this is like a young person. So with a lean body structure, type 1 diabetes would be high on carbs. And she was started on basal bolus regimen. She was quite motivated, she was educated, and she did do everything well. And HbA1c at the age, at 3 months follow-up is around 6.8%. But what next? This is a very common thing. Like at first follow-up, when the family is motivated, they're very sensitive to all the excursions in the glucose. They come over with very good control in A1C. But subsequently, the sensitivity to this goes down. They become more and more casual about everything. Many of the adolescents especially have a lot of problem with the adherence because of the onset of adolescence-related behavioral issues also at the same time. More personal autonomy, rebellious things, this, that, bullying, stigma, body image issues. So it's a very, very tough time for the individuals to navigate through all these problems during this time. And once they reach the age of probably 20, 25, again, they become more mindful about their diabetes management. But achieving euglycemia in children or adolescents with type 1 diabetes is an extremely difficult task. And especially in our country, it has been seen that from the ICMR database as well, that the long-term outcomes of individuals with type 1 diabetes are not so good compared to the Western counterparts. The longevity is less. The incidence of micro and macrovascular complications is much more compared to type 1 diabetic patients in developed countries. And there are a lot of social reasons also for this, because I mean, in the form of lack of access, affordability, resources, everything. So type 1 diabetes is a difficult one to treat. And whenever a child presents with hyperglycemia, and you don't know what the diagnosis could be, I think it's reasonable decision to start the person on insulin, and meanwhile then you evaluate as to what should be the cause, so that you prevent the catastrophic event of diabetic ketoacidosis. Because in pediatric population in type 1 diabetes, almost 80% of them still present with diabetic ketoacidosis in our country, whereas abroad only 20 to 30% of the kids present with diabetic ketoacidosis. Rest are picked up sooner before they have metabolic decompensation based on their symptoms, osmotic symptoms, weight loss, etc. Whereas in our country, because of the lack of awareness, ignorance, not reporting to the doctors after the onset of symptoms, low degree of suspicion, the diabetes is detected quite late, and most of the children present with severe diabetic ketoacidosis. And this also has to be paid attention to. So what I showed to you was a very, very classic scenario of type 1 obese, insulin resistant, and another was type 2 person who was obese and insulin resistant, and another type 1 diabetic girl where the diagnosis was quite straightforward. But in real life, this is not so, because as I said earlier, there can be a lot of overlap because of increasing body mass indices of our kids. Almost 1/3 of the youth with type 1 diabetes are now overweight or obese. So BMI cannot be the sole criteria. Presence of family history is seen more often in type 2, but it can also be seen in type 1. Among patients who present with type 2 diabetes, if the diagnosis is delayed for a long time, and if they have any concurrent stressor in the form of infection, they can actually present with diabetic ketoacidosis. And this we have seen during COVID, when kids presented with multisystem inflammatory syndrome or severe COVID pneumonia, they actually presented with diabetic ketoacidosis. And many of them were actually type 2 diabetics, which was realized eventually, and they are off insulin, just on metformin, with good C-peptide.
Sorry to interrupt you, ma'am. We have a couple of minutes.
Yeah, this less time left. Okay. So, and 10% of the individuals considered to have type 2 diabetes may actually have antibodies. So it's like kind of type 1.5 diabetes or LADA diabetes. And this, how to differentiate, is something that we saw previously. Going further, this was like a 11-year-old who presented with weight loss and osmotic symptoms, normal BMI, HbA1c of 8.8. C-peptide was not very low, not very high. The diabetes antibodies were negative. What is more remarkable or striking is the strong family history. Her mother was diabetic with onset at the age of 22, well controlled on OHAs. And if we draw a detailed pedigree chart, 3 of her aunts as well as 2 of her cousins have diabetes, so indicating some autosomal dominant phenomena going on one side of the family tree. And so as a result, a normal weight patient, autosomal dominant inheritance, diabetes running in families, lack of antibodies, a monogenic form of diabetes was suspected, and the genetics were obtained. And this girl was actually positive for pathogenic mutation in HNF4A, which is responsible for maturity onset diabetes of young, type 1. And these patients are exquisitely sensitive to sulfonylureas, at least in the beginning. So she was switched over to a low-dose glimepiride, and which actually produced quite a good result. So identifying these patients and not blanketly labeling them as type 1 is very important, because 2 of our cousins were given a diagnosis of type 1 and they were on insulin. So there are several genes which have been identified which lead to monogenic diabetes, and they can have various pancreatic, extra pancreatic manifestations, and having unequivocal or undisputed diagnosis of monogenic diabetes actually requires genetic studies, but you can actually suspect it based on the phenotype of the patients. We need to have a high degree of suspicion and keep looking for these in our patients who are actually referred to us as so-called type 1 diabetes. Moving further, 28-year-old came over for significant weight loss, almost 40% of his body weight. He was diagnosed with diabetes 3 years back. His HbA1c was 13%. He stopped his treatment a year ago, never had diabetic ketoacidosis. On inquiry, he does say that he has intermittent episodes of abdominal pain and he has steatorrhea on eating fatty meals. Never had any alcohol in life, and a simple plain X-ray, if you obtain, it's showing multiple big chunks of calcifications all over the pancreas. So this is classic FCPD, or fibrocalcific pancreatic diabetes. So young age, calcifications in the pancreas, no decay, severe hyperglycemia, and involvement of extra pancreatic deficiency or insufficiency. All these are markers of pancreatic diabetes. So this person was started on insulin along with metformin and pancreatic enzyme supplements along with fat-soluble vitamins. So FCPD is more common in South Indians, and it has like some genetic basis also, along with some nutritional factors which may be contributing. And these patients classically don't go into decay despite being hyperglycemic, but because of the prolonged hyperglycemia, they are also at the risk of developing microvascular complications, not though macrovascular complications. Macrovascular complications are more common in type 2 diabetes patients and also patients with type 1 diabetes with advanced age. MODY will have like classic complications over long term. There are also several other endocrine problems which may masquerade as diabetes. And based on the phenotype, it's imperative that we think about them. Diseases like Cushing's syndrome, acromegaly, hyperthyroidism can present with hyperglycemia, pheochromocytomas, drugs that are used for treating endocrine problems. Some chromosomal abnormalities may have type 2 diabetes as one of the prominent features, like Turner's, Klinefelter's, etc. So when we come across youth with diabetes, the diagnosis itself can be a challenge, differentiating various forms of diabetes. Other therapeutic challenges are denial from the part of the patient as well as the family, patchy follow-ups, poor adherence, suboptimal glycemic control, misclassification and inappropriate treatment, and all of them can lead to poor long-term outcomes. So these individuals have to be very diligently monitored. Type 1 diabetic patients, after 5 years of onset of diagnosis or after the onset of puberty, every year they should have certain parameters like monitoring of their nephropathy, proteinuria, foot examination, etc. Type 2 diabetic patients should be monitored right from the onset, because whenever a person has type 2 diabetes, it's considered as it has been there for at least few years. Monitoring of, again, other forms of diabetes is similar to what we do in our patients with type 2 diabetes. So with this, I come to end of my talk. And what I would say is that diabetes is one of the most common endocrine problems that we encounter in our children. And the prevalence of type 2 diabetes is increasing even among pediatric population. The differential diagnosis is wide, and we need to consider the diagnosis of monogenic diabetes, FCPD, or type 2 diabetes in every individual and systematically rule this out. And youth with diabetes are more prone to develop complications because of longer duration of hyperglycemia, more aggressive nature of the disease. That's why it's presented in pediatric population, and suboptimal control. Thank you.
Thank you, madam, for such a very informative session. Only one question from the audience: do we need to do C-peptide and anti-JD antibodies in each patient?
So the C-peptide is something that we do obtain in everyone. So if you have very classic presentations, you need not do, like the one I showed, the type 2 diabetic, 16-year-old, BMI of more than 95th centile, acanthosis. You need not do that. again, like if you have someone like 5-year-old child presenting with diabetic ketoacidosis, no family history, the diagnosis is quite clear. So when you have dilemma in diagnosis, you have somebody who has come with severe hyperglycemia, body mass index is not that high, you see some degree of acanthosis. So to differentiate between the type 1 and type 2, you must do the C-peptide. And again, for monogenic diabetes also, it may be of some help because most of them have fairly okay C-peptide. In patients who have type 2 diabetes, if you think of doing C-peptide, you should wait till the hyperglycemia resolves, or if they have presented with diabetic ketoacidosis, because the pancreatic beta cell function may improve after the hyperglycemia is treated.
Thank you. Thanks a lot. So now I would like to present certificate of appreciation on behalf of IMA to Dr. Sweta Budyal for a comprehensive and elaborate session for medical professionals on approach to a youth with diabetes during online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd February. Thank you, Dr. Budyal. Over to Dr. Archana.
Thank you.
Thank you, madam, for that wonderful session. I think we need to have a very high index of suspicion in children also these days, coming with some specific symptoms. And it can definitely have, a big outcome related morbidity, mortality, all can be assessed secondary to that. And the complications of diabetes are so very well known that unless we have a higher degree of suspicion and we try to find it, a delay in diagnosis is going to have a lot of problem in these patients. So thank you so much for taking this wonderful case-based approach on, diagnosing a youth with diabetes. Thank you so much. Thank you, Ashwini madam, for wonderful moderation. We move on to our next session. I just need a minute. Okay. So gestational diabetes mellitus is defined as glucose intolerance with hyperglycemia with first onset during pregnancy. Patient known to have well-controlled diabetes prior to pregnancy presenting with deranged sugars antenatally also require treatment and monitoring similar to patients with GDM. It is one of the most common complications of pregnancy in today's era and is increasing in prevalence worldwide. It is most commonly seen with advanced gestational age and maternal obesity. In India, the prevalence rate of GDM is estimated to be 10 to 14.3%, which is much higher than in the Western countries. Early diagnosis and management of GDM is essential to prevent the various short and long-term maternal and fetal complications. To talk on this very important topic of gestational diabetes, diagnostic criteria and management, we have with us Dr. Vijay Neglur sir. And to moderate this session, I invite upon past president of IMA Dombivli and senior gynecologist Dr. Neeti Upasni. Over to you, madam.
Thank you, Dr. Archana. Like Dr. Archana said, yes, gestational diabetes is a unique condition in which it raises on our antennae of obstetrician and neonatologist on a high alert because of the risk to mother, the fetus, and the neonate. And we have our own Dombivli doctor, Dr. Vijay Neglur sir, to throw light on this very important topic. I would like to introduce Dr. Neglur sir. Sir is a consultant physician and endocrinologist. He is a director of Dr. Neglur Diabetes Specialist Center, Thane. He is a consulting diabetologist at Jupiter Hospital, Thane. Sir holds various positions, and current position is Fellow of the Indian College of Physicians, FICP, President of NADR, Neglur's Academy of Diabetes and Research, teaching faculty in diabetology, College of Physicians and Surgeons, teaching faculty at Public Health Foundation of India. He is a founder member, Association of Diabetes Educators of India. He has many publications to his credit, some of which are publication in Oxford Textbook of Diabetes Autonomic Neuropathy, publication at RSSDI Textbook of Diabetes on Vitamin D and Diabetes, publication of Awakening Quarterly Magazine for Diabetes since June 2003 till date. Over to you, Dr. Neglur, sir.
Thank you. Thank you, Dr. Upasani, for a kind introduction. And let me share my screen. Can see my screen?
So we can see your desktop screen. Yeah, yeah.
Now, how to enlarge this? Is okay present like this only?
So if you are on your desktop, at the bottom right, there will be a book-like picture. Once you open your presentation, at the bottom right, there will be a small book-like icon. You can just click on that.
I can't find that.
Okay. So that's okay. This is visible, I think.
Yeah, in the interest of time, I think we'll go ahead, right? Okay, thank you very much for your kind introduction. Thank you, IMA Dombivli and the D4 Symposium Scientific Office Bearer for giving me this opportunity to speak on the subject of GDM, Diagnostic Criteria and Management. And we know this is the Time magazine, which looked at how first 9 months shape the rest of your life. And therefore, this is a very important concept of how you take care of patient of GDM so that the subsequent progeny is not affected. David Barker, that you see on the left of your screen, talked about early life to later illness development, origins of the health and disease, was the first man who looked at these patients from the Helsinki heart study, where he saw that those babies born with the less weight at the delivery subsequently developed either ischemic heart disease or diabetes. So therefore, this is a diabetes of two people, the high blood sugar levels, and that causes extra glucose to the baby, and baby also has extra weight, and subsequently the management and the problems of diabetes in future. When we talk of gestational diabetes, is defined as any degree of glucose intolerance with the onset during the pregnancy and is associated with increased fetal-maternal morbidity as well as long-term complications in mothers and the offspring. And this is what actually begins in physiology, that in the early pregnancy, that there's hyperinsulinemia. There's an increased profound response of the insulin secretion because of the hyperplasia and hypertrophy of the beta cells. And this is important because this is basically meant to augment the storage that can occur for the subsequent pregnancy, and the energy demands in the early part of the pregnancy is quite low because there's hardly any linear growth to begin with. And therefore, the initial part of the pregnancy has the hyperinsulinemia with a very low fasting blood sugar, and there is increased glycogen synthesis in the liver and increased deposition of fat in the adipocytes. In the later part of the pregnancy, after 20 weeks, we have the increased levels of the placental hormones, which increases the placental lactogen, the prolactin, cortisol, progesterone growth hormones, which bring insulin resistance. The idea to get insulin resistance is basically to allow the glucose to go to the baby, and the baby gets the glucose as the main fuel for its growth. And we have the accelerated starvation to the mother. So mother has to live on the fuel produced by the beta oxidation of the fatty acids and the ketone bodies. So therefore, there is what is called as the anabolism and catabolism together. And that is called as a facilitated anabolism to begin with, and accelerated starvation subsequently. You can see in this graph, in the initial part of the pregnancy, as you go along, there's increased insulin resistance, which brings in later at the end of 20 weeks. And that brings about excess amount of hypoglycemia. And the idea is to see that the baby gets enough amount of glucose for its growth, and mother lives on the ketone bodies and lipolysis. And therefore, there is a combination of anabolism and catabolism. This is the life course of women with GDM. But you see here, the glycemia increases in the second half of the pregnancy, and it settles down after delivery, and maybe a little later, the sugar might start going up again. And what is interesting to see is the beta cell function, which is decreased in the pregnancy. And as you deliver the baby, the beta cell function remains on lower side. The graph that you see, there has the inclination to lower side because the beta cell function never improve with every pregnancy. And that's why the risk of developing type 2 diabetes subsequent to the pregnancy is also pretty high. Then you have the insulin resistance, which again mounts in the later part of the pregnancy. And as the baby is delivered, the insulin resistance becomes much less or almost less. The pregnancy is a diabetogenic state, and obviously see here. And you can see that there is a resistance to the glucose response by the insulin. And therefore, you can see the graph on top with the brown line showing that the insulin resistance is the key factor for developing hyperglycemia in these patients. Now, the insulin resistance in diabetes in pregnancy is primarily because of the decreased response from the beta cells, and beta cells do not cope up with the insulin resistance because of the inherent genetic defect, and therefore the blood sugar start rising. Along with that, there's also response on the insulin receptors, especially when you look here, there's a decreased ability of the insulin resistance to undergo tyrosine phosphorylation, and the insulin receptor substrate 1 is also expressed less in all pregnant women, and therefore you have the receptor defect and the defect in the beta cells both together to contribute hyperglycemia in patients. What is important is what is called fuel-mediated teratogenesis, in which what you see here is the left of your graph. I'm sorry, this cannot be expanded, but whatever I can show here, that the decreased insulin in the mother, there is increased amount of plasma glucose, and that has the easy access to the baby. And when the glucose enters the fetal circulation, there's increased secretion of insulin, and that itself brings about macrosomia in these patients. What we should remember is that if there is a diabetes to begin with before the pregnancy or a pre-pregnancy diabetes, then there is a damage to various organs, and that results into various defects in these patients, especially the structural defects, either in the brain or in the skull or in the heart. So these defects are usually seen in those patients who have sugar abnormalities before the conception, and those who get GDM, that is at the 21st week of pregnancy, there the defect is only macrosomia, because the organization is already occurred, and the excess glucose brings about these defects like macrosomia. This is pathophysiology of diabetes, which tells us there's excessive insulin resistance and insufficient insulin production, which results into hyperglycemia. And this glucose walks into the baby's circulation, that brings about hypercirculation, hyperglycemia, hyperinsulinemia, and that can result into short-term consequences like macrosomia and long-term consequences like type 2 diabetes in the baby. Let's look at this patient, 33 years old lady. She has 2 miscarriages in the past. She has delivered a baby of 4.1 kilograms. She weighs 81 kilograms, and both her parents are diabetic. What's the risk of developing diabetes? Obviously, it's pretty high. So these are the various factors which makes the risk factor diabetes quite high. More than 25 years of age. People in India, of course, are having high risk of diabetes, obesity, waist circumference more than 80, family history of diabetes, previous GDM, and PCOS are all these indications which makes you susceptible to develop diabetes. What are the implications of this GDM on the baby and the mother? The mother will develop preeclampsia, polyhydramnios, the problem for the operation delivery, perineal trauma, and in the fetus, there can be fetal macrosomia. The birth trauma, prematurity, and respiratory distress syndrome are some of them which are quite likely to occur in the babies delivered to a diabetic mother. And these are the neural tube defects which normally occur if the patient has a preconceptional diabetes. And the sacred agenesis is the most common or the most specific condition, though it's quite rare. And the supplementation of folic acid in the pregnancy at the time of conception is very important to prevent the embryopathy, usually in a non-diabetic population, but has no much effect on the diabetic population. And if you look at the macrosomia, which normally we see in those patients with GDM, where the birth weight is normally 3.5 kilograms in the Indian standards, but for the American College of Gynecology, it is 4.5 kilograms. It causes increased risk of C-section and increased risk of diabetes in subsequent life. Now, when you diagnose these patients, you have two guidelines. One is called the International Association of Diabetes Pregnancy Study Group Guideline, which says that you should do the screening at the 24-28 weeks of pregnancy. You should give them 25 grams of glucose and do 2 hours glucose tolerance test. And the sugars are more than 126, it's over-diagnosed of diabetes. And if you have fasting sugar more than 92, 1 hour more than 180, and 2 hours more than 153, any one value abnormal is diagnosed as the GDM. The Indian DIPSI guideline, which says just one-step test, patient just walks into consulting room and the patient is given 75 grams of glucose and you check the sugar after 2 hours. At the end of 2 hours, the sugars are more than 200 and the patient obviously has diabetes. And if the patient's sugars are more than 140, that she has GDM, and the sugars are more than 120, she has impaired glucose tolerance of pregnancy. The advantage is single step. There's no need to have second visit. It's the least disturbance to the patient's routine activity is quite economical. But what is important is non-fasting OGTT has a low sensitivity in diagnosing GDM. That should be kept in mind. But the interest of the large public, this could be adopted as the easy way of estimation of blood sugar to diagnose GDM. So when patient is seen by you for the first time at any stage of pregnancy, do the fasting sugar. If the fasting sugar is more than less than 92, there is no GDM, and these patients should be subsequently screened at 24 to 28 weeks of gestation. If the fasting sugar is between 90 to 125, the patient has GDM, and is more than 126, of course, the patient has frank diabetes. And the patient who's initially having low sugar, and subsequently when you screen again at the 24 to 28 weeks, use IDA-GSP criteria, and the fasting is more than 92, at 1 hour, 182, 1 hour, 182, fasting is 92, 1 hour, 180, and 2 hours is 153, then you diagnose this patient as GDM. Once you made the diagnosis GDM, your next immediate task is to see the detection should be, of course, always early. What dietary implementation can be done. Physical activity has important role to play, the insulin therapy and the oral medication. The restriction of calories is not important in patients with GDM diabetes because the baby has to grow, and we allow 10 kilograms for the lady to gain weight. Otherwise, another diabetic patient, we tell them to lose weight, but here we don't tell them to lose weight because the baby has to grow. And therefore, we give them 30 to 32 kilocalories per kilogram body weight in the first trimester and subsequent trimester, little excess calories for the growth of the baby. Important to remember is that you should not restrict carbohydrate below 200, because if you restrict below 200, the risk of ketosis is pretty high. So therefore, at least 200 grams of carbohydrate is essential for one, to prevent ketosis, and to see the adequate carbohydrate is taken by the baby. Of course, the fat should be less than 50%, protein should be 1 gram per kilogram body weight, and fibers up to 20 to 40 grams. Physical activity is very important, at least 30 minutes. It has got an important role to play, and therefore that has to be encouraged by every clinician to have adequate physical activity if there are no contraindications. And the contraindications could be low hemoglobin, extreme obesity, smoking on previous preterm delivery, and poorly uncontrolled diabetes, and seizures and thyrotoxicosis are related contraindication for physical activity in these patients. Let's look at this patient who was seen at 23 years old primary, has GDM at 24 weeks of gestation, initiated on a diet, and postprandial glucose increased to 120 and 125, and was there, and then subsequently went to 140 to 160. Here, the next choice after the lifestyle has failed, we have insulin as a treatment of choice. Here, of course, the insulin should be used at diagnosis if the fasting is more than 120 and the post-load is more than 200. And you have to get down the patient to fasting below 90 as per DIPSI criteria and below 120, 2 hours post-prandial. These are the important cutoff values. They're different from the non-pregnant patients. Here, the most strict control is very important. As per the HAPO study, the lower you control the sugar, the better the outcome of these babies. Any insulin can be used, but The degludec and glargine are still not indicated, though there are some anecdotal evidence they can be used. But as per the guidelines, glargine, degludec are not recommended to treat patients with GDM. Regular insulin can be used. NPH is also quite safe. In the rapid-acting insulin analogs, lispro-aspart can be used. Premix insulin can also be used, and long-acting insulin, especially detimir, can also be used. Remember here, the major contribution is the prandial sugar because they have insulin resistance. Fasting sugar is usually normal, and the requirement of insulin is normally single digit. It's very rarely the patient requires more than 10 units of insulin, depending on the patient's blood sugar, unless, of course, the patient has pre-existing diabetes. It's important to realize the requirement of the insulin will keep on rising. So therefore, the monitoring is very important. This has to be emphasized and explained to the patient till the 35th or 36th weeks of gestation, the requirement of insulin will go up. And when the placental growth stops, the requirement of insulin goes down, and the patient might not require much insulin at all unless she has the pre-existing diabetes at the time of delivery. It's important also to see that the growth chart will be kept properly, and the growth chart, especially of the abdominal circumference, is important. If the abdominal circumference shows excess growth, then there is a disproportionate acceleration, and therefore this patient requires a tighter glycemic control. This is another way of checking whether the patient is taking proper treatment or not. So look at these growth charts, and growth chart is an independent parameter to tighten the diabetes control. Excuse me. Metformin has a possible concerns because it significantly transfers across the placenta. Currently, metformin is not accepted as first-line treatment, and 50 to 60% of the patients who are on metformin will require insulin therapy. Only patients who have pre-existing PCOS should continue metformin till the first trimester of pregnancy, and then subsequently will stop it. The mixed study, which looked at 751 women with GDM, randomly assigned to 20 to 33 weeks of gestation to receive metformin. However, more evidence is needed before metformin can be recommended as the first-line agent for diabetes in pregnancy. And as of now, the FDA has kept category B for metformin in patients with diabetes. And of course, metformin is slowly losing the ground, even in the general diabetic population. It is no more enjoying the first position as it did till until 2022. This current guideline has removed metformin as the first line of treatment, even in the non-pregnant patient. Glibenclamide, there's some data from Langer et al. Looking at 404 women with GDM who received either glibenclamide or insulin and showed much good results. There was no significant difference so far as the macrosomia, complications in lung hypoglycemia, and admission to neonatal ICU. But the glibenclamide was not detected in the cord serum by any infant. Maternal hypoglycemia should be looked for, of course. But then the recent evidence suggests that the use of glibenclamide in pregnancy is associated with higher risk of adverse outcomes. Therefore, it cannot be used or cannot be recommended as a therapy. And therefore, it's better to avoid all the oral drugs treatment for the patients with diabetes in pregnancy, except metformin if the patient has a pre-existing PCOS. The postpartum assessment is also important. The moment the baby is delivered, the mother goes home, and then the diabetes story is forgotten, especially in GDM. It's important that we should emphasize that 6 weeks later, she must undergo OGTT with 75 grams of glucose. It is the risk of developing diabetes is pretty high next 5 to 10 years, and therefore lifestyle modification based on the patient's OGTT report is important, and this could be a primary prevention of diabetes, a very important window we should explore, especially in such patients who have GDM, and that OGTT has to be emphasized by every clinician. To summarize what I said so far last 20 minutes, there's a new criteria for GDM are likely to identify more women with fetuses at risk. The level 1 evidence from 2 randomized controlled trials say that the treatment of GDM is beneficial. The tighter the blood pressure, blood sugar control is the key to reduce the outcomes, and the role of routine OHA therapy requires further evaluation and a long-term follow-up of mothers critically in 50% of the risk of type 2 diabetes. And therefore, before I close, this is a very important statement. Carrying a baby is the most rewarding experience a woman can enjoy. Only time in life when you will fall in love with someone you haven't met is the pregnancy. With that, I conclude my talk. Thank you very much for the patient listening.
Dr. Niti, you'll need to unmute yourself.
Yes. So sorry. Thank you, Dr. Neglur. The last line which you said was really, really beautiful line and it's true to for every mother. Thank you very much for simplifying such a complex topic. I think we have time for one question. Was there any question in chat box for Dr. Neglur, sir? Archana? I could not see.
I
Sir, there is,
noted here.
Sir, there is one question between metformin and N-acetylcysteine, which is a better drug?
N-acetylcysteine has no effect at all on the glycemic control. And metformin, of course, is used in patients who had PCOS and the first trimester of pregnancy continue metformin. The idea of continuing metformin is not that it reduces insulin resistance, but it reduces the PI1, plasminogen activator inhibitor, which is a cause for the pregnancy loss. And therefore, we must emphasize the use of metformin. Otherwise, no guidelines recommend, but the Indian guidelines, the Indian government guidelines recommend the use of metformin in pregnancy. I'm not aware of L-cysteine in patients of diabetes. What is its role? It could have role in preventing the surfactant deficiency. Therefore, the respiratory distress syndrome can be prevented. That could be a possible role, but I don't think that has any role to play so far as the glycemic control is concerned. I'm not aware of any other mechanism or many other use of the this molecule for the control of diabetes.
Okay, thank you, sir. IMA Dombivli likes to present a certificate of appreciation, and I'd like to read the certificate. Certificate of appreciation is presented to Dr. Vijay Neglur for comprehensive and elaborate session on gestational diabetes, diagnostic criteria and management during online D4 Symposium, Decode, Diabetes, organized by IMA Dombivli on Friday, 3rd November 2020. Thank you very much, sir, and over to Dr. Archana.
Thank you. Thank you very much. Thank you.
Thank you, Neglur sir. It was a pleasure to listen to you as always. A wonderful session, and thank you, Dr. Niti Upasni, for that wonderful moderation. Moving on to the next topic, we are happy to have with us our next speaker in the audience. Before we move on to our next session, once again, I remind everybody regarding the MMC credit points. I hope everybody's put their attendance in the chat box. The attendance will be verified. And the Google form filling is compulsory. So anybody if has registered but not filled the Google form, please see to it that you have filled the Google form. And the MMC credit points will be directly uploaded on the MMC website. The whole process takes about 1 month. And the hard copy of the certificates will not be issued. So moving on to the next session. We have encountered on many occasions, or we have seen on many occasions, the various emergencies which the diabetic patients may encounter, notably hypoglycemia, hyperglycemic complications like hyperosmolar hypoglycemic complications, diabetic ketoacidosis. These patients have an increased risk of infection, sepsis, and related complications. They have higher incidences of stroke, MI, and other emergencies. And to speak about the medical emergencies which these diabetic patients face, we have with us Dr. Akshay Challani. And the moderator for this session is Dr. Rashmi Sonar, who's a consultant physician having her own City Care Multi-Speciality Hospital at Dombivli. Over to you, Dr. Sonar.
Thank you, ma'am. After going through the basics of diabetes mellitus, its complications, its types, now we have the topic of diabetic emergencies. It is a very important topic as diabetic emergencies may be fatal. So for the same topic, we have Dr. Akshay Challani sir, who is the renowned critical care specialist in Navi Mumbai. He is designated as medical advisor and critical care expert at Apollo Hospital, Navi Mumbai. He is the chairman of Indian Society of Critical Care Medicine, Mumbai, and he is also the chairman of West Zone EC, ISECM National. So, welcome, sir. Now over to you, Dr. Akshay Challani, sir.
Yeah, thank you, Dr. Archana and Dombivli IMA. Is my screen visible?
Sir, not yet. You started screen sharing but can't see your PPT.
Can you see screen? No.
Yes, sir, it is visible now.
Is it the first slide visible?
Yeah.
Yeah, and thank you, Dr. Rashmi, Dr. Archana, for giving me this opportunity. At any point of time, suppose my video or voice is cracking, I'll just put my video off if you permit. I'll just start. So I'll just talk about the diabetic emergencies. As we know, in next 20 minutes, I'll just talk about these 4 dire diabetic emergencies. And as a clinician, as a practitioner, what exactly we need to do in first 20 minutes, I'll just talk that. So what by and large, we come across the most common diabetic emergency, diabetic ketoacidosis. The second one is, as rightly said, hyperglycemic hyperosmotic state. The name itself suggests actually there is a hyperglycemia, there is uncontrolled sugar, but there is no ketosis. So what is the difference? What we need to know, why there is a difference, and how the management differ, how the prognosis differ, we'll discuss. Second, there is a new term now in last few years, we are seeing this euglycemic diabetic ketoacidosis. So what exactly it mean? Sugars are normal, but the patient has a ketoacidosis. So what is the reason? Right now, you see in last 4 to 5 years, there are multiple SGLT2 inhibitors has a potential to cause this entity. So we'll just talk about this. But the worst, I think, is a hypoglycemia. So these 4 medical emergencies in the context of diabetes we'll discuss. But first, I like to discuss this hypoglycemia. So what exactly is a hypoglycemia? Suppose you see a definition of hypoglycemia in the medical literature. What exactly? Whether it is below the 70 number or below the 55 number. So by and large, if you see there are multiple numbers mentioned at everywhere. But if you follow the AHA guideline, American Heart Association, who deal with the other than heart issue and the stroke issue, whenever the sugar goes below 70, whenever the sugar goes below 70, they label this patient as a hypoglycemia. But generally, we observe these symptoms significantly when the sugar goes below 55. So I want you to remember this Whipple's triad, you must have known, but I'm just re-emphasizing. Whenever you see a patient with the hypoglycemia, sugar less than 70, symptoms typical of hypoglycemia, you know the patient has a palpitation, discomfort, sweating, altered sensorium, or not able to talk properly. You think of hypoglycemia with the background of setting of diabetes or other comorbid issues. And you check the sugar, you do the RBS, you do HJT, and you found that the sugar is less. So the third thing which is in this criteria is the improvement of the symptoms with a rise in the blood glucose. The moment you see that sugar is dropped down to 40 or 50, you give a dextrose, either 50 gram, 25 gram, and the patient does improve. So you label this patient as a hypoglycemia. So this Whipple's triad, symptoms of typical low sugar, biochemical evidence, or you check the sugar in the lab, the sugar is down, and once you give dextrose, the patient improves. This is very easy to say, but please remember, there are few conditions. If the patient is not diabetic, which are the things where you will feel that the patient has a low sugar, but the patient is not diabetic? So which are the things you will try to explore? The see whether there is a history suggestive of any alcohol intake, chronic kidney disease, hepatic failure, congestive cardiac failure can cause low sugars. And by and large, when we deal with the sepsis and septic shock, there is a significant consumption of the hormones. You can see the low sugar. What I meant to say, if a diabetic patient comes with the hypoglycemia, you know, until proven otherwise, the diagnosis is because of either insulin-induced or OH-induced. But if you see a patient who is a no history suggestive of diabetes and he comes with a low sugar, you please rule out whether there is alcohol intake, whether it is a systemic failure, heart, kidney, liver, or there is a sepsis. Other thing, there is unexplained hypoglycemia, hyponatremia in the ICU. Generally, we see the patient does not respond to anything. no diabetes history, but the sugars always remain low, the sodium always remain low, you please rule out the cortisol insufficiency or adrenal crisis. You, particularly when the patient has a septic shock, patient has a tuberculosis, there is a chance that the patient has adrenal has gone haywire. Second thing, hypopituitarism. This is a all hormone goes down, or sometimes accidental or malicious. You take a insulin by mistake and you land up with the problem. I want you to remember all this. This is the next important slide basically. Now you are sitting in the OPD, the patient comes, or you are sitting in the hospital, the patient comes, the sugar has gone down significantly low. Now I am just assuming that the sugar is around 3450. What next? You see, you come to the casualty, you see this, your RMO or somebody calls doctor, the sugar has gone down. I have seen the patient has come to the casualty. The patient is unconscious and the sugar is gone down 40. So what next? The important thing what I want to reemphasize and remember you, once you diagnose the hypoglycemia, you give a dextrose. Either you give 5% dextrose, 25% dextrose, 50% dextrose. Don't wait for a long time. Immediately you check the sugar. The idea what I'm trying to tell, don't keep the state of hypoglycemia for a long time because it will cause a brain damage. So the moment you found that the sugar is low, give a dextrose. Still sugar is 34, give a dextrose, give still sugar 34. Immediately after 1 minute, immediately after giving, keep on checking the sugar till you found the normal sugar. That is the message what I want to give in the hypoglycemia. So generally, I have seen, not seen, but I have come across few patients. What happened? The doctor has diagnosed the hypoglycemia. He put on the 5% dextrose. He come after half an hour. Still the sugar is low. So we can't afford to keep that patient in the hypoglycemia for half an hour because it will create a problem in the brain. It will cause a significant brain damage, which probably is irreversible. So my suggestion, don't keep that hypoglycemia for a long time. Check the sugar immediately after giving dextrose and document that the sugars are normal. In spite of that, in spite of your efforts, the patient is not improving, you can think of other things like glucagon or steroids. Now the other issue, the patient is doing well from last 2 months, he's taking the same OHA, but now comes into casualty or comes to your OPD and the sugar has significantly gone down. So you just need to find out why this OHA so many days is doing reasonably okay job. Suddenly why this OHA or this insulin is creating a problem. So what you need to do, just stop the all. Whenever there is a OHA induced hypoglycemia, you are pretty sure that this is because of OHA induced. Please stop that OHA first of all. Next 2 to 3 days, you need to monitor him or her very carefully because the effect of the OHA might long for 5 or 6 days. Temporarily, when the sugars are going more than 200 or 300, you can start the insulin. But please remember, there must be something wrong somewhere is going. Either the patient is not eating well, or there is a sepsis, or there is an infection, or there is some issue because so many days, suppose the same medicine is doing wonderful job, now why suddenly it's happened? So whether the sepsis, you're developing tuberculosis, or the brand is changed, or the insulin is changed, what you need to look at very seriously and carefully. So hypoglycemia, please remember, don't allow it to linger it for a long time. Immediately give a dextrose and check the sugar. Now another diabetic emergency, you will always come across these 2 things. One is diabetic ketoacidosis and one is hyperglycemic hyperosmolar state. Basic thing, the name itself suggests diabetic ketoacidosis and hyperosmolar. There is no acidosis in HHS. So how do you diagnose? One is, in both the conditions, the sugars are pretty high. So US urinary sugar in the conditions are high. But when you take for the plasma ketones or when you check for the urinary ketones, significantly high in the diabetic ketoacidosis, but significantly low or almost null in the HHS. Why it's important, I'll come to that point. So DK, there is absolute insulin deficiency. There is no insulin at all, or very inadequate insulin. That is the reason the patient landed in diabetic ketoacidosis. In HHS, there is a relative insulin deficiency. So there is some insulin to work on the free fatty acids and all that. So it will not cause ketoacidosis. But DK, there is no insulin at all. You do a ABG in the casualty, the pH is less than 7.3. There is a acidosis. Think of DK. If the pH is more than 7.3, sugars are uncontrolled, no acidosis, you think of HHS. Same time, you see the bicarbonate less than 15, you think of diabetic ketoacidosis. Bicarbonate more than 15, you think of HHS. If you can measure, well, osmolarity in diabetic ketoacidosis in between 300 to 320, but in the HHS, it is around more than 320. I want you to remember DK, DHHS. Just remember DK, there is a significant insulin deficiency. HHS, there is a relative insulin deficiency. In diabetic ketoacidosis, sometimes you see the patient is fully conscious. ABG, you do metabolic acidosis. But HHS is very unlikely that the patient is fully conscious. Either he or she is stuporous or coma. But please remember, diabetic ketoacidosis history is 1 or 2 days. HHS history is for more than 1 week, 2 weeks, and 3 weeks. So please remember, diabetic ketoacidosis onset is 24 hours. Onset, always remember there is some precipitating cause. Whenever you see a diabetic ketoacidosis, you need to understand or ask yourself why this patient landed up in the diabetic ketoacidosis. Whether it is infection, pneumonia, UTI, or meningitis, whether there is a myocardial infarct, cortical venous thrombosis, or stroke. Pregnancy precipitated the decay, as the previous speaker already mentioned. Drugs, sometimes for collagen vascular diseases, you start steroids or some medication which has a potential to precipitate your sugar issues. You think of why this drug is creating a problem and causing diabetic ketoacidosis. And non-compliance, important thing, patient forgot to take insulin, or the 2 days the stock is over, the patient landed in diabetic ketoacidosis. Symptoms: classical nausea, vomiting, thirst, and breathlessness. Differential diagnosis when the patient comes to you is acute abdomen. Sometimes you see the pancreas amylase lipase is too high. You think of diabetic pancreatitis, but then you realize the sugars are more than 400 and the pancreas workup is normal. So you think of that. Starvation ketosis and alcoholic ketoacidosis mimic like diabetic ketoacidosis. So please remember that. On examination, when the patient comes with tachycardic, tachypneic, and lethargic, patient comes to you very tachypneic, rate is around 34, 35. Your cardiac workup is normal, heart workup is normal, lung is normal. Patient, the absolute chest clear. You think of only 1 or 2 conditions. One is this diabetic ketoacidosis or pulmonary embolism. So please remember, diabetic ketoacidosis first presentation, maybe in the casualty with breathlessness, and you only found that the sugars are 700 or 800. How do you manage management? It is very easy. You confirm a diagnosis, plasma ketones are positive, think of diabetic ketoacidosis. Plasma ketones are negative, the sugars are very, very high, you think of HHS. Check the RBs, do the EBG, rule out the acidosis. Now, which patient you will send to the floor, which patient you send to the ICU? Everybody you can't send to the ICU. No, neither everybody you can't to send to the floors. Altered sensor definitely goes to the ICU. pH, if the patient has, you are not very clear, sensor not very good, or whether I should keep him ICU or floor. If the pH is less than 7, you don't have any option, send him to the ICU. Start initially intravenous fluid, whichever you want to start, whether it is normal saline or ringer lactate, you start that, but please don't start starch, don't start dextran, don't start starch or this colloid material, the colloid substance dextran. Once the sugar reach in between 150 to 200, you need to make it 5% glucose plus 0.45 normal saline. Whenever you start insulin for diabetic ketoacidosis, please remember you can't start long acting. You need to start the short acting insulin. How much time will you continue till the acidosis is there? You need to continue the short acting insulin IV infusion. Please remember that. Sodium, I want you to remember, if diabetic ketoacidosis is there and if sodium is normal, the patient is bad. Patient is very significantly dehydrated. Because of hyperglycemia, you get a pseudo hyponatremia. Normal sodium with diabetic decay, not very good prognosis. Remember, potassium, always try to keep more than 3.5, because whenever you start insulin, it will shift your potassium in the intracellular space. So you need to be very careful, otherwise arrhythmia will happen. Long-acting as insulin, when you start the long-acting insulin, once the patient start eating, you need to start the long-acting insulin. And please remember, suppose now the patient continues 2 or 3 days on the intravenous insulin, and now you want to do the subcutaneous. So right now, suppose it is 4 o'clock. 4 o'clock, you give the subcutaneous insulin, and 5 o'clock, you stop the intravenous insulin. Because if you don't overlap, again, you see that 2 or 3, the patient is doing reasonably okay, and suddenly now again the decay happens. So you need to overlap it very carefully. When will you give bicarbonate? There are clear-cut guidelines. Unless and until the pH is less than 7, don't give bicarbonate in the diabetic ketoacidosis. Magnesium phosphate, you need to correct accordingly. Last, this mortality as per the literature is less than 1% in diabetic ketoacidosis. Please remember, nobody less than 1% should die because of diabetic ketoacidosis, because management is very, very easy and it is as per the SOP. So diabetic ketoacidosis, I want you to remember IV fluids, insulin, and no mortality. Now the patient you want to discharge, or once patient reasonably does well at home, in the hospital, and you want to discharge, what will you do? Ask the patient to monitor the sugar at home. And when he will do the urinary ketones, not every day he can't do, not possible. Whenever the random sugar more than 250, he has to be alert, he has to be vigilant. That point of time, ask him to drink a lot of water, you do a proper hydration. That point of time, when the urine ketones become positive with the background of diabetes, please tell them to increase the insulin or change the plan or change your doctor. Not change, you see your doctor. Now coming back to this HHS, basically you see this patient mostly in the elderly patient, the long-standing history, several weeks of history. Patient comes in the casualty or in the hospital with mental confusion, lethargy, coma, stroke, or myocardial infarction. Two things: there is a relative insulin insufficiency, there is no acidosis, so there are no ketones. The treatment for HHS is IV fluids, and insulin. Need to give IV fluids, either normal saline or either link lactate. Don't give starch, don't give dextran. Please remember, whenever you see diabetic ketoacidosis, there is always some triggering factor. And by and large, until proven otherwise, whenever we talk about the chest pain, until proven otherwise, this is a coronary syndrome. So same thing in HHS and diabetic ketoacidosis. Until proven otherwise, there is either infection or some stroke or stroke, infection, myocardial infarct, or thrombosis. So please keep a very low threshold to start antibiotic, or make enough attempt to diagnose infection in the diabetic ketoacidosis and HHS. Here another thing, rule out myocardial infarction, stroke. This mortality is more than 50%. Please remember, in HHS, in diabetic ketoacidosis, the mortality is not acceptable. It is more than 1%. But in HHS, as per the literature, the mortality is more than 50%. So you need to be very vigilant when you are treating HHS. Other things, what we see, the euglycemic diabetic ketoacidosis. This is uncommon life-threatening emergencies. EKD, that is euglycemic diabetic, name itself suggests, is a decay diabetic ketoacidosis in which the glucose are normal. It can seen in both the types of diabetes. Now, why it happened? Generally, in last few days, we are seeing this is because of these molecules like canagliflozin, dapagliflozin, and empagliflozin. Patients who start to do some low-calorie intake, or they do starvation on the top of this, they take this medicine, they will land up in this situation. The triggered by infection, and whenever we want to do any surgery, those patients who are on SGLT2 inhibitor, at least 24 to 48 hours, you need to discontinue this medication. If you are doing some marathon, ultimately, what suppose you are keeping yourself starved, or you planning to take low intake of calories, please discontinue these medications, because it has a potential to cause this diabetic ketoacidosis. How this patient will present in the casualty: tachypnea, restlessness, and inability to eat. Subtle presentation. So how do you treat this EKDA? Stop the inciting agents. The moment you see this euglycemic diabetic ketoacidosis, you ask the history proper. Once these patients are on these molecules, you need to stop this immediately, as early as possible. Again, treatment is IV fluids, You need to give IV insulin infusion in this group of patients in spite of normal sugars. In spite of you need to give dextrose in spite of normal sugar. You need to give insulin to correct the ketoacidosis. I think that's all from my side. Coming to last slide, key points. When you talk about the diabetic emergency, there are only 4. There are few far there. The 4 are important: diabetic ketoacidosis, HHS, hyperosmolar hypoglycemic state. Other is euglycemic diabetic ketoacidosis and hypoglycemia. All 4 are worst, but the worst I feel is a hypoglycemia. Once you develop a hypoglycemia, need to correct it, document it till the sugars are normal, keep on giving the dextrose. You have to be alert when the patients you see of hypoglycemia. If he is OHA induced, keep in the hospital or keep a monitor for a long time. DK and HHS, always there is a precipitating factor in the form of infection, stroke, or something like that. Start a insulin and IV fluids. Once the sugar are run between 150 to 200, shift from 0.9 normal saline to 0.45 normal saline and the dextrose. Keep on monitoring the sugar, and when they go home, need to explain them very methodically. Whenever at home, when the random sugar goes more than 250, check the ketones. That point of time, contact your doctor, increase insulin or increase the IV fluids. That's all from my side. And thank you, Dombivli IMA, and thank you, Dr. Archana and her team, for giving me this opportunity to talk on this topic.
Thank you, sir. Thank you for your nicely presented, informative, and in-time session, sir. So I request now audience to ask the questions. There are 2 ways. Either you can raise your hands or you can write it down in the chat box. And for the same time, sir, I request you to be in audience, sir.
Yeah,
Okay, I think there are no questions. We can move ahead, Dr. Rashmi.
Okay, fine. Thank you, sir. Thank you for your nice lecture, sir. So on behalf of IMA Dombivli, sir, I would like to present the certificate of appreciation for the comprehensive and elaborate session for medical professionals on diabetes emergencies during online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd November 2023. Thank you, sir. Now hand over to Pateman.
Thank you, Dr. Chalani, for that wonderful session. I think these are like quite commonly, fairly commonly seen diabetic emergencies, and you have really covered them well. Thank you so much for that session. Thank you, Dr. Rashmi. And I think let us move on to the next session. I think as Dr. Chalani rightly mentioned, he mentioned about surgery. He mentioned about, somebody who's running marathon. So similarly, there are certain situations where your sugars may fluctuate. So how do we handle the sugars in diabetic patients who are facing certain special situations? It may be illness, it may be travel, they may be exercising, running marathon, undergoing surgery. Somebody is a severely alcoholic patient, they may be having some drug usage, they may be undergoing some immunization, people undergo fasting, Ramadan. So how do we handle diabetes in certain special situations? And for this, we have with us Dr. Aniket Inamdar, who's going to be speaking on handling diabetes in special situations. To moderate this session, we have Dr. Meena Pruthi, who's a consultant physician. Her expertise is in echocardiography and color Doppler studies, and she has 23 years of private practice at Lifeline Hospital and Diagnostic Center at Dombivli. She's past president of IMA Dombivli. Over to you, Dr. Pruthi.
Thank you, Dr. Archana. A warm welcome to Dr. Aniket Inamdar. Dr. Aniket is a consultant physician at Samarpan Clinic, Umarga, India. He has received the first prize in oral research paper presentation at the annual conference of RSSDI 2020, has been awarded the Distinguished Education Award in Asian Pacific Society of Respirology 2021 World Congress, and has been awarded the ACP India Chapter Educator Award in 2023 for the outstanding contribution to clinical research. Dr. Inamdar has presented more than 33 original research papers at international conferences and has presented a research paper on the harmony of breath and mind at the International Yoga Conference at Kanyakumari in 2020. Over to you, Dr. Aniket, to please enlighten us on handling diabetes in special situations.
Thank you, Meena ma'am. And I really thank IMA Dombivli for inviting me for this wonderful D4 symposium. Let me share my screen. Ma'am, I'm not able to share my screen. I think...
Sir, you are a co-host. You should be able to share it at your end.
Just a minute. Can you see my slides now?
Yes, sir. If you can just make it full screen.
Yeah.
Yes.
Am I audible?
Yes, sir.
Thank you. Thank you. So we will now see the situations where we need to manage diabetes in a different way. So these are the very special situations like fasting, feasting, when we are traveling, and during surgery, and when we are being given steroids. So these are the situations where we need to be very careful about managing diabetes in a very different way. So diabetes affects all aspects of life in many different ways. And it is not the primary cause, but it can have a significant impact on other medical conditions and can magnify the consequences. So it is very important to consider the relationship between the diabetes and various special situations like fasting, during travel, or during the surgery. So first we'll talk about the fasting. So fasting and feasting is a very common practice observed all over the world and from the time immemorial, and because of so many varied reasons such as traditional and cultural reasons. So we Hindus fast during Navratris, and our Muslim colleagues, they observe the fast during the holy month of Ramadan. So amount of food and fluid intake are markedly altered during these phases, and patients with diabetes are more prone for higher risk of complications such as hypoglycemia, hyperglycemia, decay, etc. So we need to risk stratify the patients, which is very important. those patients who are observing the fast. So the category with a very high risk, this should be always kept in mind. So patients with severe hypoglycemia, with DKA or with HHS recently in the last 3 months prior to the fasting, especially before the Ramadan, and history of recurrent hypoglycemia, hypoglycemic unawareness, sustained poor glycemic control, patients who are on dialysis, acute illness, gestational diabetes with insulin, pregnancy, and type 1 diabetic patients. So these patients are very high risk of complications if they are observing the fast. In the high risk group, moderate hypoglycemia, renal insufficiency patients, patients with old age and ill health, and patients living alone and who are treated with the multiple insulin injections. So these patients are again at a high risk when they are fasting. And very low risk patients are which are very well controlled diabetic patients and with diet or alone with metformin or other OHAs. So very high risk. So we should always be very mindful about these patients who are observing the fast with a high risk category. So again, what are the complications that one can encounter? Hypoglycemia because of fasting, prolonged fasting, hyperglycemia because of feasting immediately after the fasting, and dehydration because a lot of patients, especially in the Ramadan, they observe a very restricted fluid intake. So that can lead to dehydration, and ultimately hyperglycemia along with dehydration can ultimately land up you in diabetic ketoacidosis. So there are multiple factors that can be responsible for the development of diabetes complications during the fasting. The first is the fast itself. The second is the drug, that is OHA, and the third is the patient. So duration of the fast is again important. Longer the duration of fast, again, more chances of complications will be there. The more fluid and restriction will be there, more chances of dehydration will be there. And the frequency is more, then again, the complications are more. The drug, like hypoglycemic potential. So OHAs, all OHAs have, almost all OHAs have hypoglycemic potential, but especially the sulfonylureas. We should be mindful of usage of sulfonylureas during the fasting. Dehydration potential, SGLT2 inhibitors can lead to dehydration because of glycosuria. And that can again precipitate into severe dehydration and can precipitate into decay also. Acarbose like drugs like alpha glucosidase inhibitors, they have significant GI upset potential that again can induce severe complications. And the patient itself, like elderly and very frail patients, patients who have uncontrolled diabetes, and those illiterate, those patients who are very illiterate or inability to self-monitor, and if they are observing the fast, then we should be very careful about complications that can arise during these fasts. So how do we manage diabetes during the Navratris? So we need to frequently do the self-monitoring of blood glucose, because fluctuations in blood glucose are comparatively more during the fasting days, and it helps to improve the it helps us to detect the hyper and hypoglycemia. The problem solving and reducing risk, how we can do that. So we should do a pre-Navratri medical checkup, continuation of medications and insulin as per the consultation with the diabetologist. And we need to recognize the signs and symptoms of hyperglycemia, hypoglycemia, and dehydration, which are very common complications during the fasting. And we need to timely manage any of these complications. And whenever the medical help is required, we have to immediately seek it. And we need to terminate the fast if the blood glucose falls below the 60 or it rises above the 300 milligram per deciliter. So hypoglycemia should be immediately treated, and fasting should be discontinued. And being physically active, again, carry out day-to-day activities, while we have to limit the excessive physical activities that again can lead to severe dehydration and hypoglycemia. So managing diabetes during Ramadan, so a lot of guidelines now, they recommend that 7-point sugar checking, like first in the night, then again at the time of sunrise, then again in the morning, at the noon, then afternoon, at the sunset, during the time of the iftar, during evening and at the night time. So 7 times multiple, you need to check your sugars very frequently. So how do we adjust the dose of insulin during the Ramadan? So if the basal multiple daily insulin with basal bolus is there, so we need to remember that basal insulin should be decreased by 30 to 40%, and that should be taken at the time of iftar. And if the patient is on basal plus analog insulin, then the suhoor, the morning dose, should be reduced to 30 to 50%. Skip the pre-lunch dose, iftar dose, to be adjusted at the according to the second post-hour blood glucose that we are monitoring every day. And coming to the conventional insulin plus basal insulin, so NPH insulin, you need to continue that same dose, but take it after iftar and suhoor. Basal insulin plus conventional insulin, regular insulin to be continued. The suhoor, the early morning dose should be reduced by 50%. Skip the pre-lunch dose, and if the iftar dose to be continued unchanged. If the patient is taking premix once daily, then take it up after iftar without changing any dose. And if he is taking twice daily premix insulin, then take it after iftar and suhoor. But the suhoor dose at the early morning dose should be reduced by 50%. And if the patient is on insulin pump, then you need to adjust the dose. You need to, at least 15 days prior to the Ramadan, you should go to the your care provider, and you need to adjust the insulin pump rate. So lifestyle modification is very, very important. So we need to attend the pre-fast counseling and learn the warning symptoms of hypo and hyperglycemia prior to the beginning of the fast. So strict adherence to the diabetic diet is very important. Take medication very regularly as per the instructions by the doctor. Do not overeat after the fast is broken, and minimize eating sweets and fatty foods. Record the weight daily. This is very important, because if any change in weight more or less than 2 kgs, then you need to immediately seek the medical help. If any complication occurs, break the fast immediately and seek the medical help. Patient and family should be aware of the potential problems and alert them on their doctor's numbers and all the emergencies. And frequent blood glucose monitoring is very, very important. Exercise, normal levels of physical activity is recommended, but you need to avoid the excess physical activity that can lead to hypoglycemia and dehydration. So breaking the fast, if the blood glucose is less than 70 or more than 300, the fast should be broken. And after breaking fast due to hypoglycemia, patient should consume little more amount of fast acting carbohydrate diet. Coming to the medications, patients with insulin and sulfonylurea should be very closely observed by the hypoglycemia. SGLT2 inhibitors should be very closely observed for the dehydration and the risk of euglycemic decay, because in elderly and frail patients, SGLT2 inhibitors can worsen the scenario. And dose modification as per the risk group, as I already mentioned. So what about the OHAs? So if the metformin is there in the Ramadan fasting or during Navratri also, if it is once in a day, if you are taking once in a day, then take it after the iftar dose. And if the twice a day the patients are taking, then take it after the early morning suhoor and iftar, and you can continue to take at the same time. Whereas the sulfonylureas, if the once daily dose is there, that should be taken at the time of iftar. And if the twice, then the morning dose should be reduced to half. DPP4 inhibitors, no need to change the dose. SGLT2 inhibitors, no need to change, but keep in mind that they can cause dehydration and decay. So very important to ask the patients to drink plenty of water if the patients are on SGLT2 inhibitors. Pioglitazone, no need to change the dose. And if alpha glucosidase inhibitors, again, there is no need to change the dose. I have already talked about the insulin, that how to manage the dosing during the fasting. Structured diabetes education is very, very important for the patient with diabetes along with their family to improve the adherence and to minimize the complications during the fasting. Patients with diabetes should break the fast if the blood glucose is above 300 or below 70. Patients with type 2 diabetes can undergo fasting safely. However, the frequency and dose of medications need to be adjusted or modified. Metformin can be safely used during fasting. However, some dose modifications is necessary. And hypoglycemia, again, is a very major concern with the sulfonylureas. However, among the sulfonylureas, glycoside is having the lowest risk of hypoglycemia and severe complications with a very higher glycemic efficacy. So glycoside can be very widely used in Indian population during the fasting period. DPP4 inhibitors, you can very well use them without any dose modifications. In case of SGLT2 inhibitors, you need to use them cautiously, especially the elderly and frail patients, because of volume contraction and infection. Pioglitazone and alpha glucosidase inhibitors can be safely used. Only need to keep in mind the weight gain and the gastric upset with these kind of class of drugs. GLP-1 receptor analogs can be safely used during the fasting because of their weight loss effect and low risk of hypoglycemia. Now coming to the second special situation, that is travel. So we all love travel, but travel can cause certain complications with the patients with diabetes. So traveling poses challenges in terms of less or more physical activity compared to the usual physical activity, because of skipped meals or delayed meals, because of changing the time zones in overseas travel, because of infection and trauma during the leisure or religious activities, and limited access because of limited access to the healthcare facilities. So diabetic individuals should undergo a proper medical evaluation at least a month in advance before beginning of their trip, because that person is exposed to unfamiliar destination, and you need to inform, you need to take a detailed information about the climatic and environmental conditions of the destination, because that is very, very important, because extremes of temperature may have deleterious effect on the patients and may degrade the medicines. Availability of medicines again is of limited, because some countries where there is very limited medicines are available with a different generic names. So availability of medicines, use of blood glucose measurement and insulin concentrations may be an issue if you are going some exotic places. Individuals must carry a list of all medications with generic name and their dosages, and medicines should be carried extra medicine should be carried in a hand luggage, not in a check-in luggage. So health insurance is a must, and patients should be immunized with vaccine preventable diseases like COVID-19, influenza, pneumococcal vaccines. So these are very, very important if you are traveling. Airport security requiring the patients going through body scanner should be careful, because pumps and CGMs can undergo radiation-induced malfunction. So we need to keep this in mind. And during air travel, patients should carry medicines and carbohydrate-rich snacks in their carry-on luggages. In air travel, patients should not inject. So this is very important. If during takeoff and landing, because of changes in the pressure differences, so that can cause irregularity in the insulin administration. So one should avoid taking insulin during takeoff and landing. Traveling across more than 5 zones again require insulin dose and frequency adjustment, which I will cover it later. During air travel, there is increased chance of DVT, so which can be easily prevented by simple exercise like dorsiflexion and plantar flexion by just standing up and walking around, and we can prevent the DVT. So trail travel is again more flexible, and health insurance is not required, but snacks and medication should be carried in easily accessible bags. During travel, there will be inadvertent increase in the activities, so hence medication should be adjusted and blood sugar levels should be checked regularly. One must carry the physician prescription, health insurance policy, medications, double the quantity, prescriptions for all the medications, rescue medications, especially during the hypoglycemia, carbohydrate-rich snacks, all the supplies, glucometers, coolants, pumps, and double first aid kit, comfortable shoes, and protective clothing should be carried while we are traveling. So how we can manage, especially if we are traveling eastwards, like during the air travel. So traveling east shortens the day, whereas traveling west lengthens the day. So traveling east causes more chances of hypoglycemia, whereas traveling west causes more chances of hyperglycemia. So how do we adjust the doses of OHA? Non-sulfonylureas OHAs, you need to continue unadjusted. Only during the sulfonylureas, if you are traveling westbound, then continue unadjusted, but hold if the meals are missed. And if you're traveling eastward, then immediate release, skip the evening dose on the day of travel because of more chance of hypoglycemia. And what about insulin? The regimen should be changed to the basal bolus, and use of insulin pens should be more encouraged because that are more convenient during traveling. And analogs are preferred over the regular insulin. And interval between the two doses with at least 3 to 4 hours for analog and 6 hours for basal insulin for regular insulin. And if the basal insulin change is needed when you are crossing more than 3 time zones. So eastward travel requires reduction in the basal insulin dose, whereas the westward travel requires additional dose of insulin. Coming to the third special situation, that is surgery. Surgery induces stress because there is increase in amount of counter-regulatory hormones, especially the cortisol, glucagon, norepinephrine, and growth hormone. And surgery itself is an insulin-resistant state because there is increased production of glucose by the liver and decreased utilization of the glucose by the peripheral tissues. So again, recurrent vomiting, decreased appetite, and severe sepsis can lead to hypoglycemia. So how do we manage our diabetic patients during surgery? If the surgery is minor or very minor illness is there, outpatient management can be done with a stable blood sugars. Do not take any over-the-counter medications without the doctor's advice. Keep yourself well hydrated and take medicines as earlier. Patients on insulin should monitor their blood sugar frequently. So frequent monitoring of blood sugar is encouraged, and should do the urine ketone test if the blood sugars are more than 250. Urine dipstick tests are very well available, and that can be widely used to prevent the decay. So contact your doctor and emergency department if the blood sugars are low and or persistently high, and if the warning symptoms such as of ketoacidosis like recurrent vomiting, pain in abdomen, and breathlessness is there. How do we manage them inpatiently? So in hospitalized patients, both hypo and hyperglycemia are associated with the very poor outcomes because of and it also can lead to poor prolonged hospital stay, more severe illness, infections, and disability of the hospital discharge. So inpatient hospital management depends on various factors like type of diabetes, nature, severity of the illness, baseline glycated hemoglobin A1C, insulin sensitivity, what are the feeding patterns, and any associated comorbidities like renal failure, liver failure, and risk of hypoglycemia. So if the patients are non-critically ill and patients are on adequate oral intake, blood sugar monitoring is encouraged at 3 meals and bedtime. Regimen again recommended is basal bolus. Basal give at the dose of 0.2 to 0.3 unit per kg per day, 30 to 50% of the total daily dose, and then adjust 10 to 20% every 2 to 3 days. Bolus insulin with preprandial. So again, preprandial, you can adjust the dose like 0.05 to 0.1 unit per kg in addition to the correctional basal insulin. And what about if the patients are non-critically ill, but they have poor intake? Then blood sugar is more frequently monitored. Again, the regimen is basal plus correctional plus nutritional. Basal, the same dose, 0.2 to 0.3 unit per kg per day. Correctional insulin, if the patient blood sugars are more than 150, then added grade scale of 1 to 4 units on each increment of 50 milligram per deciliter as per the insulin sensitivity. And if the patients are critically ill in ICU, then our target zone of blood sugar is 140 to 180 milligram per deciliter. Frequency of blood sugar monitoring should be 1 to 2 hourly. And we need to start them on intravenous infusion of insulin, that is regular insulin. And what is the infusion rate? The ideal is IV bolus 0.1 unit per kg. And this is the usual formula that we use if the blood sugars are more than 300. Initial rate, like for example, if the blood sugars are more than 350, then divided by 100. For example, 350 divided by 100, 3.5 unit, give it as a bolus, and then 3.5 unit per kg, 3.5 unit per hour, you can adjust the dose. So once the sugars are stable, then blood sugar monitoring can be done 2 to 3 hourly. So target zone is again 140 to 180. Adjustment of OHS should be done on the basis of the nature of surgery and anticipated oral intake thereafter. Insulin dose adjustment depends on the insulin that is being taken and how we can manage the dose of OHA. So on the day before surgery, you can continue all OHAs except SGLT2 inhibitors because that can precipitate into decay. On the day of surgery, and if you are anticipating the normal oral intake on the same day, then withhold all sulfonylureas and SGLT2 inhibitors and others we can continue. On the day of surgery, if we anticipate the reduced oral intake, then withhold all OHAs except DPP4 inhibitors. DPP4 inhibitors can be continued. And what about the insulin? Long-acting insulin, the day before surgery, the morning dose as usual, but the evening dose should be 75 to 80%. And the day of surgery, the morning dose should be again 50 to 80% of the usual. What about the intermediate acting or premixed? The day before surgery, the morning dose same, the evening dose 75 to 80%, and the day of surgery 50%. And the short acting, as usual, you can continue, but only you have to hold it on the day of surgery. So transition again from the intravenous to subcutaneous insulin, at least because intravenous insulin has a very short half-life. So you need to start the subcutaneous insulin at least 1 to 2 hours before the switching to subcutaneous insulin. So intraoperatively, intravenous insulin infusions can be continued, or subcutaneous also can be continued if the duration of surgery is very less than 4 hours. Post-operatively, you can continue the basal or correctional insulin, or if the adequate oral intake is there, then basal plus nutritional plus correctional insulin can be safely given. So managing the last part of the special situation is while the patient's on steroids. So glucocorticoid again represent very important immunosuppressant and anti-inflammatory agents that are prescribed in various medical conditions. Despite their proven efficacy, glucocorticoids have wide variety of side effects such as steroid-induced hyperglycemia, which is very common. So general hyperglycemia in diabetes and steroid-induced hyperglycemia in hospital and outpatient settings detrimentally impacts the patient outcomes, including the mortality. So how do we divide short-acting, intermediate-acting, and long-acting? Short-acting is hydrocortisone, which leads to the peak within 10 minutes. Prednisolone, it is intermediate-acting, leads to peak within 60 to 180 minutes, whereas the long-acting DEXA leads to peak within 60 to 120 minutes. So So short-acting hydrocortisone, the glucose profile.
Dr. Namdar,
Yeah.
if you could wind up the session.
Yes, ma'am. Yes,
Yes.
ma'am. I'll just
Thank you.
come straight away to the end of talk. So this is how we can manage the steroid-induced hypoglycemia in hospitalized patients. If the patient's on short-acting, where we observe very fast increase and high peak and short duration, then start them on rapid-acting insulin analogs such as 0.1 unit per kg, and then you need to adjust the therapy. If they are on intermediate acting, then NPH can be given. If the dose of prednisolone is less than 40, then 0.2 unit per kg. And if it's more than 40, then 0.3 unit per kg. And if if you are using dexamethasone long acting, then there will be a slow decrease and lower peak will be there. Then basal insulin or NPH insulin can be used. So this is again a slide where gliclazide is recommended if the patients are stable and having steroid-induced hypoglycemia. And coming to the physical activity, nutritional plan and pre-fast counseling is very important if we are observing the fast. And the caution and vigilance on the patient's part and simple, specific, individualized care or advice from the physician is very, very important to reduce the chances of complications during travel. And there is increasing need to provide more evidence which first identifies the most safe and efficient therapy modalities to treat the steroid-induced hypoglycemia. So I really thank IMA Dombivli, Meena ma'am, Archana ma'am, and Vijayalakshmi ma'am for inviting me for this wonderful symposium. Thank you.
Thank you. Thank you, Dr. Inamdar, for this highly informative and a detailed session on special situations and managing them in diabetes, patient with diabetes mellitus. However, because of time constraints, I request Dr. Inamdar to please stay logged in. And I request the delegates to please post in your questions in the chat box. They will be surely answered by Dr. Inamdar. Thank you, Dr. Inamdar, once again. And on behalf of IMA Dombivli, it's my pleasure to present the certificate of appreciation to Dr. Aniket Inamdar for a comprehensive and elaborate session for medical professionals on handling diabetes in special situations during online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd November 2023. Thank you once again, Dr. Inamdar, for your precious time and the session. Over to you, Dr. Archana, ma'am.
Yes, thank you so much, Dr. Inamdar. We understand that time is too short for a topic which is really elaborate to this level. But we are thankful that you took it up, as fast as you could. Next time, we would definitely like to have it, in a more elaborate way. Thank you, Dr. Pruthi, for that wonderful moderation. And now we move on to our next session. And the next topic is also very, very, very important and, something which we need to understand. Like there is a barrage of oral antidiabetics in the market. The old time-tested medicines and the newer medicines, oral antidiabetics, which are claimed to be having too many useful aspects. What to use, when to use, how to use, when not to use. So there are so many aspects to the use of oral antidiabetics, and so now we need to understand the rational use of oral antidiabetics. And to present this, we have with us our expert speaker, Dr. Vijay Panikar sir. And to moderate this session, I invite upon Dr. Medha Oak, who's a consultant physician practicing as a diabetologist. Just a minute, so sorry. Practicing as consultant physician and diabetologist since last 30 years, and she's a trainer for National Diabetes Education Program since last 5 years. So over to you, Dr. Medha, for taking this session further.
Yeah. Thank you, Dr. Archana. It's my pleasure and honor to introduce Dr. Vijay Panikar, our teacher and mentor, for the topic of rational use of oral antidiabetics. If time permits, we'll take questions at the end of the session. So audience can type questions in the chat box or raise hands. Dr. Vijay Panikar is Honorary Consultant, Department of Endocrinology, Diabetes and Metabolism at Lilavati Hospital, Mumbai. Ex-Professor of Medicine, KJ Somaiya Hospital, Mumbai. Ex-Vice President, Research Society of Study of Diabetes in India. He has also been a past chairman of RSSDI in India, Maharashtra chapter. Past President, College of Physicians and Surgeons of Bombay. Organizing Chairman, RSSDI National Conference in 2023. More than 20 research publications in journals to his credit. He has also written chapters on in textbooks and medicine updates. He has co-authored RSSDI recommendations for diabetes management, authored RSSDI guidelines in hospital management of diabetes 2016 and also developed an app for the same. I think he's a right candidate to talk on this subject. Over to you, Dr. Panikar.
Thank you, Dr. Mehta, for a very kind introduction and a long introduction. Thank you. Let me just share my slides. Can you see my slide?
Yes, sir.
Is it moving?
So you can put it on a full screen mode.
It is full screen mode.
No, sir.
Can you see the...
Sir, it is not seen in a full screen mode.
I have put it in full screen mode. Can you see my second slide?
Sir, it is 82% if you see below. Probably it's because of that it is not seen on the right bottom corner of your laptop desktop.
Let me see. Does this move? Now can you see the next slide?
No, sir.
No, sir.
No?
No, sir. It's frozen.
I'll stop
It's
share
on the
and
first slide. Yeah.
I'll share again. Okay, now can you see?
Yes, sir.
Is it moving?
Yes, yes, sir.
Thank you, Mehta, for a very kind introduction, and thank you, Pruti, for having invited me for this online talk from Dombivli IMA. Rational use of combination therapy in type 2 diabetes, that's what the topic is. Today, I'll tell you, it is a golden age for diabetics and diabetologists because all the molecules are now generic and they have become very affordable. And in fact, some of them are even cheaper than the sulfonylureas. And that is one thing. If you look at this drugs here, except for oral semaglutide and the GLP-1 analogs, they are all very, very affordable. So we have no problem in thinking whether your patient can afford or not afford. Now, if you look at this, this is Ralph differential ominous octet. You have different pathophysiological mechanisms which are affecting hyperglycemia. And there are different drugs which can act on these different pathophysiological entities. So obviously, there is no way that a single drug is going to affect and be able to treat all the pathophysiological mechanisms. So given this finding, it is prudent that we should hit hard right from the beginning, using several drugs together to nullify the known defects of type 2 diabetes and preserve the beta cells, treat insulin resistance, and so on. So combination therapy should address most of the pathophysiological targets in type 2 diabetes. Now my question is, why should you intelligently manage diabetes? Everybody used to say, go step by step. Diet, exercise. If that doesn't fail, that fails, you give metformin. If that fails, you give. That is a treatment for failure, nothing else. You are just waiting to fail. You should hit hard and then reduce the medications. Now, what is the importance of treating diabetes properly? Look at a 30-year-old person who is a non-diabetic will live up to 75 years very comfortably. That's the lifespan today. But if he's a diabetic at 30, he is going to lose 14.5 years of his life. So when you're treating type 2 diabetics, you should be thinking of this, how you can give your patient a good, healthy, long life without him losing those 14.5 years of life. What do patients die of actually? 80% of them will die of a macrovascular disease, like a stroke, like a myocardial infarction, peripheral vascular disease, and so on. 60% of all patients undergoing dialysis are diabetics. And that is another major reason for diabetic morbidity. And today we have another thing which is coming up, and in a big way, it is the fatty liver. That fatty liver can progress to cirrhosis and can progress to hepatocellular CA. And that has become an epidemic. In fact, in the United States, NASH is becoming the first probable indication for liver transplant. Now look at this, UKPDS, the basic study which looked at type 2 diabetes, said that getting the HbA1c below 7 is very good, very beneficial. So what happened? This is the ADA ESD guideline of 2006. If you see, it says diagnosis, lifestyle intervention, metformin, and then it says HbA1c. If HbA1c is more than 7, then you treat. If it is less than 7, you don't treat. That is what was the thinking in 2006, very glucocentric. Then came major studies which said that if we treat sugars to bring it down to below 7, we will have much better benefits. So you had these major studies, Accord, Advance, and VADT, which all tried to bring the HbA1c to 6.5 and below. And what did they find? No benefit. There was increased mortality. In the Accord study, there were 250 deaths, and the study had to be aborted. And the only benefit that they found was in nephropathy, in the Accord and Advance study. And I think that is because that is a glycemia-driven thing. So you have the microvascular and the macrovascular complications of diabetes. The microvascular, that is your retinopathy, the nephropathy, and the neuropathy, are driven by hyperglycemia. Whereas the macrovascular disease is not driven by hyperglycemia. There are other factors for it, like insulin resistance, hypertension, dyslipidemia, prothrombotic state, etc., etc., etc. This is the Nurses' Health Study. Beautiful study. I won't go into the details, but the gist of it is that the elevated cardiovascular disease risk begins at least 15 years before the diagnosis of diabetes. So the moment a person is diagnosed with diabetes, he is already at a high risk for macrovascular disease. So what is the big message in cardiovascular disease? That good glycemic control does not prevent a heart attack. You can die of a heart attack with an HbA1c of 6.5, because that is not what is driving your heart attack. So what you really need to do is get a good glycemic control, which will address, just a minute, my battery is running low. Sorry. So a good glycemic control will take care of the microvascular complication. For the macrovascular complication, you have to address the dysmetabolic syndrome, which is insulin resistance, obesity, hyperinsulinemia, hypertension, dyslipidemia, atherosclerosis, poor chronic state. This is what you have to look at in your patient whom you are trying to save his 14.5 years of his life. So how do you look at what drugs to use for targeting? Your first aim is to achieve a good glycemic control. All the drugs will reduce hyperglycemia. And these are the charts, like lifestyle will bring down the HbA1c by 1 to 2%, metformin 2%, sulfonylurea 2%, insulin can go up to 3.5%, and so on. The other drugs lower down just 0.5 to 0.8%. So all the drugs can help you achieve glycemic control. So that is out. You want to preserve the beta cell, which will give you a durable glycemic control. Why does a diabetic progress? It is because of the apoptosis and death of his beta cells. So if you have medications which can preserve the beta cells or delay their apoptosis or death, you are going to give him a good, durable glycemic control. And that is done only by a glitazone. There are so many mechanisms here, but the most important one is highlighted in yellow, which says mobilization of toxic lipid metabolites out of the beta cell. And that is what? That is a lipotoxicity. And that is what helps in preserving and preventing the apoptosis of the beta cell. So when you talk of preservation of beta cell, there is only one molecule, That is pioglitazone. Now you want to treat insulin resistance. Indians are insulin resistant. No question about it. And insulin resistance can cause a whole lot of problems. Just look at this last consequences. Diabetes, hypertension, atherosclerotic cardiovascular disease, heart failure, sleep apnea, PVD, stroke, PCOS, and NAFLD NASH. This is the consequence of insulin resistance. So it is mandatory that we treat insulin resistance in every type 2 diabetic patient. So based on that, this is an IRIS study, beautiful study done in non-diabetic patients who had a recent TIA or ischemic stroke. And they were non-diabetic, but they checked for insulin resistance by doing the HOMA. And if the HOMA was more than 3, they labeled them as insulin resistant. And they treated them with pioglitazone 15 to 45 milligrams for 5 years and placebo. And there was a good number of patients. And what did they find in the IRIS study at the end of 5 years? Recurrent stroke was reduced by 24%. In the proactive study, where pioglitazone used, the stroke rate had reduced by 47%. And that was the reason, that was the basis on which the IRIS trial was done. So stroke reduction by 24%, myocardial infarction reduced by 24%, and new onset of diabetes reduced by 52%. Because these were non-diabetics. So here, for the first time, you have a study which says you treat insulin resistance and this is the benefit that you can get. But there was a subset of these patients. This subset was 2,885 patients in this IRIS study who were pre-diabetic. Their HbA1c was not above 7, but and they were there. So these are pre-diabetic patients, and those pre-diabetic patients who had a good adherence to pioglitazone, what do you find? Stroke and myocardial infarction reduced by 40%, stroke by 33%, acute coronary syndrome by 52%, new onset of diabetes reduced by 80%, and all this in a mean year of 4 to 5 years, 4.8 years. Now here, this is a pre-diabetic. The point I want to make is, the earlier you treat insulin resistance, the better is the outcome, long-term outcome. What people do is, they initially treat with metformin, this, that, time pass karke 10 saal baad, they will start pioglitazone, which is of no use. Right from the word go, patient should get it. And this is the American Heart Association and Stroke Association, which says treatment with pioglitazone may be considered to prevent recurrent stroke. No ambiguity. So to summarize this insulin resistance part, Indians have the highest prevalence of insulin resistance. Diabetes and cardiovascular disease starts much earlier in India. In fact, Indians start becoming diabetic 10 years earlier than the whites or the Caucasians. And that is because we are insulin resistant ethnically. Insulin resistance plays a pivotal role in the development of NAFLD, CVD, and stroke. Treating insulin resistance aggressively as early as possible is the surest evidence-based approach to minimize the deadly effects of looming epidemic of NAFLD also. So NAFLD, cardiovascular disease, and stroke will be significantly reduced and addressed if you treat insulin resistance. So early use of pioglitazone in the Indian type 2 diabetes is the key for prevention and treatment. So when you talk of insulin resistance, you have pioglitazone and metformin. Actually, metformin does not reduce insulin resistance the way people think it is. It only reduces hepatic glucose output. So the main drug here would be a pioglitazone. Now, should not cause hypoglycemia. Obviously, you don't want hypoglycemia. There are only 2 molecules which will cause hypoglycemia: the insulin and sulfonylureas. So if you don't use them, you are going to sleep well, because you're not worried whether your patient is going to have hypoglycemia. And now you have all the other molecules to use freely. So in the scheme of things today, sulfonylureas and insulin will be your last choice. You have metformin, pioglitazone, DPP-4 and SGLT2, which you can use very freely. And if that fails only, then you add a sulfonylurea. So that would be the last. So when you talk of hypoglycemia, all except sulfonylurea and insulin should not cause weight gain and preferably promote weight loss. There are only 3 molecules which will cause weight gain: sulfonylurea, insulin, and the glitazones. But the difference here is that the weight gain which is done by glitazones is a cosmetic weight gain. In fact, it is shown that those patients who gain more weight on pioglitazone live longer because they have less complications. So here, if you ask me, are weight gain hai, so we are not using pioglitazone, my simple thing is, I don't mind my patient getting 5 kilos more weight if he's going to live 10 years longer, rather than he not gaining weight and dying 10 years earlier. It's a very simple choice that you have to make. So if that is gone, weight gain is out. Now, renal protection, like you said, that is the main thing that happens to most diabetic patients. There are some studies which show DPP-4 can have renal protection, especially linagliptin. Even there are studies with pioglitazone, but the main study is the SGLT2 inhibitor. SGLT2 inhibitor across the board, every SGLT2 inhibitor has shown consistent and impressive renal benefits in both primary and secondary prevention. What is primary? Patient's kidneys are normal. You are giving SGLT2 to prevent him from getting kidney damage. Secondary is already has kidney damage, and this can help to even reverse that kidney damage. So that is the beauty of these drugs. So when you talk of renal protection, main drug is SGLT2. Cardiovascular benefits. SGLT2 has again shown cardiovascular benefit. Basically, as far as heart failure and cardiovascular death is concerned, is observed both in primary and secondary prevention. So SGLT2 becomes a very important molecule in our treatment. It is going to protect your heart. It is going to protect your kidney. So these are 2 molecules which will be very beneficial for the treatment. These are some studies with pioglitazone which showed that pioglitazone has anti-atherogenic properties. The proactive study, Chicago study, IRIS study, Periscope study. This is a comment by Robert Ryder and Ralph DiFranzo. Ralph DiFranzo is incidentally the person who described the ominous octet, and he is going to be there for our conference on 16, 17, 18, 19th of November, RSSDI. What is the comment? It says pioglitazone inexpensive, very effective in reducing HbA1c, no evidence of bladder cancer risk, plenty of evidence of cardiovascular benefit. So when you talk of cardiovascular benefit, the UKPDS had shown that metformin has cardiovascular benefit. Pioglitazone proactive study has shown, IRIS study has shown, and so many other studies have shown. GLP-1 analogs have shown, especially liraglutide and semaglutide. And now we have the twin cretins, that is your terapetide and a retatrutide, which is now coming, which has shown very good results. So when you look at this strategy, macrovascular damage starts many years before the onset of diabetes. Microvascular complications are linked to dysglycemia, hyperglycemia. Insulin resistance and its complication and beta cell preservation have to be adequately addressed for positive long-term outcomes. Unless you treat insulin resistance and preserve your beta cells, your patient is not going to have a long-term positive outcome. If insulin resistance and dysglycemia are adequately treated right from day one, we will be able to prevent or minimize all diabetic complications, including NAFLD. That is the most important thing. And metformin and pioglitazone most durable, less weight gain with metformin in place. But to this, if you add an SGLT2, That's an unbeatable complication, combination. Whatever little weight gain that pioglitazone will cause, the SGLT2 will neutralize. Whatever little fluid accumulation pio will do, SGLT2 will knock it off. So that becomes the unbeatable combination, metformin pio plus SGLT2. So metformin pio gives you best results when endogenous insulin is present. What does it mean? Means very early in the onset of type 2 diabetes, not late. 10 saal ho gaya, all his insulin reserves are gone, beta cells are gone, and then you want to start with that, it is of no use. So metformin pio plus SGLT2 with endogenous insulin in place, early use is intelligent use. So what would be the ideal algorithm? See, basically you want to reduce peripheral insulin resistance and you want to preserve the beta cell. So that would be your glitazone and metformin. You want no hypoglycemia. So that is DPP4 inhibitor, GLP-1 analog and SGLT2. You are not touching sulfonylurea and insulin. With this, if you are not controlled, then you will think of adding a sulfonylurea. Among the sulfonylurea, the best would be a glycoside, and preferably a modified release glycoside, because the chance of hypoglycemia with that is minimum. If you have only a postprandial hyperglycemia which is left, you would use an alpha-glucosidase inhibitor in combination with this, acarbose, voglibose, or miglitol, and your postprandial hyperglycemia will be taken care of. If in spite of all this, you still need something to control, that is when you will think of starting insulin. There are many schools of thought basically promoted by the insulin companies. Early insulin is the thing. All nonsense. No early insulin. Last. Because it has no cardiovascular benefit, no renal benefit, no CNS benefit. It is only a sugar controller. So it has special situations like in hospital management where you want to give IV insulin. Yes. Where you can't give OHS, that is where you want to see. Now, we are having the RSSDI National Conference in Mumbai at the Geo Convention Center, which is on the 16th, 17th, 18th, and 19th of November. And just yesterday, I got a confirmation that Salman Khan will be coming as a chief guest to inaugurate the conference. And this is a small video of the, it's a Mahakumbh, because the last conference was 12 years ago. It is now 12 years later in Mumbai. Thank you very much. Thank you.
Thank you, sir, for that lucid presentation. We have one question for you in the chat box, sir.
Yep.
The doctor is asking, how can we regenerate beta cells?
We cannot regenerate beta cells as of today. We can preserve the beta cells. And many a times, see, basically, when the beta cells, when the sugars are high, that hyperglycemia stuns those beta cells. They're not dead. They're stunned. So if you bring down the hyperglycemia, those cells become reactivated. That is not regeneration. As far as regeneration is concerned, there are some studies with GLP-1 analog which has shown in neonatal mice that they can regenerate the beta cell. But in humans, no.
Thank you, sir. We learned a lesson that we have to be wise or prudent and hit hard from the very beginning of the onset of diabetes with combination of drugs, including pioglitazones, SGLT2 inhibitors to save beta cells and correct diabetes early in a glucocentric way. So I'm very thankful for you for this presentation. Sir, on behalf of IMA, we would like to present you a certificate of appreciation for your valuable contribution. I'll
Thank
just
you.
read out the certificate, sir. Certificate of appreciation presented to Dr. Vijay Panikar for comprehensive and elaborate session for medical professionals on the rational use of oral antidiabetics during online D4 Symposium, Detect, Decode, Defeat and Diabetes, organized by IMA Dombivli on Friday, the 3rd November 2023. Thank you, sir. Over to Archana for
Thank you,
further
Medha.
questions. Yeah, thank you, sir.
Thank you, Panikar sir. It's always a pleasure to listen to you. For the wonderful teacher that
Thank
you
you.
are, it's a pleasure listening to you. Thank you, Dr. Medha, for moderation. We move on to our next session. And just give me a minute, please. Just give me a minute. So I think Panikar sir has set the stage for you, Dr. Amit, by saying that insulins are not needed. I mean, they are the last things to be needed in the treatment of diabetes. But with so many insulins available in the market, a few conventional ones and the newer designer ones, I think the clinicians need to have a better understanding of the types of insulins which are available in the market, the newer and the conventional ones, and when to use, what are the pluses, what are the minuses. For this, we have to speak on the conventional and designer insulins. We have with us my dear friend Dr. Amit Saraf, and to moderate this session, I invite upon Dr. Sushil Shinde, who is a gynecologist and IVF consultant at EVA Women's Clinic and Lab at Dombivli. So over to you, Dr. Shinde.
Yeah, thank you, Dr. Archana ma'am. Good evening, sir. Amit Saraf, sir. Now, it's really after the Panikar sir lecture, it is really a challenge for you to prove that insulins are having upper hand. So I'll just introduce you. Sir will be speaking on conventional and designer insulins. He's the director of Department in Internal Medicine, Jupiter Hospital, Mumbai. He's a head quality control, Jupiter Hospital, Mumbai. He is a national API honorary treasurer. He is an ex-assistant professor of medicine in TNMC. His professional achievements are: he is an international advisor of India for RCP London. He is a reviewer of British Medical Journal, BMJ, and of Internal Medicines. He is a lead MRCP examiner. He is also a DNP teacher and MD examiner. Sir, you can share your screen and start with the lecture, sir. Thank you, sir.
Thank you so much, Dr. Sushil and Archana. It's always a pleasure to attend and sort of take part in any sort of scientific session which you have hosted. They're always of immense quality. But I sense a bit of a conspiracy here to put me after Panikar sir, because after sir, I feel like Bumrah, who's coming to bat after Virat Kohli had just finished his century, and and he's already convinced everybody that it's right. It's not really required to have insulin. So the point is, Dr. Archana Pate, a senior of mine from the college, we've all respected her. She's a phenomenal person. IMA Dombivli has an excellent scientific crowd there, and the academic programs conducted by IMA Dombivli are really very good. So it's a pleasure to be on this platform. My job today is to honestly not convince anybody what to use, where to use, what not to use. But as the talk says, she gave me insulins, conventional designers. So I just thought insulins all you need to know. I leave it to the judgment of my clinical fellows here that where to use, what to use, that you choose as per the clinical scenario. But everything that you need to know about insulin in the next 15 to 20 minutes, I've put in a nutshell over here. So with that, I begin. At the outset, heartiest congratulations, Dr. Archana Pate and IMA Dombivli for a very successful D4 Symposium. I think the 200 plus audience on the online itself proved that it was a successful day. This is actually the insulin bottle in 1923 when Banting and Best first discovered the molecule, and it's been more than 100 years since, and it's stood the test of time. If you Google the word insulin, you will find in the pharmacopoeia is one of the most read about, most inquisitive molecule. People type in insulin most of the times in their Google trying to read about it, right from lay people to doctors. Drugs. So let's understand in a bit, what does it do? It's stored in the beta cells, produced in the beta cells of the pancreas, comes out from there, works on different target organs like the lipids, the liver, the muscle, and it causes some kind of either decreased production of glucose for example, in the liver, neoglucogenosis is prevented. In the lipids, in the muscle, the uptake is increased, so the blood glucose level goes down. Whenever these two processes don't happen, in the right-hand side box, if you see, because of diabetes genes, adipokines, inflammation, hyperglycemias, free fatty acids, other factors, all of which lead to diabetes. That's your normal insulin secretion. Remember, we all secrete around 10 units of insulin per day at baseline. So most of us have that basal insulin output happening all the time. So mostly a dose given by RMOs of 8 units of insulin and 6 units of insulin in our indoor patients are actually under physiological dosages also, because that's the basal output of insulin happening. And it happens in this particular manner, that's a basal flow of 10 and a bolus happening at each meal that we have or a snack we have in between. Where do we use insulin? All of the above indications. Type 1 diabetics, gestational diabetics or a lactating mother, transient type 2s where in special situation like preoperative management, postoperative management, diabetic ketoacidosis, for example, stressful situation, whether it's physical or mental, type 2s which are inadequately controlled on OADs. Dr. Panikar's slide had shown at the end, if nothing works, you need to go put on insulin. That's where that point comes in. And to delay, arrest, or to prevent complications of diabetes, which are either macro or micro. What is the benefit of early initiation? So though Pandikar sir was very right in saying that drugs is the mainstay of the Indian diabetic market and treatment, but remember, many a times we as clinicians say कि sugar control नहीं आएगा तो insulin चालू करना पड़ेगा. So don't use it like a punishment for the patient. He will get scared, and that's how the negativism against the molecule begins. Tell him it's one of the armamentariums in our basket and it will be used when it's time appropriate. So by using it, you know that it improves the beta cell function. Your basically beta cells are arrested by giving just exogenous insulin. Early in type 2 has shown temporary remission of diabetes, allowing controlled diet at times. Early intensification in the newly diagnosed diabetic basically maintains the beta cell function. As Sir had said, 15 years ago, before the actual diagnosis of diabetes, beta cell function has started to decline. So that remaining 50% of beta cell, the recovery and maintenance is done by early initiation of insulins. Protracted glycemic remission compared to OADs is maintained, reversing some effects of glucose toxicity and lipotoxicity, and improves both insulin sensitivity, insulin secretions. A short-term insulin treatment may have a long-lasting effect when introduced in a stage of early type 2. Though this was not studied in the UKPDS trial, this was exactly what the legacy effect was all about. That the earlier you have a glycemic control, it has a longer-lasting effect, a beneficial effect to the patient in the years to come. What are the types? Based on our structure, we have human insulin, designer insulin. Based on duration of action also, they are divided. We are a generation where we use bovine, porcine, so I put those also, and that goes in the bottle. India is the only country in the world where we have a 40 units of international units of insulin per ml bottle available. Worldwide, 100 IUs of insulin per bottle is available. What is the difference? Each ml in 100 IU of insulin contains 100 international units, and 40 contains 40 international units per ml. Only use a 100 IU syringe, which is an orange cap, easy to remember, and a 40 IU syringe, which is a red cap. So respective syringe for respective insulin strengths. Using a 40 IU for a 100 IU will obviously cause severe hypoglycemia, and vice versa if you do that for the 40 IU one. And lesser volume of injection is given for a dose of injection in case of 100 because it's a more compact preparation of insulin, and a larger volume vice versa for a 40 IU insulin. That's the basic chain. There are two units, the A chain, the B chain. And we have all these coming in insulin like the Lispro, the Aspart, the Glargine, and the Detimir, depending upon where and what the molecule addition or the amino acid substitution has occurred. So available insulin and vis-a-vis their analogs are the following. We have basal insulins, prandial insulins, and a pre-mixed insulin. Basal, as we all have studied, are the NPH, neutral protamine hectone insulin, which basically was your long-acting one. The analogs are your Glargine, Deglutec, and Detimir. Prandial ones are the regular human insulin, the HAI, which we asked to give in our indoor patients. The analogs include Lispro, Glulicine, and Aspart. And a premixed are human premixed one, which are the human insulins, and analogs, which are a combination of either aspart with degludec or lispro with lisproprotamine. So by adding a protamine molecule, there is also a aspart protamine available. So aspart and aspart protamine, or lispro and lisproprotamine, they make it a premixed insulin having an intermediate kind of an action. Prandial insulins are the ones which are your regular insulins. They are absorbed very quickly, last for several hours, and they are rapid. For example, Actrapid. The analog insulin formation of the same human prandial insulins are also rapidly absorbed very quickly. They aim to control a postprandial glucose like glulysin, the aspart, the novorapid, lispro, and Humalog. This also helps a little. Fiasp was a newer insulin came out for ultra fast acting control. It was basically needed where imagine a sister on the ward duty has 20 patients to see, out of which, say, for example, 12 are diabetics. She starts with the pre-breakfast sugar at 7 o'clock in the morning for patient number 1. She informs it to the doctor. And by the time she reached the 12th patient, either that gentleman has already had his breakfast or it's 1 hour post the breakfast time. So then what do? Not every sugar informed from the hospital can be pre-meal or pre-breakfast or pre-lunch or pre-dinner, depending upon the workload the sister has. That is where these ultra-fast acting insulins like Fiasps have come in the market, where a little of time delay aage piche to the meal can also be adjusted and the control is a little better. So that's where these ultra-rapid acting analogs have recently been approved for marketing in many parts of the world, including India. When we compare the regular human insulin with the rapidly acting analogs, the rapid analogs have a faster absorption after a subacute administration compared to regular insulin, and they have a peak concentration of 1 hour. What do they help on? Improved postprandial control, improved A1Cs, lower weight gains, lower the risk of late hypoglycemias, faster onset of action, higher peak insulin concentration around the PPG values, and they mimic the physiological insulin profile as you saw in that initial graph of a basal and a bolus output. The rapidly acting analogs are basically 3, as we saw: lispro, aspart, and glulysin. The PK/PDS parameters for various ones are these. The onset is between 5 to 15 to 20 minutes for most of them. The peak, again, 30 to 60 minutes for all 3 of them. Duration is between 3 to 5 hours for the 3 of them. The maximum the MU per ml is around between 80 to 116 milliunits per ml. Tmax, that is the maximum efficacy of the molecule, is usually seen between 30 minutes of action to 1.5 hours of action. And all of them are clear and colorless. In fact, if the vial is cloudy or opaque, give it back. So all the 3 rapid acting insulin analogs are demonstrated similar pharmacological profiles. Basal insulins now, what are the molecules available? NPH, Detimir, Glargine U100, and Degludec. What about their onset? All of them between, say, half an hour to 1.5 to 2 hours is where their onset of peak starts. NPH, our age-old one, is 4 to 10 hours of a peak. The others, peakless, basically means that their graph of control remains a little sustained for a duration, if you see, of 16 to 24 hours, up to 24 hours, sometimes in Degludec more than 24 hours also. The NPH actually comes down to 12 to 18 hours, and thereby NPH once daily has always been a questionable effect, that if it comes down between 12 to 18 hours, it's not really a 24-hour insulin compared to the others where Glargine, if you give it, see the graph of Glargine, it is remaining at baseline for around 24 hours and thereby has a sustained action. That's the molecular design of the Glargine. They removed the amino acid tyrosine and supplemented it with these chains over here. That's a bit of the electron microscopic structure of these molecules. The pharmacological characteristic of Degludec, basically it's twice as long as half-life as compared to the Glargine U100. The concentration reaches a steady state in 2 to 3 days. So that means if you start a Degludec today, it will take at least 40 to 72 hours for a peak action to happen and the sugar control to be seen. Important clinical practice, because the moment you start a basal insulin and in first day, second day, the patient is saying, abhi bhi sugar control mein nahi aaya. So you tell him the steady state is achieved in around 48 to 72 hours. Flatline action profile in type 1s is seen and compared head-on between Glargine and Degludec, almost peaks of control are equal. The premix insulin, we have basically the regular and the premix insulin which are put together. And what do they contain? They have a regular NPH insulin either in the concentration of 30-70 or 50-50, which are very commonly available in the market. The Lispro and the protamine Lispro either in 25-75 or 50-50 ratio. And similarly, the aspart or the protamine aspart in 30-70 or a 50-50 ratio. They're all designed to cover both the basal and bolus insulin requirements, like the natural physiological secretion. They're cloudy insulins and therefore need resuspension, so basically a vigorous shake before they are administered. What is the rationale for combining them in a single injection? We know that type 2 is a progressive disease. Addition of insulin to provide mealtime coverage is needed when basal insulin is no longer enough. Existing basal bolus regimens offer basal and precise postprandial glucose control, but as separate injections, and a combination of both of them could allow for a simple regimen with fewer injections. The advantages include avoids drawback of patient mixing both the molecule and thereby dosage errors. Option to intensify with the same insulin depends upon the clinician and the patient at times, and a coverage of both fasting and a postprandial and effective A1C control is seen. The combination of insulin has evolved over the period of time. So in the 1950s, we had a premixed animal insulins come up. In the 1980s, you had the premixed human insulins come up. By the 2000s, we had premixed insulin analogs. And by 2013 now, we have a degludec aspart co-formulation, which is very effective. It's a soluble insulin aspart, rapidly acting, making about 30% of the dose, and 70% is made up by the soluble insulin degludec, which is the ultra long acting. It's ready for immediate use, and there is no resuspension required, and it's very, very effective in controlling the sugars. So when we compare a co-formulation with a premixed formulation, co-formulations has two separate components which maintain a distinct identity. Premixed are already a mixture of the two components. Appearance of a co-formulation is clear. The premix will be cloudy. Proportions are predetermined, whereas premixed also are predetermined. Kinetics and dynamics of both are maintained a distinct for co-formulation, whereas they are merged together for the premixed. And examples of a co-formulation include degludec with aspart, degludec with liraglutide, glargine with lexinatide. Whereas premixed preparation, the examples include biphasic human insulin, such as aspart and lispro. What is the comparison clinically of these molecules? So whether it's a short acting, intermediate acting, or a longer acting, the basic difference see at the peak and the duration of, forget the onset of action. The peak for most of the short acting is half an hour to 1.5 hours, and the duration 3 to 4 hours. Intermediate anywhere between 6 to 10 hours, and the action will last around 10 to 16 hours. And the longer acting will start acting at a minimalistic peak, but will act for around 24 hours and sometimes even more than that. The premixed ones, which are all of the above, insulin regular with NPH, 30-70, 50-50, lispro with protamine lispro, lispro with protamine 50-50, aspart with protamine aspart 50-50 or 30-70, all of which have an action starting in around 25 minutes to an hour and duration lasting around 10 to 16 hours. So they are pretty much predictable as compared to the conventional ones. Dosage route of administration of bolus insulins are, all of them are to be given around, say, 15 minutes to 30 to 45 minutes pre-meals. The dosages are traditionally 1 to 3 times a day. Subcut or IV administration can be done. Basal insulins like NPH are cloudy, the others are clear. You have to decide a same time every day, whether it's once a day for the glargine, detimir, degludec. NPH also either the morning or the evening. It's 1 or 2 times in a day and a subcut administration only, not an IV. My last 2 slides, we've come now to the evolution of insulin. So right from 1922, where Banting and Best did the isolation of the molecule, we are here presently where we are come down to almost once a weekly insulin in the armamentarium. We have oral insulin on the anvil, on the horizon, just about to probably be launched by next year. We have liver preferential insulin. We have glucose dependent also on the anvil. These are all futuristic modalities. So the past, present, and future of insulin is very, very rich. We've come a long way, a century of insulin, ultra rapid acting, ultra long acting, weekly insulins, insulin pumps, CGMS, smart insulins, beta cell replacement, stem cell therapies, leptin, proglucagon, direct blanket target, AI-driven personalized insulin pumps, innate insulin, oral insulin, epithelial absorption, all are doing the rounds. With that, I thank you very much for a patient hearing. And as Sir said, Sir is the chairman of the RSADI. I am privileged to be a part of the organizing team. And on the behalf of the RSADI organizing team, we welcome you all to the RSADI 2023 to Mumbai at the Geo Convention Center. Thank you so much for a patient hearing.
Thank you so much, sir, for this very interactive and very nice talk. It's like from the evolution of insulin from years to now, the recent ones. If there are any questions, I will just see in the chat box. Anyone can raise hand if they have question. I don't find any question in the chat box. Sir, I just wanted to ask, like, it's now about a decade or so after completing MBBS and all. So can you just brief on that dawn phenomena which was there, which we used to learn, that there's something called hypoglycemia which occurs in the morning time. So we have to reduce the dose of insulin. Can you just throw some light on that?
Somogyi effect, dawn phenomena, also known as Somogyi effect, primarily basically just like to give a very simple example, like you have nocturnal dippers for blood pressure. So traditionally between 2 to 4 or 2 to 5 a.m. in the morning hours, where physiologically the human body has the least adrenergic drive. So bradys, hypos of all kinds, hypothermia, hypotensions, hypoglycemia, all of which are known to happen. And these are physiological dips in the graph. The Somogyi effect was similar. Unfortunately, because of the drugs at that time, mostly sulfonylureas, the Somogyi effect was aggravated. So at early morning hours, a 75, 80-year-old gentleman traditionally waking up to go to the washroom is to have a hypoglycemic sump. His sugar is to dip, BP probably is to crash, and they has to have a syncopal attack. And that at times also lead to a TI or a stroke. So that was a very bad phase for these patients, and thereby it was important. Today, you can pick it up, by the way, on CGMS. So the moment you put anybody on a drug for diabetes or insulin, you rather do a Abbott CGMS for 2 weeks, let them come back to you with the graph, and you can pick up these subtle variations immediately.
Thank you so much, sir. Do we have any more questions? Can you move ahead, ma'am? Can you present the certificate? Yeah.
Sure.
Yeah. On behalf of Indian Medical Association Dombivli, I'd like to present this certificate of appreciation to Dr. Amit Swaraj sir for comprehensive and elaborative session for medical professionals on conventional and designer insulins during the online session, that is D4 Symposium, Detect, Decode, and Defeat Diabetes, which is organized by IMA Dombivli on Friday, 3rd of November. Thank you so much, sir. Thank you, Archana ma'am. Over to you now.
Thank you.
Thank you so much, Dr. Amit. There was a wonderful presentation on all the insulins and all that you need to know about insulin. And as you rightly said, all clinicians need to use their basically clinical judgment as to when to start insulin or not. And yes, better started early if at all you want to preserve the beta cells. So it's a clinician's judgment whether to use and when to use. So thank you so much for that wonderful presentation. Thank you, Dr. Sushil, for the wonderful moderation. And with this, we move on to our next session for the day. Thank you, Dr. Om Lakhani, for joining. I think you were supposed to be traveling and you had sent us your pre-recorded video, but now that you are there in the audience, we are so happy that you will be taking it in person. So with this, we move on to the next session, which is the use of newer technologies in diabetes. Just one second. Yes, and it would have been rather, more use of the newer technologies in the webinars had you asked us to, just present this as a recorded video. But then we are happy that you are here, and to moderate this session, I invite upon Dr. Swati Gurav, consulting dermatologist and cosmetologist, who's proprietor of Dr. Gurav's Skin, Hair and Laser Clinic at Dombivli. So over to you, Dr. Gurav, for taking this session forward.
Thank you, ma'am. Welcome, sir. Dr. Om Lakhani is consultant endocrinologist at Diabetes Hospital in Ahmedabad. He is a founder of Mellitus Healthcare LLP and Algomet. He is a winner of President NBE Gold Medal in Endocrinology, winner of 2 gold medals in MD and 5 gold medals in MBBS. He has special interest in technology in endocrinology, thyroid disorders and endocrine oncology. Developer of several apps in endocrinology like Notes in Endocrinology, Centurion Insulin app, Hypothyroidism in Pregnancy, and coming soon with Algomet. So he has 26 publications and 15 book chapters. Over to you, Dr. Om Lakhani, for further session.
Yeah, thank you, ma'am, for the kind invitation, and thank you to IMA Dombivli for having me. Can you just give me a second? I'll just share. So, good evening, everyone. My name is Dr. Om J. Lakhani. I'm a consultant endocrinologist at Diabetes Hospital in Ahmedabad. And I'd like to really thank IMA Dombivli, especially Dr. Gayatri, for having me for this talk. I'm going to talk on my favorite topic. That's the use of newer technology in management of diabetes mellitus. Now, what we're going to do is, in this, we are going to divide the presentation into two parts. We are going to talk about newer technology for diabetes patients available in the market. And secondly, we are going to talk about newer technology, mainly apps that we are developing for doctors to help them manage diabetes. Let's talk about some newer technology for diabetes mellitus, which is available worldwide. Some of these things are available in India. I'll tell you what is available in India. I'll tell you what's not available in India also. So I think a very, very important form of diabetes technology, especially for patients with type 1 diabetes, is a closed loop insulin pump. So what is a closed loop insulin pump? So you have two segments of the pump. You have a continuous glucose sensor, which obviously continuously monitors the glucose level. And this sends the data to the pump. And based on the data from the continuous glucose reader, the pump decides the dose of insulin and adjusts the dose of insulin. Now, there are several generations of a closed loop insulin pump. There are actually 6 levels of closed loop insulin pump, which are there worldwide. The early ones are more or less outdated, but what we have right now is a second generation of closed loop insulin pump available in India. It's called the 780G from Medtronic. This is an automated basal hybrid closed loop device, right? So what this is basically when it continuously monitors the blood sugar, as you saw from here. So it continuously monitors the glucose using the sensor, and it sends the data to the pump, and based on the glucose reading, it can adjust the dose of basal insulin. So for example, if the patient's blood sugar goes high, then it automatically increases the dose of basal insulin, and if it goes low, it automatically reduces the dose of the basal insulin. So this is a hybrid closed loop device which is available in India. It is extremely useful for patients with type 1 diabetes. I think the next generation of a second generation closed loop device would be a fully automated closed loop device, where actually you can also have mealtime data, and the bolus also can be automatically calculated and delivered by the pump. So this is the next generation, which is going to come very soon. And then finally, the third generation is fully automated multi-hormonal closed loop device, which is not available in India, but there are trials done by it in the West. It's called an islet device, where they are using two different types of hormones. You have both insulin as well as glucagon being used, and it completes. It's exactly like an artificial pancreas. Now, coming to from pumps, there are other pumps which are available worldwide. You have the Omnipod 5, which is automated insulin delivery system. Here, the advantage of Omnipod, this is not available in India as yet. The advantage of Omnipod is that you can have two different segments. So one, you have a pod, and second, you have a controller, and it's a wireless system, so you don't have to require any kind of tubing for this to happen. And similarly, you have a T-Slim pump, which is a slim and light pump, which is also similar to that. It doesn't require a tubing. So these are some newer pumps. They are not available in India as yet, but they are available worldwide. Now in India, they are developing a pump from IISC. This is called Insuflow. It's an insulin pump under development in India. It's an affordable pump. So the challenges with the pumps are that it tends to be a little bit more costly, and this is a pump which is more affordable. So that is what they're developing, but still, of course, still far from being available in the market as yet. Now, like I said, pumps are very useful for patients. So this is our patient with type 1 diabetes. She's a young girl, about 14 years of age, and we had a hard time actually managing her diabetes. There were a lot of hypos and hypers. And we started to put the patient on a 780G pump, and you can see the blood sugars are almost flat, right? So you can see the data over here. The average blood sugar reading is about 155, right, which is close to bringing her HbA1c close to 7%. This is called a GMI, this is glucose management index, which is an approximation done from this. And you can see, I think the important parameter to see is the time in range, and anything above 70% is considered to be good. So you can see 80% of her readings are in range in the left side. So that means that she's doing very well, right? You can see that she's having zero hypoglycemia. She's having almost no hypoglycemia. So I think all these things point out to the fact that the patient is having a good glycemic control with the use of insulin pump. Of course, then you have CGM. CGMs keep getting better and better. So in the worldwide, internationally, you have Freestyle Libre 3. Of course, in India, you still have Libre 1. And then you have Eversense. So Eversense is basically a 6-month CGM, which is implantable CGM. So you can implant this device, and then for 6 months you don't have to worry about it, right? So it's a it's again available, not available in India as yet, but this CGMs keep getting better. Now, what is available now in India, which is very good from Abbott, is Abbott's original apps. These were not available in India earlier. So there are 2 apps from Abbott. One is Freestyle Libre Link. These apps are freely available. You can install the app, and then you can then wear the CGM and start recording the device from the app, right? And you have the Libre Link Up app. Libre Link Up app is for doctors or for parents of a patient who is probably on a Libre or any close relative. So what you can do is you can actually monitor your patient using the Libre Link Up app, right? So the patient who is using the Libre Link, they send the permission to the person at Libre Link Up. So without putting the CGM, you can actually monitor somebody else's CGM values, right? So this is what a Libre Link and Libre Link Up generally do. Another very interesting technology comes from Bigfoot technology. Bigfoot is a company which was made by parents of people with type 1 diabetes. And they have developed something called a smart pen cap. Now, what the smart pen cap does is, it's again a very interesting device. So instead of using your usual cap on the pen, on your regular insulin, you don't have to require a special type of pen. On your existing insulin pen, you can put a cap on this, right? And what this cap does is, it recommends the so you need to, it can connect with your CGM device, you can see here, and it can recommend how much dose of insulin to take, right? So this is a smart pen cap, which is from Bigfoot. It's a great idea, I think, and I hope that it comes in India soon. But a similar type of device which is going to come to India soon is called the InPen from Medtronic. So this is the InPen system, which is a smart insulin device. So here what you have to do is you have to replace the insulin, with the pen. I mean the regular pen with the, so you need to put the cartridge in the smart pen, and again it connects with the CGM, connects with your mobile app, and it can recommend the dose of insulin to take depending on the blood sugar level. So these are some of the technologies. I think, in my opinion, a very important, perhaps I'll tell you, a breakthrough technology, and hear me out in this. This is something which is completely a game changer. I feel it's very, very important. We have probably not estimated this. So this article was actually shared to me by Dr. S.V. Kulkarni from Mumbai. It's very interesting. I would suggest that you go and read this article. It's a very early prototype thinking, but there is great potential here. So this is called acoustic analysis and prediction of type 2 diabetes using smartphone recorded voice segments. So here what they did was, they took some volunteers. Interestingly, most of the volunteers were from India. So they took these volunteers, asked them to record some voice samples using their smartphone, and they analyzed these voice samples and then correlated the data, have diabetes or they don't have diabetes, and they found that there are certain features in the voice which can predict the diagnosis of diabetes mellitus, or which can predict the blood sugar status of the patient, right? Very interesting, right? So basically, what they're doing is they're doing something called a voice biomarker. So they're actually using voice sample to make a diagnosis. Now this is so interesting because this is something which AI can do very well and machine learning tools can do very well, that they can actually go deeper and try to find connections which commonly our human brain may not be able to analyze or may not be able to understand. So what I feel is that in future, we are going to full circle. Remember, we always used to do clinical diagnostics in front of you, and there's the or your oscillator doing is, we are depending more on lab reports, on imaging reports, all that. I think we're going to go back in the future again, where with all this type of biomarkers, clinically available biomarkers, without asking the patient to get any investigations done, you will be able to analyze the patient's voice, see the patient's face, look at the patient's skin color, all these things, and make a diagnosis based on these clinical parameters, probably just using maybe a smart glass. Now I don't know if you have seen this, but there is a Ray-Ban has developed along with Meta have developed a smart glasses which you can actually record videos with that. So these things are coming very soon, and I think in future, as a physician, you will be sitting in front of the patient, analyzing your patient through your smart glasses and making the diagnosis without asking for any kind of investigation. So this is, I think, a breakthrough, And I really hope that such things keep coming more in future. Now I'm going to show you some of the work which we are doing. So apart from being a doctor, endocrinologist, I am also a little bit of a developer. We have developed some of the apps. So some of the apps, some of the people might be aware. The apps we have developed earlier are Notes in Endocrinology app, which are there in the store, and we had developed a Centurion insulin app. There's a hypothyroidism in pregnancy app. So these are apps which we had developed earlier. Now what I'm going to show you is our current and future work in the field of diabetes management. These are again apps. Remember, what we are trying to show you here are mainly early prototypes. These are obviously they are wherever they are available, they're free of charge. So you can try it out. Also, if you have suggestions, please send them to me, and I'll be happy to take those suggestions from you. So you have the creatinine, you have urine albumin creatinine ratio, you have the patient's liver profile, SGPT, SGOT, platelets, everything, right? Now, how do you, with all this data, remember, different, data points will have different connotations in terms of the prescription that you generate. For example, what is the patient's cardiovascular risk? Should I give this patient statin? Should I give this patient aspirin? Right? These things are important issues that we need to grapple with. Right? Whether this patient should be given SGLT2, should we give this patient DPP4, metformin should be given or not? All these kinds of issues really come. And when the patient is right in front of you, you don't have that much time to really analyze all these things quickly, right? So what we are trying to do is we are trying to develop a system called diabetology.co.in, which quickly analyzes all these data parameters for you and then suggests a treatment prescription based on the entire system, right? So we have already developed the first prototype. You can check it out on diabetology.co.in. You can click on the first prototype and you can have a look. It goes something like this. So when you first go in, it is going to show you this type of data where you have to enter all this data. So you have to enter the age of the patient, the all the data points that I showed you. So all these data points need to be entered into the system, right? Now we timed the system. It takes only 3 minutes to enter all the data, right? So if you see the entire thing, this is for a person who is not experienced using the system. But if you're already experienced using the system, you just need to, it'll take about 1.5 minutes only, right? So you enter all these data points in the system. There are some data points which are mandatory. For example, creatinine, fasting blood sugar, and HbA1c are mandatory. This has to be entered, but other data points are optional. So other cases you may or may not be able to. So at the end of this, you get this kind of recommendation, right? So the first question is, does the patient need insulin? Yes or no? Diabetic kidney disease status, it will tell you. Cardiovascular risk category. There are a lot of other things you'll see when you open this up. It will tell you. We'll also do the FIB4 score calculations. Everything, these things will get. And then it will start recommending the medications, right? Statin, metformin, whatever, right? And any medication it's suggesting, it will also tell you why this medication should be considered. So this is something we have developed. It's a labor of love. It's a experiment. It's still we are developing this, but I think we have breached something which is quite remarkable in this space, right? And then after that, you can go to the prescription page where you can do the modification. You can add the brand name of the drug, maybe modify the dose of the drug depending on your requirement, and it will give you the final prescription like this. You can then add more medicines to it, right? You can add more medicines, whatever you like, and finally it will generate the entire prescription, right? So this is what it looks like. You can download this prescription like a PDF, right? You can in fact change the language also from English to any other language, Gujarati, Marathi, whatever. You can change it depending on your need, right? So this is diabetology.co.in. Of course, the prescription generation part, this is there on our backend. We have still not uploaded it, but the initial part, this part, and the treatment part and everything, the initial prescription, raw prescription part, it's already we already put this up, so you can try it out for yourself. And again, like I said, you do give me feedback. Second thing we are developing, which is now in a more mature stage, is EndoAI. It's called endoai.co.in. You can again visit this website and you can find the link there. And you of course need to register for EndoAI, so you can check this out. Right, I'll show you the so it looks like this. So you click start here, and then when you click on start here, it will take you to the EndoAI page where you can log in and register, right? And when you log in, you need to go to start here again, right? So here what it does is, EndoAI is basically like a chat GPT for endocrinologists, right? So you have this segment over here where you select the subtopic from where you want to ask questions. For example, let's say diseases of bone and mineral metabolism. So you go there, right, and you ask questions, right? So what are the causes of osteoporosis in men, for example, right? So it will give you all the answer tuck, 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 very quickly, right, like this. And then you can ask a follow-up question, right? How does hypogonadism contribute to osteoporosis in men, for example, right? So you can then get the answer. And you can the entire thing, you can save this as a chat, right? You can save this up, okay? And then you can share it with somebody, or you can probably save it for your own thing, right? Now, at the back end, we have used something called endotext.org. Endotext is the largest resource for endocrinologists worldwide. It's a freely available textbook written by some of the best authors in the world, started by Dr. Leslie Decode. You know, some of you may know that Decode textbook of endocrinology was, before he passed away, it was a very popular textbook in endocrinology. So what we are trying to say is that we are trying to develop a system which is extremely robust and which is evidence-based kind of answers it will give you. And you can in fact make a lot of diagnosis of patients also. In fact, you can try with some of multiple choice questions. You have this USMLE style MCQs, you can put it up and I'm sure 9 out of 10 times it will give you the correct answer, right? It's very, very accurate and very useful also, right? So this is how you can use. So here in this case, you can see we have taken this MCQ, USMLE style MCQ, and with a single best answer, and we put this up, right, and it was able to give the diagnosis. Yeah, so we put this question and you can see it will say it's normal and gap, right? So that's the answer. So it is of ours who keep sending us reports, which bunch of reports, so many pages of reports. Some of the tests are really meaningless, they don't mean anything, right? So this is something which I've been trying to develop for a while. This is one of the early things we are trying to develop. But of course, we've not put this up so far on the web. But we'll be doing this soon if a lot of people have interest in this. So what we are trying to develop here is that you take the patient's report, it will analyze the report and send it. For example, let's say this, right? So you upload this report over here, right? And I have modified this in saying that I'm an endocrinologist, so I only need relevant tests to my field, right? So it will, in a few seconds, analyze the thing and generate the important tests which are from the endocrinologist perspective. You can see here what tests are required from my side. So there are a lot of garbage tests, which are not required and they have been done. But in this case, for example, you have the patient's testosterone report, you have the other reports which are there. So you can see that, it was able to generate the entire thing, right? And then very interestingly, it will also start giving you the analysis, right? So you can do the analysis over here, right? So, so it does a pretty good analysis also, right? So you can then send this directly to a patient saying that, this is the analysis and this is what you probably need to do. For example, let's say vitamin D is low, considering that you need vitamin D supplementation and so on, right? So, like I said, you have annoying relatives who said, please have a look at the report and tell me what it is. Well, instead of that, you can say that, why don't you go to my AI assistant and, upload the thing over there and, it will be giving you the analysis from this, okay? Yeah, and finally, the last thing, again, something which, one of the early developments, again, we still not put it up online. It's still at the back end, but it's something which could be useful, right? So it's an app for summarizing medical papers. So we are all, we get shared a lot of important research papers and, but who has the time to read all the papers in detail, right? So what you can do is, we have this system called Saraswati, right? We named it after the goddess of knowledge. And so you upload the paper in the system, right? And then you can directly say, you can make a one-line summary of the paper, or you can have a 5 important bullet points, or you can have a section-wise summary. So in this case, we have uploaded this paper. Here you said, tell me the 5 key points from the paper, and here it will give you the 5 key points in bullet forms. You can say then, just give me one-line summary, and here it gives you the one-line summary. You can say, give me a section-wise summary. So it will generate the, there you go, develops the section-wise summary of the paper, right? In fact, then you can go and chat with the document also. You can ask questions to the document. So this is something we are developing independently. Now, a lot of you will say that ऐसे तो apps हमने देखे हैं, but having said that, we are trying to go one step further. What we are trying to add is now, so you need to give an audio sample of yours, and it will develop and download. You can generate the audio summary in your own voice. right? So then which can share it with your patients or with your friends or with your other colleagues. So in your own voice. So you need to give a small 30-second audio sample, and once it starts, it analyzes your voice, and then it will start generating the summary in your own voice, which you can then download as a MP3 file, and you can share it with your friends or colleagues. You can also convert the article into PowerPoint presentations. So a lot of us, make a lot of PowerPoint presentations, give a lot of talks. So you can use this tool for doing that. Right? So these are some future additions to the same which you are trying to do. Finally, of course, a lot of you might be following me on, we have a notes in endocrinology, which is a freely available notes system. It's available on endocrinology.co.in. You can visit that website. You can get all the notes, and you have very interesting notes on very interesting topics. A lot of these topics are not covered in textbooks and other textbooks. So again, we went one step further and actually made a book, wrote a book on this called The Best of Notes in Endocrinology. I'm happy to say this is now available on Amazon and available on Flipkart. So you can order this. It's called The Best of Notes in Endocrinology, first volume. We have about 9 notes here in this, which are varying from various topics, and one of the topics which would be very interesting to you would be artificial intelligence in medicine. So you can check this out and read it. I'm sure it's going to be very, very useful to you in your day-to-day life, right? And we are coming up with more volumes, so we are going to come up with about 3 or 4 volumes more of this, right? So it's going to come out soon, right? So again, thank you so much. Thank you for a patient listening. And if you have any questions or queries, you can send it by email to me on dromlakhani@.
Thank you so much, sir.
Yeah, sorry, would be happy to take questions live.
Yes, there is a question in chat box saying, is diabetology.com to be used by doctors or by patients directly?
No, it's for doctors. It's diabetology.co.in. So you can check that out. It's currently it's a free module right now. So we've just put the first prototype. The entire thing with the prescription, we're not sure put that. When we put that, we'll be behind the a registration system where only the doctors will be able to use it. So patients cannot use it right now. Of course, right now the version we have, patients may be able to use it if they understand that. But they will not be generating a prescription. They'll just get some suggestions in terms of what kind of treatment they can have. But yeah, so it's only for doctors. Obviously the law also does not allow us to develop something directly for patients. It's going to be for doctors. It's going to be for a lot of primary care doctors also who can use that system basically to get an idea of what would be the right treatment, what would be what kind of medications they can add. In which cases a statin is required, which cases perhaps an ACE inhibitor is required. So those kind of things.
Sir, as we are running short of time, I hope you would be online. There are certain questions in chat box more, so you can answer them.
Sure. Yeah.
Thank you so much, sir, for such a peerless session. I would like to give you the certificate of appreciation on behalf of IMA Dombivli for comprehensive and elaborate session for medical professionals on use of neurotechnologies in diabetes mellitus during online D4 symposium, that is Detect, Decode, Defeat Diabetes, organized by IMA Dombivli on Friday, 3rd November 2023. Thank you so much, sir. Over to you, Dr. Archana.
Thank you so much. Thank you.
Thank you, Dr. Lakhani, for that wonderful session. Thank you, Dr. Swati, for the wonderful moderation. We move on to our next session, and that is something, which I think every clinician keeps on hearing it in their clinical practice. Whenever a patient is diagnosed with diabetes or some blood sugar abnormality is seen in the report, and you think of putting the patient on medication, and the question that you are asked is that, will I have to take this lifelong? With so much of social media talking about, reversible diabetes, we need to understand if there is something called as reversibility, what is remission, what are the lifestyle modifications which we can do in a diabetic patient, or we can advise to a diabetic patient to bring down the blood sugar levels. And to talk on this, we have an expert speaker, Dr. Roshni Sangani. And to moderate this session, I invite upon Dr. Bhakti Lote, who is a family physician for last 25 years at Regency Health Clinic, and she's past president of IMA Dombivli. Over to you, Dr. Bhakti.
Thank you, Dr. Archana. For the next session, that is on lifestyle modification in diabetes, is it reversible? We have a speaker, Dr. Roshni Sangani. Dr. Roshni has done MBBS from KM Hospital, Mumbai. She is American board certified endocrinologist and accredited practitioner with Society of Metabolic Health Practitioners. She conducts physician supervised coaching for comprehensive lifestyle change for metabolic disease. At present, she is working on tailoring international best practices in Indian lifestyle and habits to create sustainable changes in medication management with aim of de-prescription. Recently, she has written a book on diabetes reversal through lifestyle change in Indian context. Its manuscript is in editing phase and it will be published in 2024. So now I request Dr. Roshni to conduct the session. Before that, there is a small announcement for the audience. If they have any questions, they can ask the questions at the end of the session, or they can ask in the chat box. Thank you so much. Over to you, Dr. Roshni.
Hi, thanks for having me. Am I audible?
Yes, yes, ma'am.
Okay, so thanks, Dr. Gayatri, for inviting me. It's always fun to connect with this audience and to see what's happening. I'm so lucky to come right after an amazing talk about technology in diabetes, and it's really good that the medical field is keeping up with what's happening in the technology side as well. So I'll go ahead and start my presentation. Okay. Is it visible?
Yes, madam, it is visible.
Okay, fine. Great. So the question is diabetes reversible? And I think we have a very advanced audience here based on the level of presentations before me, so I'm not going to make it too basic. But we know that diabetes is a condition of elevated blood sugar, and the diagnosis is made when somebody realizes their blood sugar is high. But if we're going to talk about reversibility, then as an endocrinologist, we have to make sure what kind of diabetes are we talking about. So yes, it's an elevation of blood glucose, but is diabetes only an elevation of blood glucose, or is there something going on with insulin, right? It starts with insulin problems. Now, obviously, type 1 diabetes is when there's an insulin deficiency, and this would not be the reversible kind of diabetes that we're talking about today. So for the rest of the talk, I'm not going to talk about how insulin therapy is required in type 1 as a life-saving drug. We are going to talk about insulin resistance when we talk about diabetes for the rest of this. And whether this is reversible or not is exactly what I'm going to talk to you about. The best way for you to differentiate, because you can see somebody with autoimmune destruction of the pancreas with overweight. So don't use their body weight or their BMI. Don't use their glucose levels as a way of deciding whether this is type 1 or type 2. Please check their C-peptide levels, because both type 1 and type 2 can come with extreme hyperglycemia and weight loss. So to really know the difference, you would better off be checking the C-peptide levels. Now, there are 184 people here. I would love to, if you could put your Zoom hand up. How many of you know or think that diabetes is a lifestyle disease? I like to make my talks a bit interactive. So even on Zoom, if you put your hand up, there is a way for you to do reactions. So one person has raised the hand. Yeah, I'm only going to give like 60 seconds to this. How many agree it's a lifestyle disease? Lots of people, right? I hope everybody agrees that it's a lifestyle disease. Yeah, I don't think I should wait for 184 hands to come up. So yes, you're all right. It is a lifestyle disease. Now, what about show of hands? Type 2 diabetes is a chronic and progressive disease. Now, how many hands do we want? Someone's saying something in the chat. Okay, that's not for me. Is diabetes a lifestyle disease, or is it a chronic and progressive disease? And if it's both, how's that so? Any quick explanations, you can put it in the chat, right? But this was something that used to bother me a lot, is how are we calling it both chronic and progressive as well as why lifestyle? For me, the bulb is, if you change the lifestyle, then why would it be chronic and progressive? So let me talk to you about that. What we know as type 2 diabetes being a chronic progressive disease, we've seen these slides all time and time again. I've sat through so many presentations where we use this slide, and we say that at the time of diagnosis, You're told to modify your diet and exercise, eventually one drug, some dose adjustments, then multiple drug combinations will start. You'll start getting some maybe in between meals symptoms. If you're on a sulfonylurea, you'll have to eat on time. You have to avoid hypoglycemia. You're not safe to skip meals. And pioglitazone, if it's there, you're going to be gaining weight from all of these combination issues, where although we want you to lose weight for type 2 diabetes, very likely you're going to be gaining weight as part of a response to therapy. So then reversal becomes, on the contrary, it becomes you out of hand, and we start talking to you about insulin and multiple daily injections. So this is not looking reversible at this point. It looks chronic and progressive, but that's because we haven't helped them change the lifestyle. And we don't do this in any other disease. We seem to do this in diabetes. Is you see the symptom of, let's say, an infection like typhoid or TB, you see fever, you do the fever workup, you notice the local symptoms, you investigate, and yes, you'll give the paracetamol for the fever, but you will obviously understand that there is something driving that fever, which is the bacteria, and you will give the antibiotics as the root cause approach. Whereas when it comes to type 2 diabetes, we say, oh, high glucose, that's what raises the alarm. I give things to lower glucose. What's the root cause here? Insulin resistance. And how much of our therapy is actually going towards insulin resistance? Maybe you'll say, I prescribe metformin and I prescribe pioglitazone. Sure. But beyond that, are you actually helping the person with their lifestyle to reverse the root cause of insulin resistance? And that's where type 2 diabetes becomes chronic and progressive if the patient actually is not being guided how to make the lifestyle change. Now, if you look at this, this could be Tokyo, this could be Mumbai, right? Where if you're trying to push more people into this train, it's not going to work. And all these crowded platform people, that's like the hyperglycemia in the blood. And we cannot say that the solution to the crowded platform is just push harder and push more people into the train. Obviously, we need to do something to empty out this train, which is overloaded with people, which in the body is excessive fuel stored inside all the cells. That is the sort of main trigger why we get insulin resistance. There's so many reasons, but this is one of the biggest ones that we found, that if you are able to reduce visceral obesity, inches around the waist, overall weight loss, you will be able to reverse this fuel excess and reverse type 2 diabetes. So the way I go about this in my practice is I help the patients. I work with them over 3 to 6 months, working on the 4 wheels of what I call the lifestyle car, which is nutrition, sleep habits, stress management or spirituality, exercise, medication management throughout that. As an endocrinologist, we have to, so that we can de-prescribe. And the word reversal, now we're getting a bit more sophisticated. Is it remission or is it reversal? So right now we talk about, if it's reversal, we mean that from 4 drugs, could you come down to 3 drugs? From insulin, could you get to de-prescription of insulin? If instead of being chronic progressive going forward, could you bring the trajectory of type 2 diabetes back with less A1C, with less medicine? That would be reversal. Remission, the way we have the same for cancer, it would be that we think that right now the disease is not active, and going down the road, we have to keep monitoring to check for recurrence. So remission would be that you've got your A1C below 5.7 without any medications, you have an absolutely normal HbA1c, and you're without drugs. Now, the reason I put this car and I made that car go like this is you could achieve remission and then life could happen. Life's ups and downs could happen, and somewhere something might go for a toss. We can tell people all we want is fix your diet and fix your exercise. But the reality is, after they leave our clinics, that's when life happens. So we need to be able to keep this in reality, is to help them achieve success. We need to help them with these lifestyle areas. So let me give you a graphic of how it's all interlinked. And if you don't address these interlinked areas, you will find the patient's condition to be chronic and progressive, and it will not reverse. What are the problem areas in major chunks of nutrition, sleep, stress management, and exercise? And how do all 4 of these contribute to insulin resistance, right? And I could even spend like 1 hour on this particular slide, so I'm going to go through it a little quickly. Is that when you eat a carbohydrate predominant, protein deficient diet, you're triggering high insulin levels. Leptin levels you get leptin resistance because of high insulin. You feel hungry, you're eating all day. Insulin resistance becomes a vicious cycle, and you're gaining weight, and now you're stuck purely thanks to nutrition. India is actually ranked very poorly in terms of overall sleep quality as a nation. We're time-wise sleep deprived. We also have a lot of artificial light pollution, spoiling our natural circadian rhythm. We have sleep apnea. And even at small body weights or BMIs, I've seen OSA, even in like, they look like thin fat. So just because the jaw or micrognathia is there, I've seen a lot of sleep apnea, even with normal BMI. This is often missed because the patient is always awake when we talk to them. We don't look at them when they're sleeping. So you need to ask the questions about sleep apnea. When you don't have good sleep, you don't have good energy, so then you won't exercise, you'll feel tired, you won't have growth hormone, so you won't build muscle even if you are exercising, because growth hormone release happens in deep sleep. And then you have a muscle gain stagnation, muscle plateau, you have sarcopenia, a major problem in India where we are overnourished and under-muscled. So this becomes a major site of insulin resistance, is muscle loss itself. Then that's a major contributor. And as Indians, we love to do walks and yoga when we get diabetes, but we don't really embrace the idea of strength training. When you don't eat well, when you don't get enough protein, you again don't get the benefits of your workouts. If you're not working out, you don't have a natural stress buster. That's going to make stress worse. You anyways have stress in life from all our normal family problems, work problems. And that chronic hypercortisolemia will contribute to insulin resistance. If you're not sleeping well, you're going to be more cranky. If you're stressed, you're not going to sleep well. Everything becomes a vicious cycle. And this is what starts to make type 2 diabetes look like a chronic progressive disease. If you don't sleep well, you won't learn. So imagine you come to the doctor's office, doctor tells you everything, and you're so sleep deprived that you're not going to retain anything new because you're just not, your brain is not getting repaired at night because of poor sleep. Again, insulin resistance purely from sleep deprivation. This has been proven. 4 days of sleep deprivation can directly cause normal people to have hyperglycemic responses. And sure, we all know about emotional eating, is that when we're stressed, we tend to reach for foods that do not help insulin resistance, right? None of us look for doodhi when we're stressed. So what does reversal look like? This is a person who was in my practice long back, 52-year-old guy, 9 stents, losing vision, micro and macrovascular complications, 20-year history, 100 units of insulin, still hyperglycemic 500. Nobody knows what to do with this guy. The cardiologist says, I can't put more stents in you. I'm looking at 100 units of insulin and saying, I can't ethically feel like this is the right treatment, that I'm just going to keep pumping more insulin in you. Everything is going wrong. Your treatment is just not going right. So when we put him on CGM, we saw his carbohydrate impact. He saw it, he reduced it, got his protein to target. We got him onto intermittent fasting. In a month, his insulin stopped, which he had been taking for so long, 100 units. He started doing 42 hours of fasting with strength training to preserve muscle. He lost 10 kilos from that paunch. He's a typical Gujarati guy from Juhu, lost some of that Gujarati paunch and got much improved. So this, he can still see. Now he finally went for a bypass now, but this particular slide is from 2018. So he was able to, with 9 stents, pull on another, 5 years, and finally he needed a bypass now. Obviously he had the legacy effect of really bad diabetes control for a long time. So we don't want to wait for so long before we start offering reversal to people where there's permanent damage. But it's quite interesting to see that even such an advanced case of diabetes can show you de-prescription if you hold their hand and show them what to do. So what is medical nutrition therapy? Every January, this document comes out from the ADA, Standards of Care, and this is written there. So it says, it's complex language. It says for individuals with type 2 who are not meeting glycemic targets, means what? A1C is high, or for whom reducing glucose lowering drugs is a priority, means what? For people who don't want to be on so many medicines. Now, if you dare ever ask your patient, do you want to be on less medicines? Surely the patient is going to say, yes, I want less medicines. There is no person on this planet who wants more medicines. And yet this document is putting it in this twisted language, is if your patient wants to be on less medicine, reducing overall carb intake with low or very low carb pattern is a viable option. That means it's been proven that reducing carbohydrates will bring uncontrolled diabetes into control with less medication. It's in the books. So the question of, is this reversible or not? We need to stop asking that, I think, and we need to figure out what we can do to help each other as practitioners to actually offer ideas to our patients how to stop progressing this metabolic disease. This is also from the ADA, no one size fits all pattern. Prefer low carb foods and whole foods, and I'll come to that in a second. And this showed the reduction in the A1C, and so much research that it reduces the need for anti-hyperglycemic medication. I don't know if we tell our patients this, I think if you told the patient that, look, this is your food, this is your glucose, either you reduce your chapatis or I give you more medication, Does the patient know that if they reduce their carbs, then their glucose will come down with less medicine? Do we actually tell people this? I don't know if we all do. I sure didn't until I found out about this concept, which I was forced to pay attention because of a patient. Until that point, I didn't get this from my endocrine training that I should offer this option to the patient. So this man actually did this. He had A1C of 16 when he cut his 4 chapatis to 2 because he didn't want insulin. He was willing to do anything. And I told him that, of course, you need to have protein and vegetables. And I had already certified as a diabetes educator also when I moved from US to India. So I had this knowledge that I should give him more protein and vegetables. And that's what he did. Now, put in the chat box, what do you think the glucose level came? With 5 tablets A1C 16, cutting 4 chapati to 2, what do you think the glucose level must have been impacted by cutting out 4 chapatis to 2? I was shocked. I almost fell off my chair when I saw this. Any guesses? 180. I see a guess of 180. 150. Okay, fine. Y'all are close, but guess what the level came? Oops, did I lose the slide? Where's it gone? Yeah, 94. Do you see that? 94. So I was like, oh my God. And this man also realized that this is so powerful. He's like, चार चपाती का 2 किया, 94 आया. He's like, madam, मैं अभी ये 2 चपाती का 1 करके आता हूँ. आप और भी मेरा medicine कम करो. He got very excited at the power of reducing carbohydrates. And this was a Gujarati guy who was eating 8 chapatis a day, 4 at lunch and 4 at dinner. So he was very excited to reduce his rotis if it means reducing glucose. So the thing is, when you tell people, and I saw a comment that maybe it's chronic and progressive because lifestyle change is not sustainable. Now, if I told you that stop all your rice, then that's not sustainable. Okay, I'm not going to tell you to do that. But if I ask you that, are you willing to reduce your rice so that your glucose can be normal without medicine? Then the question becomes, how much rice do you need for you to be thinking that this is a sustainable way of life? And that brings us to portion sizes. What is a normal amount of rice for you? Do you need to sustain that definition of normal quantity of rice? Because that what you are calling normal has given you this much hyperglycemia. And well, different people think different amounts of rice is normal, right? So depends. What's your definition? Now this, I had to take the entire plate of rice from my whole family of 4 people. We can't even finish this rice between 4 of us. So we put rice on the top. We put rice on the top of the plate. And this is a major problem. Now that people have gotten interested in the word whole foods, unprocessed, whole grain, multi-grain, we have gotten into another scam. What is that scam? Is we think that nachni chips or nachni idlis or dosas or multi-grain khakras or bajri wafers is whole grain. It's not. The whole grain has been turned into a powder and everything melts in your mouth without chewing. So if it's instant jawar puffs or makhana seeds, which you can just pop in your mouth and just it melts away without any teeth, that's no longer a whole grain. So idli is no longer whole grain. Upma and shira is not. Whole wheat bread is not whole wheat. It's powder. It's been turned into a fluffy thing. There is no whole wheat left in that bread. All right. Millet, because millet is considered India's superfood. We keep saying that, but we've turned it into a powder. And do you know that the carbohydrate content of millets is actually very similar to wheat and to rice? How many people know that? Have you checked the carb count per 100 grams for these millets? So here's a scam example where the box tells you that there is whole grain. It says whole grain, whole grain, whole grain. Everybody's so excited about whole grain, multi-grain. And then you see magnify, look, it says 100% of the grain is whole grain. So they're really kind of screaming at you saying whole grain, whole grain. And when you read the ingredients on the back in the fine print, it says, what does it say? It says rice flakes. It doesn't say whole grain rice anymore. It says jawar flakes, not whole grain jawar. And it says rolled oats, not whole grain oats. Which one is the whole grain oats? This big one at the top where my mouse is on the top. This is powdered oats, which you use for your oats noodles, and you think you're buying good noodles because you bought oat powder noodles. And then in the middle is the rolled oats. So this idea of whole grain is a scam if you don't see a whole dana. If the dana doesn't require 20 minutes of cooking and it's just instant cooking, no whole grain is instant cooking by default. So please don't get scammed and buy all these whole grain things for your family, which is powdered. Now on rounds in the hospital, everybody's getting idli and poha as the diabetic tray because we still follow the food pyramid, which has carbohydrates as the base, 50 to 60%. So we give them so much of carbohydrate. So you're giving them the ratio of, look at the ratio of soft, fluffy carbohydrates to protein for a vegetarian Indian. So instead of 4 idlis, maybe you can reduce the idlis, double up on the good coconut chutney, the good healthy fats, double up on the sambar and the vegetables, and change the ratio of what your Indian plate looks like. If we keep on saying Indian diet is a very balanced diet, Indian heritage is such a balanced diet, why do we have the epidemic? Why do we take #1 position as diabetes capital of the world? And why did we reach our 2030 goals of diabetes numbers? Why did we reach that target 7 years early? If our traditional diet is so great? Okay, so be careful when we convince ourselves that everything is going fine, because we need to change something. Protein sufficient diet. Now, this was a trial which compared high protein diet to low protein diet. Now, I'm not going to spend time on this slide, which says that the higher protein diet gave more pre-diabetes remission. Okay, but what I want to show you is the high protein diet versus the low protein diet. So in the control group, which they called the high carb diet, right? So they had a high protein diet compared to a high carb diet. Even the high carb, low protein diet still had 56 grams of protein per day. Now, how many of your patients have you counted?
Hello.
Yes.
Hello,
Hi.
Dr. Roshi.
Yes.
Sorry to interrupt you. We are really running short of time.
Yes.
We will have to finish it fast.
2 minutes?
Yeah. Okay.
Sure. Anyway, so even their control group was getting more protein than the average Indian. Okay, so we need to count our protein for our Indians. One more slide on sedentariness for people who don't exercise, that even if they are sedentary, tell them to do alternate bouts of sitting and standing. So if you're sitting for 3 hours doing consults, can you stand every 30 minutes instead of sitting for 30 minutes at a stretch? And doing little breaks in the sedentary. So get up, walk around and come back instead of non-stop unbroken sedentary spells. This itself has been shown to improve the outcomes, like physical measurements changed when they just broke the sedentary time. We need to add strength training to our protocols, not just walk and yoga. Please instruct your patients how to build muscle. Most doctors don't know how to do that. I had to train in personal training to be able to help my patients. So in summary, it is a reversible disease if you consider insulin resistance as the core, and if you consider that you're willing to offer the lifestyle support to your patients. If we don't, or if our educating team, if doctors don't do it, maybe they put their dietitian team or their educator team, but somebody needs to hold the hand of the patient and break all these myths about nutrition, sleep, stress management, exercise, and fasting. And yes, all of these approaches, I see it every day in my practice, and that's what we do. Thank you very much.
Thank you, Dr. Roshni. It was very interesting and wonderful session. Actually, because of the time constraint, we couldn't continue it, but I myself was feeling very interesting topic. So, Dr. Roshni, IMA Dombivli, thank you by presenting you a certificate of appreciation for comprehensive and elaborate session on lifestyle modification in diabetes. It is reversible. During online session on Decode Symposium, Detect, Decode, and Defeat Diabetes. Now I request the audience, if they have any questions, they can ask Dr. Roshni. I think there are no questions in chat box. Anyone has any question? You can raise the hand. I think there are no questions. Everybody is satisfied with your lecture.
No, I think people would be having lots of questions, but it's just the effect of a prolonged session. The entire session has been really overwhelming, but I think 173 people still remaining till the last session. That itself speaks volumes, how much, the audience is enjoying all the wonderful sessions. And I think the time is really short for such wonderful, enlightening topics, because I think diet is one of the most important aspects of, when we call it a lifestyle disorder. Diet is probably the genesis of many disorders, and probably, will help us in reversing many of the illnesses. So we need to have a lot more time, to speak about diet and, of course, diabetes and the various other diseases. And I think we can have one of the sessions related to that. So with this, thank you, Dr. Roshni, for that wonderful, elaborate session. I think the audience really enjoyed it a lot. And I think all those who have raised their hands, if you're not asking your questions, I think you may please put it down. Please lower your hands. Yeah.
In chat box, Dr. Roshni, you can answer them in chat box itself. Is it okay?
Yeah, I've already started doing that.
Yes, thank you
Okay,
so
okay.
much. Yes, and thank you, Dr. Bhakti, for moderating this session so nicely. And I think we move on towards the last session of the day. Whenever we as clinicians are treating diabetes, there are so many questions which many of the, I won't say all the patients, but many of the patients bombard us with, because there are so many myths and facts, myths rather, surrounding this disease, because the WhatsApp university rules supreme, and people gather information rather than gathering information from the clinicians and the doctors. People these days try to gather information from the relatives of the relatives and the friends of the friends who are suffering from any of the illnesses. And so there are many myths which are associated with this particular disease. And now we move on towards the last session of the day, that is myths and facts related to diabetes. And the panelists, this is a panel discussion, and for the panel discussion we have with us Dr. Anil Boraskar, Dr. Tejal Lathia, and our previous speaker, Dr. Roshni Sangani. And to moderate this session, I invite upon Dr. Meena Pruthi. Over to you, Dr. Meena.
Thank you, Dr. Archana. Good evening, respected speakers and dear delegates. After such amazing, elaborate knowledge sessions, I welcome you to this last icing on the cake panel discussion on the myths and facts about diabetes. As Dr. Archana rightly said, myth is something which we all experience in our daily clinical practice, where patients come up with these false ideas in their minds because of poor education, because of cultural beliefs, social misconceptions, passing on from one generation to the next, and having a very strong influence in their lifestyle and health-seeking behavior. In fact, it becomes very difficult to break this chain of myths, as it is so deeply seated in our society. Our aim as doctors and healthcare educators is to bring about this shift and change in the mindset and behavior of the population by understanding and eliminating the myths, educating our patients, doctors, community about the facts, and especially about diabetes mellitus, where unfortunately we are the leading nation today. So for the next 30 minutes, let's get on together on this myth-busting panel discussion with our renowned panelists, Dr. Anil Boraskar sir, Dr. Tejal Lathia, and Dr. Roshni Sangani, who have so very graciously spared time from their busy practice to share their experience, their insights, and enlighten us with facts on diabetes and patient management. It is my honor to introduce you the speakers. Dr. Roshni Sangani, we all have heard her, a beautiful, an amazing speaker. We have with us Dr. Anil Boraskar, sir. He's a senior consultant diabetologist at SL Raheja Hospital, Mumbai, Asian Heart Institute, and Asian Cancer Institute, Mumbai, with special interest in diet and nutritional therapy and humor therapy in chronic disease management. Scientific Secretary of Diabetic Association of India for past 20 years. He's the ex-chairman, Southeast Asia region of IDF, Course Director, IDF Center of Education and Excellence, Mumbai, has many papers, publications, and presentations in national and international journal and conferences to his credits, and is the recipient of many awards, all-time achievement awards, orations, both in academics and community service. A warm welcome, Dr. Anil Boraskar, sir. We have with us Dr. Tejal Lathia, who is a consultant endocrinologist practicing at Apollo and Fortis Hospital, Navi Mumbai. She has 50 peer-reviewed publications to her credit, with latest publication being Emotional and Psychosocial Wellbeing by Ethnicity and Birthplace in Women and Individuals with PCOS, which is published in the British Journal of Obstetrics and Gynecology in 2023. And currently, she's researching on exploring the relation between mothers and daughters with PCOD in context of hirsutism. And we have with us Dr. Roshni Sangani, whom you all heard, and you know her very well. So let's move on with this brief introduction to the panel discussion. A warm welcome to all the three panelists. on behalf of IMA Dombivli. Dr. Boraskar, sir?
Yeah, am I audible?
Yes, sir. Yes, sir.
Good.
So we have these, this notion where patients come with these routine evaluation reports in hand, and the reports show very high sugars, and they get totally flabbergasted, saying that I have no symptoms. How can I really be having diabetes? How do we handle such notions, sir?
This situation is very, very often, but unfortunately, I don't face this situation because I am the garbage bag of diabetes. I get patients who have surpassed all complications and they have no place to go. That's why they come to me. That's a penalty you pay for being senior and 40 years in the business. So I get people who already have some amount of problems. So they are not surprised. And luckily, when the patients come to me, they are already on some of the treatment. Very rarely I come across a patient who is a newly detected type 2 diabetes. Now, newly detected diabetes who comes with a high sugar, there are three reactions. First, he says that this report is wrong. Second, he says, I think there is some mistake in printing. Third, he says that there is no history of diabetes in our family. I cannot have, and I do not have the classical symptoms which are told to him, like excessive urination, thirst, weight loss, weight gain, lethargy. I have no symptom. So elevated sugar can come as a surprise, but many times you counsel them and ask certain subtle questions that do you get up in the night to pass urine? Oh, that's normal. That's normal because I've been told to drink a lot of water. So I drink about 2 liters of water before going to bed. And that's why I get up 2-3 times. I said, that is not normal. Number one, that is abnormal. Anyway, this kind of interactions are seen by me many times. The point is, I am not much worried about this at all because what comes to our rescue in such case is HbA1c. Fasting sugar, post-lunch sugar, post-glucose blood sugar, a test could be wrong. HbA1c will never lie. HbA1c will tell you what Mahapap this man has been doing for last 6 months. Sagaya papaza pada vasto, HbA1c. And many times patients, when going for the blood sugar testing, they starve themselves for 4-5 days, just to see that they are all right. So HbA1c elevation, elevated fasting blood sugar more than 140, post-lunch around 200 and above, his diagnosis of diabetes is made. That is my take on this.
Thank you, sir. Thank you very much for explaining in detail. Dr. Roshni, ma'am, if I may ask you a question, the patient come up with a statement like, I am just a borderline diabetic, so I do not need to worry. How factual is this belief, ma'am?
The example I give over there is how does India protect her borders? Since we're going to use the word border, if somebody is getting inside my border, should India worry or it should not worry? Or if a cockroach is sitting on the window, should we worry or we should say it's only on the window, it's not inside my house? So I think my job is not to, tell people what to think, but I'm going to ask them, why are you thinking that borderline? Where is it going to go from here if you don't change anything? It is going to progress. So, I think like Dr. Boraskar said, maybe we are in that sort of biased space where people come to us knowing why they're coming to us. So luckily, Dr. Meena, I've not had that question in a long time, I don't need to worry about pre-diabetes or borderline HbA1c, because probably the message I'm putting out there is we are here to help you change your trajectory. So the ones who don't feel the need to change the trajectory, probably I'm not the right fit for them.
Yes,
unfortunately, if I can interrupt and substantiate what you said.
Yes, sir.
Medicine is interplay beautifully by use of English language. ज्याला आपण गोंडस स्वरूप म्हणतो ना, गोंडस. Can you say that this woman is otherwise quite fine, well educated, good looking? The only thing is she's slightly pregnant. No, slight, borderline, zarasa. occasional.
Yeah.
These are all beautiful words given to a serious symptom, believe me. And patient also say, mitha mitha darad hota. It could be cholecystitis. You understand? So English language particularly has many adjectives which are basically created to pacify a patient. These are all pacification words. And one should not use this word. I never use words slightly, borderline. Your border is vulnerable. You remember 2611 happened to us because we neglected our border. Then we realized the naval coast, the border has to be secured. Shivaji Maharaj has said it. Secure your borders. So this is a point that you said I would like to substantiate. Thank you.
Absolutely. Yeah. So these are the notions which they have in their mind, and we need to correct them. There's nothing like being at the border. It is either you are or you are not a diabetic. Sir, Roshni ma'am, also there is many patients, they get well controlled on medications and they stop their medicines on their own without even consulting the doctor. And very proudly they say that I can stop taking my diabetes medicines because my blood sugar is under control. Can you guide us on demystifying this notion?
Well, if the blood sugars are normal, what is the wrong thing that's going on? What's the problem? Why do they need to keep taking pills if they've corrected everything?
Right. So do they need to continue taking their pills or medicines once their blood sugar is under control on medications?
Right. Okay. So
That
on
is what
medication.
Yes,
So
ma'am.
then
Yes.
obviously it needs to be done with monitoring and follow-up. Is if I have a normal glucose on medicine, now I'm taking away the medicine, then a scientific mind will say, you're running an experiment. Please check the results of your experiment. You're taking away a drug. Please check what happens to the glucose. It's a very simple discussion to have is, sure, let's see what happens. If you want to check if your body is able to have a normal glucose without medicine, hopefully you do that under the trusting supervision of your doctor and do it with a professional, safety net. Now, your point of they do it on their own. See, I think we also have to be careful, they are masters of their life. And as much as my ego might get hurt, ki bina puch ke kiya, kyun pucha nahi, and I want to scold them and sit on their head and hold my certificate against them. I think that's me taking myself too seriously. This is a very intelligent person sitting across the table. If they have the capacity to tell me that I did this and I'm now informing you, then why don't we have a conversation between two equals and check what's going on in their mind? They're definitely not doing it to be suicidal, right? They're definitely not doing it to become sick.
Right.
So let's align our goals and then work from there.
Absolutely. So it has to be a patient-centered and patient-oriented approach totally.
Absolutely.
Yes, absolutely. Thank you. Dr. Tejal ma'am, can I have some question on concepts among doctors? There is this concept, especially out of empathy for their patients, where we feel that, we need to scold our patients or create a fear of impending complications to make them aware, teach, or understand the importance of diabetes. Dr. Tejal ma'am, do these methods really work with our patients?
So thank you, Dr. Meena, for that question. And I'll put a disclaimer for the audience that it was my idea that, yes, we always talk about patients and what they are doing wrong, but very rarely do we turn the mirror to ourselves and introspect that what we as doctors can do different. So traditionally, that's what we've been taught, right? When you're in medical school, you see your professor, your colleagues, your senior colleagues scolding patients who don't have a good HbA1c or have high blood sugars. Now, what happens with the scolding business is somehow it implies, like Dr. Roshni pointed out, that people don't care about their health and they don't understand what they're doing. But that's not true. The very fact that the patient is sitting in front of you with a high blood sugar report means that they've tried their best and it's not working, and they've come to you to sort out the problem. So it's really counterproductive to scold the patient and tell them, oh my God, you have high sugars. How could you be so careless? Because we're assuming that they've been careless. We're assuming that they've not done any effort to take care of their diabetes. Even if the efforts may be misled, maybe in the wrong direction, but they are trying. I'll just say one thing about this whole scolding thing. So just yesterday, the CEO of a large health technology company came to see me, and his father has diabetes, and he took his father to a very big doctor in Navi Mumbai to show for his diabetes. And the first thing that the doctor did is blasted the CEO's father, saying how bad he'd been about his diabetes. And the only thing that the person did is the elderly man who was the CEO's father, came out of the clinic and told his son the CEO, I'm never going back to that doctor. So what happens is we've scolded the patient, we pat ourselves on the back that we've done a great job, but often it puts a lot of people off healthcare. It reduces their courage to come to a doctor because they know if the sugar is high and they go to a doctor, they're going to get scolded. What's the point of going at all? So many times you come across patients who haven't been to a doctor for years because of one bad experience. So out of 100, maybe there's 1 or 2 people who need to be told sternly. But I think for most of us, being told something nicely, we are far more likely to do it than being scolded for it.
Absolutely. So we have to be kind and gentle, and at the same time, get our message set across the patient that it is important.
We are not their parents. We are not their teachers. We are not God. We are just a person practicing a science who's trying to share their science with them. And whether they do it or not, as Dr. Roshni very rightly said, is ultimately they're the master of their own lives.
Absolutely. We just have to instruct them, and then they have to take care of themselves. Absolutely. Let's move on. Thank you, ma'am. Thank you, Tejal, ma'am. Let's move on to some myths related to food and diabetes. Dr. Boraskar, sir, there is this common belief: eating more sugar causes diabetes. Can you please guide regarding this myth?
See, there has been a general consensus about sugar causing many diseases. And it is not the carbohydrate content of the sugar. The refined white sugar, which is created by this sugar lobby, I'm sure many of them are my patients, is treated with chemicals which are highly toxic. In fact, I had a great discussion with my great friend Nitin Gadkari. Nitin Gadkari came out with a fantastic idea. He said, Dr. Boraskar, I agree with you that the sugar is bad. But what we are now encouraging people to stop growing sugar cane and grow bamboo. And he gave me the ecosystem by which how growing bamboos will help the environment much more than the money that you make from sugar cane. You see, this is what has happened. The sugar lobby is so strong, and sugar is something which is very pleasant. Any occasion, any festival, and India, I must tell you, out of 365 days, 265 days are festivals. And that way we are सर्वधर्मीय. म्हणजे हिंदूंचे सण पण, मिया लोकांचे पण सण, क्रिसमस पण जोरात. We don't spare anything. Everything is associated giving sweets. So that is synonymous with culture. Now to change it and to change children and give them the lessons that they give to in Australia. My granddaughter is in Australia. She says they call white sugar and white salt as a white poison. I mean, these people, these Gora people can go to any extreme. We won't do that, but we tell them moderation. Now, many patients who come to me, I allow them to take 2 teaspoonfuls of sugar in a day. First cup of tea in the morning and 1 cup of tea in the evening. 2 teaspoons sugars is not a big deal, but taking 10 teaspoonfuls of sugars and adding everything, ज्याला चव म्हणतात चव, आम्ही फक्त चवीला घालतो. गुळ, and all tasty food is laden, Gujarati, Maharashtrian, with good. And a lot of people say, we don't take sugar, we take good. We take honey. Please remember, these substances have the same calories. Only thing, good has iron, so better than sugar. And therefore, sugar is, I would say, not, it is not toxic, it is not poison, but the quantity must be reduced. Second thing, when the sugar is added to the food, I heard our Sangani's lecture very intently, the quantity consumed is always more. When the food is not very tasty, automatically eat less. So if you add sugar, the food is tasty and then you tend to eat more. So this is why we say sugar should be controlled judiciously. One point I must add to Dr. Sangani's talk about dietary fats. We have been very revolutionary. For last 30 years, we have been talking about the virtues of coconut oil. And the whole world was laughing at me and Dr. Reja when the entire world was favoring polyunsaturated fatty acids, and they condemned the saturated fats coming from ghee and coconut. Now, please remember, in our Hindu Sanskriti, Shriphal, coconut, is a deity given to God. People survived during tsunami on the treetops by eating only coconut and coconut water for weeks together. Therefore, the saturated fats which are there in coconut are not harmful. Coconut does not increase your cholesterol. It has got phytosterol, which builds up your immunity. So one myth about coconut is gone. Now ghee. There is a lot of objection about ghee. In Sindhi, there is one kahawat. I talk so confidently about Sindhi because my wife is Sindhi and I work in a Sindhi hospital, Rajas. So they say, Je so kare ghee, na kare mai or pi. What ghee can do to you, even your mother and father cannot do. These are the virtues of the ghee, but limit it to only 2 teaspoonfuls per day. Eat it as a garnishing. Don't fry anything in ghee, because when the ghee is put in the iron container, kadai, and you boil it, it produces cholesterol oxidase. Oxidation of ghee is danger. Ghee and coconut is to be garnished over the food stuff and not fried in the oils of those. So this is one myth I wanted to bust. Thank you very much.
Thank you, sir. That was amazing. So there's one more question to you, sir. Then there is also this statement which is commonly passed that people with diabetes should not eat fruits. Could you guide us on this too, please?
I agree, because there are a lot of idiots who say, Doctor, आम्ही फक्त fruits खातो. Now this should realize that there are many fruits which increase the blood sugar, the swing of blood sugar. On a fruit diet, if people are taking only fruits instead of proper meal, they have a swings of sugar. Now the fruits, which fruits you like to eat? We recommend fruits which are fibrous and pulpy, not very porous. Means we tell them, I allow my patient to eat 1 mango per day. I allow them 1 mango per day. But there are some idiots who say, आमची झाडं आहेत आणि पेटे आले आहेत 2 आणि सगळे आंबे एकदम पिकले तर आम्ही 6 खाल्ले एक दिवस. Now I say, if you have got so many mango, distribute it, but don't exceed more than 1 mango. Second thing about banana. Now banana, believe me, Boraskars are all Deshastha Brahmins. And the longevity in our house is almost 90, 92. And the cause of death is boredom. Either they are bored of the life, or people are bored of them, or they shot them. You understand? The reason is very simple. When we were small children, we were given shikran poli. Now, shikran poli is a highly ripened. My mother was so good at dietetics. She had studied that the spotted banana, jasta piklela kela, has got high phosphates. And that is good for child's brain. The growth of the brain will enhance if you take spotted bananas. So these are good fruits. Now, certain fruits are very rich in carbohydrates. Do you know that a mango contains lesser carbohydrates as compared to banana? But pulpy fruits like apple contains iron, cherries, lychees, but limit their good. Papaya, melon, watermelon, these are all healthy foods, but limit your fruit intake to less than 300 to 400 grams per day. Fortunately, fruits are more expensive. Luckily, because when we write a diet, की सकाळी 2 फळं हे बघतात आमच्याकडे हे डॉक्टर कुठून आले हे काय किंमत माहिती आहे का बाजारात कायची. So this is one way of controlling. But fruits which are seasonal, which are available in that particular season, are not harmful. Fruits out of season, stored, preserved, tinned, are not helpful. So this is my, take on fruits as such.
Thank you, sir. That's highly insightful. So we have a question for Dr. Roshni, ma'am. There is this common belief, in patients or they are suggested by their peers and family members that take bitter tasting food like karela, neem, methi, and that will help you lower your blood glucose level. And even natural products like aloe vera, cinnamon, fenugreek, ginger, they will all help you cure your diabetes. Madam, how true or factual is this?
Oh, I have no idea. I have no idea. I'm not going to, yeah, I think people, yeah, Tejal, go for it.
Yes, Tejal, ma'am.
The doctor at Indore, he who runs that whole center with the insulin pumps, he's actually done studies where they put CGM and made the patients have the bitter stuff, and the sugar didn't come down.
Okay.
So he actually used to demonstrate to them because he is highly into pumps and CGM, and he actually did it for the patients to show them that what you're doing is not helpful.
Exactly. Yeah, I was.
If I can add to this,
Yes. Yes.
karela, methi,
neem,
and all those stuff are definitely healthy fruits, healthy foods. But the point is, if you, again, I'm married to a Sindhi. Now, the type of karela they make, so-called stuffed bharlele karela. The karela is opened. There is a fried onion, little potato, and it is deep fried. So that karela has lost all its natural immunity producing substances. And karela is a very favorite dish. Huh? So this is the way how you eat karela. Now karela juice is an astringent. You drink karela juice, it chelates all the carbohydrate molecules. And you get a bloody diarrhea, with the result of which the absorption, it does the same job of acarbose.
Okay.
But you cannot possibly start your day with a glass of karela. Whole day you will be bloody grumpus. You try to understand. Methi has a great role. Methi dana. Methi palak is also extremely beneficial. But the type of methi which is made, lasanachi phudni dileli methi. Now what is lasanachi phudni? You take a handful of oil, put it in a pali, put lasun in that, roast it, and pour it on the top of methi. That is not a right way to eat it. It is the preparation of all this bitter stuff to make it palatable. They make it lose all the values of that food. So this is, the good stuff. They have a lot of antioxidant properties. Normal Indian diet contains enormous antioxidants. Dalchini, lavang, jaipatri, tejwan, hinga, mohri, jire is loaded with antioxidants. You don't need any extra antioxidant. But unfortunately, mohri is given as a tadka. Jire, tupachi phudni. You see, you can add jirpud on the top of dahi or tak, which is healthy, or jiravan, or jaljira with a lime, with a less salt. But people have different palates. Unfortunately, Modi ji says, Vasudevaka Kutumbakam. I agree. The whole universe is one family. If that was true, then India will be the kitchen of that family. The diversity on the food and diversity of so many varieties of food. Do you know in Maharashtra there are 22 types of dals? In Kerala there are 11 types of sambars. So look at the diversity and availability of food. That is what we have to really protect ourselves from.
Right. Absolutely, sir. Dr. Roshni, ma'am, there is a statement about the millets, whether all millets are good for diabetics or is there any inter-individual variability?
Yeah, so I'm going to club my response to the karela, methi, bitters, and the millets all in one. So when I said I have no idea, I was actually leading to this, which is I'm not going to pretend that my degree on the wall lets me look at your face and tell you that if you eat methi, your sugar is going to come down. So let's not have this false illusory discussion. If you think karela is going to bring your sugar down, do it the right cooking way Dr. Anil has mentioned, and check your sugar before and 2 hours after. I don't know how many of our patients are doing the before after with any food, whether it is millet. Now this question keeps recycling, it's an outdated, overused question, which millet is the best. We need to help our patients ask more intelligent questions. If you really want to know, why don't you sit with your glucometer, have the pre-meal level, have the millets of choice in a whole grain form, not in a powdered khichdi like, steamed form, which is a porridge, and check in 2 hours. They're not running their own experiments and they're staying in ignorance and continuing these outdated, ignorant-based questions. So we need to teach our that's why I refuse to answer. So I'm like, I don't know. I want you to know by checking in your body with your glucometer. And guess what? Today, if the millet spikes your glucose in November 2023, does not mean that November 2024, the same millet will spike you if you invest in the right lifestyle changes, reversing your visceral adiposity, building muscle, then the millet is not the issue at all.
Absolutely, absolutely. So they have to be made to understand that it is a multifactorial approach that they have to take, and it's not just only one thing.
Exactly.
Thank you for
See,
clearing
again,
this.
one minute, if I can just add, any foodstuff, logic, makes you chew. आम्ही म्हणतो की तुमच्या तोंडात 32 दात आहेत तर 32 वेळा घात चावून खा. Masticate your food stuff which is in the mouth for 32 times. What does it do? It produces saliva. 50% of the carbohydrate digested by saliva. Remember that properly. It produces a lot of enzymes reflexly. Mastication, in fact, badams and pistas are called as negative calorie producing food. Why? By masticating them, you spend more energy than the energy you obtain from this food stuff. They have negative glycemic index. So if you just, whether you millets, bhakri, jwari, whatever you take, you make it a habit of chewing it more number of time, making sattu of millets in a kheer fashion and drinking it does not serve the purpose. That is what I feel. I mean,
Right. It has to be cooked rightly in a right manner and taken in a right manner to have its effect on the body metabolism. Absolutely right, sir.
I'll add to that is we're destroying the slow absorptive properties of these products when we turn them into powders.
Okay,
the coating, the shell, the external thing. I give the example of if the pest, some dana get bugs. If you keep the jar of the pulses or the millets in your house, it gets infection, right? It gets those pests.
Right.
They make one hole through the external cover and then they go inside and they make it hollow from the inside.
Okay.
Andar ka maal wo log kha jate hain. So what does that tell you? That the external shell is difficult to digest.
Correct.
They only make one hole.
Right.
So when we turn it into a powder, then porridgeify it and idlify it and dosafy it and kheerify it, you're ruining the glycemic index and the natural slow absorptive properties. So cook it in its whole form. It'll absorb much slower. You'll have more satiety.
And absolutely same is with the whole grain rice, because patients feel that, those who are rice loving and rice eating patients, they feel that I can eat the whole grain rice, to my heart's content. Is it really true?
Again, check in 2 hours, no? How much quantity?
Right. Even the whole grain rice, which you're talking about.
I mean, there is no food which should be given blind faith that I can just keep eating it without checking my own body response to it.
Dr. Rashmi, do you want to talk about the scientific term personalized glycemic response? So the physicians would, right? I mean, so ma'am, there's something which is called as a personalized glycemic response. Every individual's response to a particular food, a particular portion can be vastly different.
Right.
I consult for a digital technology company and we have had patients whose sugars are high with millets, but normal with rice, high with wheat, but normal with rice, high with rice and normal with mango. So what Dr. Roshni is continually emphasizing is the personalized glycemic response. It's high time that we stop giving blanket statements about what we shouldn't, because based on our feelings and our so-called science, I think that nutrition is a very underserved part of our medical training, and most of us, I think, know very little about nutrition. Dr. Roshni, of course, runs a company which does a deep dive into it and has a lot of practical experience which she's witnessed over patients, and I've had the same with, and we use CGM sensors, so we can actually pinpoint ki ye khaya to ye hua, ye khaya to wo hua. So I think, time to give the power back to the patient.
Absolutely.
There is one thing which I have to tell you.
Yes, sir.
In families where the most looked at problem, most looking forward for that particular event is the evening dinner where the whole family sits together. Now, you remember the man has worked out, the children have gone to schools and they're all at the dining table. The job of a housekeeper or a homekeeper, what they call today, housewives are called homekeeper. Her job is to see that everybody is happy and the atmosphere is very, very nice at the dinner table. And they always ask me, doctor, you asked me to cut down oil, you cut down this and cut down that. The food becomes virtually a kind of a udara bharana nohe, janije yajna karma, that is what we say. It is just not filling up the stomach, but it is some kind of a ritual. That Sanskriti you are asking us to break. Now, this is a difficult proposition because when you are changing the dietary practices, you are changing the culture of the family. And you have to do it in a very tactful manner without hurting anybody's sentence. And taking science to the kitchen is an art. It needs a lot of patience. A lot of values which people have been taught that now our wives are trained by their mother, grandmother, great-grandmother. That's how the tradition of cooking goes on in Indian cuisines. So this has to be handled very tactfully. And normally when people come to me, looking at my size and my seniority, then nobody argues with me. But when they leave my chambers, I'm sure they are not satisfied. I'm sure they are not going to come back to me if I go continuously telling them about changing their food habits and culture. So you have to do it very tactfully.
Absolutely. So we just have last few questions to all the panelists. Dr. Tejal, if you could just demystify the statements regarding patient treatment, where they say that diabetes medicines do not have side effects or insulin injections are not painful, and it can be easily fit into a person's daily routine.
So quick comments. So,
Yes.
a lot of times as doctors, we tell the patient, आप insulin ले लो, इतना कुछ मुश्किल नहीं है, कुछ भी दर्द नहीं होता है. It's a very small needle. Now, for those of us who've taken subcutaneous injections, maybe a low molecular weight heparin injection during pregnancy, or themselves have diabetes, or have taken liraglutide for maybe obesity, insulin injections are painful. From time to time, there's an intense stinging sensation when the needle is inserted into the skin. So what I'm trying to say is we don't discourage our patients from taking insulin, but we don't brush their complaints under the carpet. We acknowledge that, yes, insulin injections can be occasionally painful. Yes, it would be great if you could change the needle more frequently, because often when the needle becomes blunt, it's difficult to insert the needle. Let's not minimize or, not let them not validate their pain. So for us to say that insulin is very easy, it does not affect your lifestyle, it does affect your lifestyle. I'll give you my own example. If there was a Miss Universe competition for the most non-compliant patient of all time, then it would be me. I have the dubious honor of having never completed a single course of antibiotics in my life. In my entire pregnancy, I kept one gynecologist appointment. So I'm not encouraging people that they should be non-compliant, but what I'm trying to say is insulin therapy is hard. It is often painful, and we need to acknowledge and validate our patients when they tell us about this. Also, the thing about diabetes, medicines have side effects, right? Every patient comes and says, we are afraid of side effects. A very simple way to tackle this is explain to people that there are two types of side effects. One is a major side effect, where your worry is that the medicine will affect the heart, the kidneys, or a major organ, and that is not true. However, there can be minor side effects. So let's acknowledge that, yes, when you take metformin, you can have gastric acidity. When you take an SGLT2 inhibitor, you can have burning micturition. When you take pioglitazone, you can have swelling over the feet, and you can have humongous weight gain. So acknowledge that, yes, medicines may have some effects, but they're usually minor. The major problems that you are worried about the kidney, the heart, the liver, that is not true. So let's acknowledge them. Often our speech, we completely invalidate our patients, and we pretend or we behave as if what they feel or think does not matter, which is why I would like to, once more talk about what Dr. Roshni said, that as a doctor, it's our job to give them, share our knowledge with them, and maybe help guide them in the right direction. But ultimately, what they want to do is probably a choice best left to them. And the more vehement we get about it, and the more we behave like a school principal or a teacher or a parent, it doesn't really work most of the time.
Absolutely. So Dr. Roshni, if you could just share your take-home message on this panel, in this panel discussion, or the myths and the facts which we have shared, it would be very nice, ma'am.
Sure. I'll just add one technical geeky point about the painful injections, which I'm sure everybody here knows, but I'll just remind, is that sometimes it hurts when it goes into muscle. So if you get blood at the tip, then maybe the patient is gone into a muscle. Adipose tissue is not as vascular as muscle. So if you're hitting a blood vessel inside a muscle and injecting there, it's going to be very painful. So that could be one sort of a quality check that we can ask the patient to do. Coming to the parting words, I think this was fantastic. I enjoyed being on this panel with some really intelligent and inspiring physicians, Dr. Anil and Dr. Tejal. And thanks, Dr. Meena. I'm going to just add one thing, since everybody agrees on this, is I've just gotten, exposed to, well, not just gotten exposed to, something called motivational interviewing, which is a way of talking to patients, which starting point is that the client is the expert of their life. And maybe the healthcare meeting is a meeting of two experts, two equals, where the client knows exactly what's going on in their life, beliefs, preferences, realities, challenges, future situations, home environment, psychosocial, everything. And we have a degree on the wall. And by alone, maybe the solution won't come, but if we partner together, and the whole technique of motivational interviewing, it's an art that if the patient says, I cannot cook for myself a diabetic diet, right? And sorry, I'm a female, but I don't cook in my house. And I keep telling my husband that it's also his role to be in charge of food. And, but since we're talking about food, I'll say that if a patient tells me I cannot change the food in my house because of the rest of the family's needs, then there's a reflection to be made there. What's the reflection? Is, oh, looks like taking care of your family's needs is important to you. Rather than saying the patient is making excuses, patient is not listening, patient is not serious about it, the patient is telling you what's important to them. Is, it's important for me to take care of my family's needs. Oh, okay, so it looks like you're saying it's important for you to make sure your family is also looked after. And you enjoy that. That's a big part of who you are. You value that. Now I'm wondering that, keeping in mind you have that need to take your family's needs into account, and you have this need to manage your diabetes, according to you, what needs to change? We can stop hallucinating that we have all the answers for how they're going to change.
Right. They are,
yes, and I think
their choice.
It's their choice. And I think the consultation time that we have is the opportunity for these people who have busy, hectic, tough lives, doing the best they can till they walk in the door. That session is precious time where we're giving them a safe space to introspect, which in the bhagadori of life, they don't get time to introspect. We are posing well-structured questions. We are their Google map. We can see we want them to go towards better health with less medication. We can ask the question in such a way, respectfully, acknowledging their needs and struggles, where there's seemingly contradictory needs, and let them think through. And guess what?
Absolutely.
They always come up with amazing answers.
Yes,
always.
yes. And they are their own doctors. We have to place their health in their hands. Absolutely, ma'am. Absolutely. Dr. Boriska, sir, your take-home message, please.
My take-home message is very simple. Because I'm in this line for 40 years. And I have 3 generations of practice. That means people I've seen 40 years back, they are still alive and they still come to me. Their children come to me, their grandchildren come to me. So many of my students, postgraduate students, tumhara kya guru mantra hai? But the first thing, you have to create a faith. You have to make your patients develop faith in you. They develop faith in you only when they realize that this man is trying to do his best at the present moment of the state of knowledge and information that he has. It's very interesting that the medicine is an ever-changing branch. Whenever I see a prescription which I've written 20 years back, and I look at it, and I see, my God, I got away with this, yeah. How could I have written this kind of medicine? So I remember my great guru's words. You see, Anil, if your intentions are noble, and you have all the intentions good for the patient, then even if you commit a blunder, the God will take you out of that. So once patients have this faith in you, that this man will not keep a single stone turned to save me and come to my help in the middle of the night. Once he develops this faith, his family develops this faith, then the practicing medicine, which is changing, is not very difficult. So you have to create that faith, and that faith depends on your behavior.
Absolutely.
How well they trust you, and they must know that in the adverse times, he's the only man at the middle of the night you can call him and he will come in the ICU, even if it's raining. My doctor will come and help me. You create that faith.
And trust is very, very important. Absolutely.
That is what my
the
take home.
patient will be at calm and ease. Thank you. Thank you, sir. Dr. Tejal, you have a take-home message for the audience, please, before we wind up the session.
Well, one is I want to like do a big clap for Dr. Roshni because she said all that I wanted to say and more in a very well put manner, Dr. Roshni. So thank you very much. Once my friend Dr. Chitra told me this, that, you know, the power in the relationship lies with the doctor. So we have to be very careful of this power and use it responsibly. Time and again, when we're sitting in the clinic, remind ourselves that we are not here to change people and save them from themselves. It's time to let go of that traditional way of thinking. We're here to partner with people for their good health. Respect your patients, don't talk down to them. Acknowledge and validate their concerns and work with them in a manner so that you can reach good health together.
Absolutely. Work hand in hand with the patient, patiently, and taking them, guiding them step by step. Thank you. 100%. Thank you so much. Thank you. Thank you so much for to all the panelists. It was amazing. I mean, time just flew by. We completed almost more than 40 minutes here. And on behalf of IMA Dombivli, I would like to share the appreciation certificate to all the panelists. This is to Dr. Anil Boraskar, sir, a certificate of appreciation for participating in the panel discussion on myths and facts about diabetes during the online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli for medical professionals on Friday, 3rd November 2023. We have a certificate of appreciation presented to Dr. Tejal Lathia for participating in the panel discussion on myths and facts about diabetes during the online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli for medical professionals on Friday, the 3rd of November, and the certificate of appreciation to Dr. Roshni Sanghani for participating in a panel discussion on myths and facts about diabetes during the online D4 Symposium, Detect, Decode, Defeat Diabetes, organized by IMA Dombivli for medical professionals on Friday, 3rd November 2023. Thank you. Thank you very much, respected panelists. It was great to have you here. And with this, I would like to hand over to Dr. Archana Pate, madam.
So thank you, everyone. And I think it's a pleasure and a privilege to have, attended, witnessed, I would say organized, or whatever we may call it, but a symposium where people have really, really enjoyed. I mean, till the last moment, we started at 12 o'clock sharp, and it's 7 hours since we started, and we are seeing the last attendance is 140 people still in the audience. So really this symposium has been really, really well appreciated by all the attendees, and I really thank all the speakers, the panelists, for imparting such wonderful knowledge regarding diabetes to all our attendees. I'm sure people have taken home great take-home messages. To all the attendees, we would love to have some feedback from you on our mail ID. You have received mails from us from imadbl2010@gmail.com. If you have not received it in your main inbox, you may have received it in the spam, because we had sent you all the Zoom links via mail also through imadbl2010@gmail.com. So if you could give us some feedback regarding today's symposium on mail, it would be greatly appreciated. I take this opportunity to thank everybody who has been instrumental in making today's symposium a great success. I thank Dr. Vijaya Lakshmi Shinde, our president, IMA Dombivli, who had, given all the charge of the symposium on us. She gave us full reins of doing what we wanted to do with the symposium. Thank you, Dr. Shinde. My sincere thanks to Dr. Meena Pruthi for taking up the lion's share of today's workshop. She's been responsible for doing so many things about today's workshop. Sincere thanks to Dr. Gayatri Ganikar for getting us to coordinate with so many esteemed speakers. Sincere thank you to you. My sincere thanks to all the moderators for today, Dr. Hemant Patil, Dr. Makrand Ganpule, Dr. Shruti Patki, Dr. Sharad Gurav, Dr. Ashwini Acharya, Dr. Niti Upasni, Dr. Rashmi Sona, Dr. Medha Oak, Dr. Sushil Shinde, Dr. Swati Gurav, and Dr. Bhakti Lote. Sincere thank you to all the speakers and the panelists, without whom, of course, today's sessions would not have been so wonderful as they have been. Sincere thank you to all the participants, because without your participation, I do not think any program can become successful. So sincere thank you to everybody. My thank you to observer from MMC, Dr. Rajan Mane today. So with this, thank you everybody, and great having you all on the symposium. Until we meet next with equally wonderful topic next time, maybe in next 2 months time, and we will be informing everybody. We do hope you will be joining for our next informative session as well. So till then, thank you so much and have a great evening and a great weekend. And one more announcement regarding the credit points. We will not be issuing any hard copies of the MMC certificates, because right from tomorrow, I'm sure I'm going to be bombarded with the queries. When is the MMC certificate going to be issued? Please do not ask me regarding any MMC certificates. The certificates will not be issued in hard format. The certificates will not be issued at all in soft or hard format. The MMC credit points will be directly uploaded on the MMC website. You may check it in your individual MMC web page after logging into your own web page. After a month's time, it takes us almost 1 month to complete the entire process. And the credit points will not be coming as D4 Symposium. They will be reflecting in your web page as from IMA Dombivli. So please check it in your own MMC web page after a month's time. Thank you, everybody. Thank you so much. Have a great weekend. Thank you so much.
Thank you. Thank you, Dr. Archana, for the amazing session and the amazing coordinating and the idea itself of having such a symposium. Excellent work. Thank you, and thank you, everybody.
Thank you. Thank you so much.
Yes.
Yes, Medha wants to say something. Medha, your
Yes.
co-host.
Please unmute yourself.
I think I'll just make anybody wants to say anything. I'm going to now unmute everybody.
Yes, yes.
No, I just want
give
to
me a
say
minute.
thank you. That's all.
Yeah. It was lovely. It was lovely, and it was very privileged to be a part of this symposium. When we are imparting so much knowledge to so many doctors all across Maharashtra. It's great.
Yes, absolutely. Yeah. So now anybody can unmute themselves. This session is open to all. Now, if anybody wants to speak and unmute themselves. So thank you so much, everybody.
मैडम ये पॉइंट एमएमसी पॉइंट डायरेक्ट एमएमसी को जाएंगे क्या?
जी एमएमसी को जाएंगे. MMC का guidelines है sir. MMC does not require any of the associations to issue hard copies or soft copies. What MMC requires is only to upload all the credit points to the MMC web page or MMC website, and that is what we do very diligently. अगर हमने आपके पॉइंट्स अपलोड नहीं किए और हमने आपको सॉफ्ट कॉपी या हार्ड कॉपी इशू किया, फिर भी उसका कोई वैल्यू नहीं रहता है. अगर हम एज एन एसोसिएशन आपका क्रेडिट पॉइंट्स डायरेक्टली एमएमसी में अपलोड नहीं करते हैं, तो रिन्यूअल के टाइम पे आपका सिर्फ सर्टिफिकेट कुछ भी काम में नहीं आता है.
ओके, थैंक यू मैम.
या
थैंक यू मैडम, वंडरफुल सेशन.
थैंक यू सो मच मैडम, थैंक यू. So we can end this session. So please feel free to leave the session. Thank you so much.